Please take your seats. Our program will begin in 5 minutes. Please take your seats. Our program is about to begin.
At the turn of the 20th century, America was a land of limitless possibility. The skyline rose with steel and ambition, bold, daring, and unstoppable. Fueled by the American dream, small-town entrepreneurs built companies that reshaped industries and uplifted their communities. Innovation became the heartbeat of our nation. In 1912, local business leaders united with a shared purpose: to create a single voice dedicated to defending free enterprise, empowering businesses to serve people, provide solutions, and strengthen society. That voice became the U.S. Chamber of Commerce, committed to advancing economic freedom and opportunity for every American. For over a century, we've been a driving force at the crossroads of progress, shattering barriers, fueling growth, and creating opportunities for people building better lives. We don't just support business, we ignite it. From local startups to global enterprises, we create an environment where potential thrives, empowering communities, leaders, and creators to transform bold ideas into lasting impact. Working with and for a local, national, and global federation of partners, we fight for American businesses in the courts, in state capitals, in Washington, and on the world stage. Steadfast in our principles, unwavering in our resolve, uncompromising in doing what's right. This is America's story, written with vision, bound by conviction, illustrated through courage, and enriched by the hard work of everyday people, local business owners, and global visionaries who continue to define us. It's an enduring legacy of strength, determination, and shared ambition. one we proudly build upon as we work to write the next chapter of our nation's story. Join us. Together, let's build a future of growth and opportunity for the pursuit.
Good morning, everyone. I'm Lexi Branson, Vice President of Health Policy at the U.S. Chamber of Commerce, and it is my pleasure to welcome you to the 2026 Health Summit. To our members, partners, speakers, and leaders joining us from across the healthcare ecosystem, thank you for being here today. But more importantly, thank you for the work you do every day to strengthen the health of this country. We were intentional in pulling together the people in this room. People who are not just talking about the future of healthcare, but building it. Because if there's one thing that we believe at the Chamber, it's that America's health advantage is not accidental. It's built, and it's built by the people in this room. Now, we're gathering at a pivotal moment. Healthcare is no longer at the margins of economic policy. It is economic policy. It's workforce, it's competitiveness, it's affordability, it's national security. So the question today is simple. How do we strengthen and advance America's health advantage? We believe the answer starts with a simple premise. Business is not on the sidelines of healthcare. Business is the backbone of it. Employers are the largest purchasers of care and primary drivers of innovation adoption. And today's program reflects that reality, that business has a critical role to play here. Now, today also represents something bigger. The summit is also a part of the formal launch of the Chamber's Health Policy Center, built to be the leading business voice on health policy. Our work is focused on employee health, consumer health, and emerging health. Hopefully you've picked up on that by now. And if we get this right, we don't just improve a system, we improve lives. We're grateful to so many of you in this room who are already a part of this work, and none of this happens without partnership. So let me recognize the organizations who made today's summit possible. Thank you to Chobani for quite literally getting us started this morning, and also for leading on prevention and consumer health. To UPS Healthcare for showing that innovation is not just about discovery, but about delivery. And to the organizations that represent the breadth of this entire ecosystem, Pharma, Oscar Health, Zimmer Biomet, Oracle, and finally to Guidepost Strategies, Carson Consulting, and Michael Best Strategies. Thank you for your continued partnership and support, the investment in this work. To all of our sponsors, you are not just supporting this summit. You are helping build the future of American healthcare. Now, we are ready to get started this morning. We're kicking off today with the founder, owner, chair, and CEO of the yogurt brand Chobani. We're going to talk first about the consumer health advantage, because there's no better way to begin than by grounding us in the root of healthcare and how companies are leading on prevention, wellness, and access. To lead this conversation is the Chamber's own Executive Vice President, Chief Policy Officer, and Head of Strategic Advocacy, Neil Bradley. I will turn it over to Neil, but I just want to end by saying welcome. Talk to you guys soon.
Good morning. Come on, you can do better than that. Good morning.
Good morning.
We have to have a strong welcome for our first guest today because our first guest not only created America's #1 yogurt, he created the yogurt you had this morning,
Yes.
and we are deeply grateful for our partnership. I suspect this gentleman needs no introduction, but I'll give him one anyway. We're delighted to be joined by Hamdi Ulukaya, who in 2005 founded Chobani Yogurts. Chobani is one of those companies that everyone recognizes the name. You buy their products in stores, but the impact of the company goes far beyond what they market and sell. What they've done to improve health for Americans, what they've done to improve the lives of immigrants and refugees in the United States, what they've done to build local communities, restore local communities that were in decline, is going to be written about and talked about not just today, but in decades and years to come. And so when we talk about business leaders, the epitome of that is gentlemen like Hamdi.
So, thank you so much.
Thanks for joining us.
I'm so honored to be here, Neil. Thank you so much for having me. I've been part of Chamber very actively last few years, thanks to you and Suzanne and all the leadership. I am also we just came back from a mission from Turkey with our Chamber colleagues, Kush and Jennifer, Ria. I see Jennifer's here. So I'm kind of part of this place without being here before, so I'm so honored to be here.
We're going to get you a little office in here. You come by any time.
I hear different stories being in D.C., so I'd rather stay in upstate New York with the farming community.
Some days I wish I could go to upstate New York and be in the farm community rather than here. I actually want to go back 21 years. I would love for our guests today to hear a little bit about the origin story of Chobani. Why yogurt? Why the name Chobani?
Yeah.
Why did you decide to get into this field?
So my background from Turkey. I'm Kurd from northeast of Turkey, which is a Kurdish community, and I grew up in a very nomadic lifestyle. So, my wife asked me when we met first time, "What's your birthday?" I said, "I don't remember. I don't know," because the nomads were coming back from the mountains, and I was born during that time, and everybody's in our town registered in January, so I have no idea what my birthday is. She thought I was making things up, but the point is, my journey from where I was born to here, it feels like it's 1,000 years of journey from the life that I grew up with and life that I'm in here. So it's been amazing. When I left as a student from Ankara, I got into trouble. I was publishing a newspaper, and I found myself in New York City, and with it's another story for another time. I find myself in a farm in upstate New York, and milking 60 cows, doing everything that you do in a farm for a year and a half to learn English. That led me to be, very familiar with the dairy and the farming of this country, which I come from a farming background. You could be thousands of miles away from each other, but land is a land, farming is a farming, the language of farming.
Cows are cows.
Cows are cows.
Yeah.
That's where you meet, similarity. And actually, that farm really the reason I stayed in this country. If it was in New York, I don't think I could have made it. And that led me into the making cheese, and later on, I kind of came to a point there. If you are from Turkey, the first few food that you really, really look for is one of them is yogurt. It doesn't matter where you live, what kind of income you have, what kind of professionals that you're involved with. Yogurt is a staple. And we all know what to expect from yogurt. It's just the simplest thing. And it was always surprising to me that you go to a Price Chopper in upstate New York, the yogurt there that's full of sugar, it's just impossible to call them yogurt. It was more like a candy. It's like, I wonder if these Americans won't eat yogurt if it was done right. And then you would hear people would say, oh, I was in Greece and I was in Turkey. The first few words that would come out is that yogurt with the honey and the walnuts. Yeah. Like how much they loved it. So there was a disconnect between what the corporations were saying, that Americans only eat when it's very sweet, and the consumers, people's...
there was a gap in the market.
Super gap in the market. And then you'll see some of the importers that will bring in yogurt from Greece, some other countries, especially Greece. So I kind of formed an idea that if you make good yogurt, there might be some opportunity here. And then he comes with an old factory in a junk mail, and literally a junk mail. And I looked at it, it said, fully equipped yogurt plant for sale. I threw it away, picked it back up, went to the plant, and I made a TED talk on this one. And finally bought this place, hired the 4 people from that 55 employees that used to work there. This is a place that was there for 75, 80 years.
And this is in upstate New York.
It's in upstate New York. It's called South Edmiston. It took me 2 hours to find it. It's literally a tiniest community you could ever imagine. Probably 45 miles south of Utica. And there, I got an SBA loan, me and 4 employees. And in summer of 2006, we painted the walls. And in 2007, we launched Chobani. By 2012, it was $1 billion in sales. So I thought, okay, I was right. People would eat if you made a good yogurt. I guess the difference is I do not come from a business background. I never worked anywhere. I never went to business school. I had never read a business book before I started that place. So it was tiny community, me and few factory workers. We had to come up with all the ideas and capabilities and resources by ourselves. And we found out that the part is that was missing money, experience, all that kind of stuff, which is very, very valuable. But what we have is this community, these amazing ingredients, and these people who give it everything they got into this. And how do we make this a success? And while we're making it, how do we improve the life of people who work in the company, but also, most importantly, when we serve this product to everyone, how do I make it in a way that if I'm comfortably can give it to my own family, my children, before I give it to anybody else's children? So it is mind-blowing that it took 18 years for us to stay in that mindset of says, delicious, nutritious, natural, but most importantly, accessible. We made that from day one.
Accessible being a huge part of that.
100%.
Right.
And now where we are is, like last week, my team said, the Chobani has grown more than the top 12 CPG companies combined last year in volume and dollar.
Wow.
Yeah. So there is a hunger out there that people want to put better food from better brand and trusted brand into their bodies and serve their families, because food is emotional.
So this has an impact, obviously, for all those who walk into a store and pick up a carton of Chobani in terms of what they're doing for themselves and their own health. And I want to come back to that in a moment because this is our health summit. But before doing so, it has an impact. Those 4 people that you started with are now a lot of multiples of 4.
Yes.
Talk about the impact in that upstate New York community, and as you've expanded, how you think about your company's role in impacting the areas in which you operate.
Sure. I think that's where I was blown away, the impact of a business just going from this dimension to this dimension, just tiny bit of change. When we said we're not going to repeat the people who closed this factory, which was Kraft at the time, we had to adopt a different set of rules by ourselves. We're going to open up these walls to the community. The factory workers, the people, the farmers are going to be on top of the pyramid, not the other way. And we're going to be starting from our community first before we expand to the other places. The electricians and everyone who's going to work in here, we're going to build this together. And there's an enormous, deep involvement in there. But you end up saying, this is not my place, this is this community's place. It's actually everybody's house.
Yeah.
And there's a pride that comes along with it. And it's embedded in these countries, in every single towns and villages, that when you come together and you believe in the dream and you give your best to it, then you change, you evolve, you become something else. And I said, okay, we've done a few things, but my biggest thing is if there's a success, this has to be shared with everyone who's involved with it. The community has to benefit, of course, but the most important, the employees has to benefit from this. Their life has to improve through this, because we hit the bottom. People let go, steam cut off.
Devastating for some of
Devastated.
these rural communities
Yes,
that
sir.
are tiny.
Yes, sir. And literally very, I would say in a very ugly way, I'm using that word because I mean it, abandoning the community that you're in there for 75, 80 years. It's just pretty awful. So you've got to make sure that this doesn't repeat itself again. One of the few things that I said is that economically, they have to be healthy place, because health is not just health. Economic health is extremely important. Emotionally, they have to be, like satisfaction has to come. And then, of course, nutritionally and as body being healthy, how do you serve to your own people where they are building this company? How do you make sure that when you're working so hard, but you go back to your children and your family better than you come in the morning? And you spend a lot of time thinking about it. And unfortunately, you're looking at, simple things like parental leave. 90% of the manufacturings in this country, that might be number might be 5% up and down, do not offer any parental leave to their employees. When I had my own first son, I realized we don't have it either. How do you expect a mom to go back to the work after birth? And if she doesn't, in New York, you would get disability, I don't even like the word, but disability insurance. And that's only covers 75%. If you're in Idaho, they don't even offer that one. It is inhumane in a way. And what do you expect for a person to come to work right after having babies? What kind of impact is that person is going to have your work? So from that place to retirement to having a stake in the company, to last one, like we just go deeper and deeper and deeper and deeper. During the pandemic, we kind of went a little bit more crazy. And the last one was, which became one of the most popular, is that everybody who's working in the factory will have access to healthy food all day long.
Not just the yogurt.
Not just the yogurt. Yogurt was always there. Everybody would, from day one, they would get 2-3 cases of yogurt to their home every week. We offer the full kitchen, cooked it in our place to make everybody get healthy food. We've started.
Bet you saw your insurance costs come down.
We see
better employee
better
health.
employee. And then we say, okay, we give you $250, and then we made it to $500 if you do annual check every year. And we discover so many things. Like, you just gotta lean in and make sure that this becomes a habit of everybody's getting healthier when the company is getting bigger and successful.
So part of that, we started with the yogurt, and your goal was accessibility, and that's about getting onto shelves and in front of people.
Right.
For your employees, it was about getting accessibility beyond just your product, but to other healthy foods,
Yes.
access to health care and kind of support. When you look out particularly in the food space, and when you think about your own experience, what are some of the barriers to access, to making more healthy food, more accessible, more of these quality of health and life improvements more accessible?
Yeah, Neil, this is a big one. So when I started, go to yogurt aisle, you have 40% of market share one company, 35% share of one company, and then there are small other ones. And you look at, and this is ordinary grocery store in any Americans will shop. I'm not talking about the fancy ones. In there, you will look at the ingredients of yogurt as this thick. And we looked at back, just not recently, the average sugar in the 6-ounce cup was about over 40 grams of sugar in average. And that was the norm. That picture is almost in every section of the stores. You go to the frozen section, you go to the middle of the aisle, or everywhere, the packaged food, cookies or snacks and all that kind of stuff. Every single ingredient, you look at them, the size of the ingredients are this thick. And it's just as it is. And then you look at who supplies these foods to all these countries, all these places. The vast majority, I would say more than 70% of the food consumed, packaged good foods consumed in this country, controlled by a handful of companies, 12, 15, somewhere around there. So for someone like a startup to start with 4 people in a small factory and make a yogurt and say, I'm going to go after this market, not Whole Foods,
Right. You want to be in every grocery store every day.
Exactly.
Yeah.
You said, okay, If you say, I'm going to moon, I would believe in that, but this is
This seemed harder.
beyond impossible. The reason for that is you have to have factories to be able to supply. You have to have money to be able to build it. You have to have a patient, for that reason, you have to have a patient investment. Because it takes a really, really long time.
To recover, yeah.
And you really have to come up with an idea that when you are building this, you can have targeted to the larger audience, so your price point and your value proposition is really aligned with what they can afford in the very early days.
Right.
And it's almost impossible to do. So mass majority of the people who come up like me, that they start to go after certain categories to make the food better, the two things happens. One of the large food companies, and let's say you get it to the $50 to $100 million business, one of the big guys come in and says, I want to buy you. And that's been 5-10 years already. They have investors and family members. They throw money in there. The founders mostly, they're heartbroken, but at that moment, the journey cut short, and the large company buys it, and that product sleeps. It never sees to the large scale, and you still get the bad cookies, bad yogurt. The second one is, the founder said, no, I'm continuous. But when you pass that specialty process to the next level, you always, like you do big C, you don't survive. And in the result is this circle never changes, where there is an enormous amount of desire for people to want good food, but yet there's not enough food coming to the marketplace for consumers to be able to change from what they were buying to,
If I understand correctly, one of the things that you're trying to do now is help other companies navigate that through partnerships. How is that working, and do you think that's part of the future of solving some of the concerns you just raised?
Right. So here's what used to be. This is a very, very interesting time. Like, this is a health summit, Neil, and you said the health starts from what you put in your body. And Greeks said it, food is medicine, basically. And we are doing a pretty bad job what kind of food we are serving to our people in this country. It's pretty awful. I got to give you an example. I started coffee creamer. You saw it out there, and we have it. 75% of the coffee creamers are controlled by two companies. I'm not going to tell the names. And if you go grab one of the coffee creamers, and there's got the ingredients list of this, in the front it would say twice churned. Churned is a very beautiful word. That is, usually you churn butter, if you live in the farms. It's just like a very wholesome word. And then it says twice richer than milk. You say, okay, there's milk moistening, it's in there. You go into the back and you look at it. I mean, I've been here in this country for 30 years. I have a broken English. For God's sake, I have no way that I can read every single one of those things. Impossible. And then I give it to my colleagues and say, okay, it might
not just you.
Yeah, like, Neil, you read it. How are you going to read this? There is not even a drop of cream in there. Not even one drop. It's all made up stuff. 80% of the consumer consume this food believes that it's made from the cream because of what they see in the front of the material. There's an enormous amount of misleading happening in a way that we go after the tobacco companies for that kind of damage that they do in human health. This is worse than that. You could take some of those creamers, powder version, throw it in the air and put a light up, it will flame. It's in the YouTube, you can see it. We got to get really serious about how the food is made in this country by these large companies, because I would say to them, every single one of them, you go to their CEO, you say, do you serve that food that you make to your own children? Do you serve it? If the answer is yes, do you serve it every day? Then if the answer is yes, okay, you're in the right place. But the 90% of them said no. So we got to get up. Impossible to build many, many manufacturers to make better food. It's just going to be very hard. It took me 18 years to make Chobani. Yeah. But what we can do is, I am not against this new way of coming in and say, you got to take out of these ingredients out of these foods. So there has to be some kind of pressure, authority to lead these large companies that has enormous amount of assets to make the food little bit better every year, so our children can have an access to better food.
You've obviously had a market response to what you've developed, right?
Yeah.
Where do you see that kind of market demand going? Are we at an inflection point in which that's actually creating lots of opportunities for people who want to supply the type of food that you're talking about?
Anybody in this room is in the business. Anybody's out there looking at the invest in the food, invest in any type of businesses. Any members of the chamber is looking at what they have in the food dimensions. If you are in the world of making good food, which is not so difficult, it's not, it's just not. Yogurt might be a little difficult, but everything else is not. I'm just saying that so nobody comes to yogurt.
Yogurt, very hard.
It's
Everything
hard.
else, exactly.
But it's really easy. I would say if you create the ecosystem really well from the beginning and have a little bit of patience, the world of food in this country in the next 10 years is going to be one of the most exciting industry. I don't know about AI, but let's put the AI on the side. It will be the most amazing industry in this country. It's the first time in the American history, recordable, since it's been recorded, first time the total consumption of calories has gone down.
Yeah.
People don't want to eat bad stuff anymore. They want to watch what they're eating. They want to serve good food to their families. And this accelerated after pandemic.
Yes.
And I think more and more people, more and more companies, or also the companies who are in the business today, can adapt their way to what Americans want, what the people want in the future. It'll be winner. In there, we talked about, before we came here, the farmers, we need them more than ever before. Yeah. So we got to stop being disrespectful to the farmers. Let's go say thank you. You know, we got to go say thank you that you sacrifice your time, your family, your health to create this amazing food to supply to all of us all around the country, because it's not easy.
So we only have a few minutes left, but we are in Washington. This debate is not just happening around kitchen tables or in grocery store aisles. This debate about how we improve the nation's health, how we have more of these growing companies, how we have more Chobanis. We like competition at the U.S. Chamber. We'll agree that yogurt's hard, but in lots of other spaces, we want to see more of these entrepreneurs. What advice would you have to the policymakers here in our nation's capital or even in state capitals across the country?
I think, to me, before I go to the policymakers, I go to more on organizations like this that people trust, the people who, who has credential to say things that people can adopt, like people can listen to. The one is I give it to the financial world and say, you got to support good food companies and be patient. That's one message you give, which is
more patient capital.
More patient
Takes
capital
a while.
in these places. I think you go to the retailers and say, you got to serve your consumers to give more space for the companies who are making better food and put them in the front of it. Be open and honest about what you think that your consumers should eat and bring it to their family. Like just bring more of that. So we have to put the bad food in a wrong place, bad food to the place that they deserve, instead of just looking at it as a money-making type of things. And then the policymakers, and I think we don't want to, I love how this country is kind of not making so much laws to be controlling the environment of the business, but at the same time, let's just go be honest and say this ingredient, no way we're not letting this be used. We've gone really crazy on here. Europe has got better standards in these things than here. So we got to go in and say, okay, this stuff, you cannot put in this stuff, especially for children. I think one of the biggest suggestions I would make, like if I see anybody in the audience, and I would say, if you go to the rural communities, if anybody wants to invest in the rural communities, especially in the food space, there should be so much tax breaks type of things that should be given for companies and then entrepreneurs to go to these farming communities, start building these food companies. Because if you look at food plants in this country, they are old, they are broken, And you cannot have natural food made in those buildings because they're filled with so many bad bacteria and all that kind of stuff because it's been out there. So we have to start building many food factories for us to be able to make good food and new food and original food. So that means super investment has to happen as factories. Like I'm building factories every year on $1 billion. You have to start building so many factories all across the country to change the landscape of the food.
I love everything about that answer, especially because at the U.S. Chamber of Commerce, not everything is about what government can do.
Yeah.
It's about what entrepreneurs can do.
Yes.
It's about what consumers can do. It's about how markets solve problems. And you came here, you saw a market gap, you filled it, you've created an incredibly successful business, and now you are inspiring other people to do the same. And so I couldn't think of a better way to kick off our Health Summit.
Thank you.
Please join me in thanking Hamdi Ulukali for joining us and for his leadership.
Thank you.
Well, thank you guys again. As we already got kicked off, I think you're going to feel this kind of central theme throughout the day, that consumers, patients, all should be at the very center of healthcare. So a great bridge to kind of talk about what's next is how we are talking about it from not just the private sector, but also from the public sector. So joining me today is Chris Klump. Chris, you have a very long title.
The longer the title in Washington, the less important you are. That's what I've learned.
I don't know if you can say that about you,
Most
but
powerful
you are
person, POTUS,
Director of
5
Medicare,
characters.
Deputy Administrator at CMS, and the Senior Counselor to our HHS Secretary, RFK. So big job. As we were talking about before, I do want to know how you're doing this all with 4 children, but I also want to know how you're prioritizing specifically what matters for both the patient, the consumer, and how you're focusing on this from the lens of HHS and CMS.
Well, folks always say that the most important decision you make is the person you marry, and that's certainly true for me. My wife is incredible, and we have 4 young children. They go back and forth between Utah and DC, and she's holding down the fort, and we're all here bought in on this chapter of life, which is a little bit trickier, and it's gotten a little bit busy. But everybody, including my youngest, our 6-year-old, understands that this is an opportunity to serve.
Right.
And they actually believe that this is doing their part. And sometimes if dad's not around quite as much, that's part of the sacrifice. So that works out pretty well. In terms of actually balancing the role, you're right. So I've got a couple of roles. I came to DC. I'm not a DC insider. This is my first time in government. About a year ago to lead Medicare, the Center for Medicare, which is the $1.1 trillion program that serves 68 million Americans over the age of 65, providing their health insurance under the leadership of Dr. Mehmet Oz, the administrator for CMS. And then about 2 months ago, took on a role, the chief counselor role, overseeing all of the operations of Health and Human Services. So it's gotten a little bit busier. Thankfully, we built an extraordinary team. Some of them, I think, who are running Medicare day to day, and I'm parachuting in on kind of some key decisions and focusing most of my time on the department.
You have a great team. We were with many of them just last night. They've been fantastic partners and very present with the U.S. Chamber and a lot of our members. And one thing that we really appreciate about you being in this role is that you have such great experience on the private sector as well. Tell us a little bit about how that shapes your perspective when you're kind of looking at things from, let's dive in a little bit on CMS in particular, right? From your experiences, you've been building, investing in healthcare companies, those companies that are a lot like many of our members here, right? How does that shape what you're doing and building at CMS?
So I grew up in the private sector. I was at Bain & Company and Bain Capital for the first decade of my career. Did a bunch of healthcare, and then in grad school co-founded a couple of companies, one of which was in the healthcare space, and focused on that. Became a pretty large business in the health technology, health data analytics space. I remember in the early innings, we were focused on the opioid use epidemic, and specifically leveraging real-time data to identify patients who might bounce around multiple different emergency departments, always for a different reason, often with different demographics: nondescript lower lumbar back pain, acute migraine, abdominal pain, otherwise, in pursuit of narcotics, and they were struggling with this underlying addiction. And we used data to try to serialize that set of patient encounters so that even otherwise disparate emergency departments that had never worked with one another could act and behave as a single team to help the underlying challenges that this patient was facing. And the National Governors Association had asked us to come do some work with them. And in that process, we're presenting to all of these governors, and we're saying how would we accomplish the results that we had in reducing opioid use deaths. And they asked me this question. They said, well, what policy recommendations do you have for us? What policies would you change? And I was just deer in the headlights. I had absolutely no idea how to answer that question. I didn't understand policy. I only learned actually more recently that you can major in policy. That was a new insight to me. I didn't totally understand how this world works. And from my vantage point, you had a private market, and entrepreneurs see problems, and they see the world as it could be tomorrow, not as it is today. And then you go, aggregate capital, and you go aggregate talent, and you build a solution for that problem. Fast forward all of these years, when I was looking at coming on board, joining the administration to lead Medicare and going through the vetting process, I must have asked 24 different times to the vetting team, are you sure you got the right guy? Are you sure? Because I don't come from a policy background. I'm not a policy expert. I understand the business of healthcare. I understand the market of healthcare. I understand the mechanics of healthcare and how it works. I understand the games that people play. I understand the failures of the system. I understand the forgotten man and the millions of Americans who have unmet needs by this system that is otherwise the best in the world, and yet still falling short. But I didn't fully understand how the two work together. And so the last year has been a crash course. And thankfully, people smarter than me wrapped me with some of the people you're talking about on a team who are deep policy experts. And the resounding answer came back each time I asked that question in vetting about, are you sure you've got the right guy? The answer was, we've had policy experts in this seat for decades, and the system's getting worse, not better. We need people who will think about things, and this is not maligning policy experts, it's bringing them together, and this is where I'm going. We need people who will think about interesting, creative, novel solutions to the problems that persist and are getting worse. And you're gonna have 1,000 people on your team who are utterly expert in policy, and more so than you will ever be or become, and they will figure out how to translate this and drive it forward. But we need you to set a vision and a pace for how to make the change. And so that's where we're spending time.
Well, I think that's a wise place to be spending time, and surround yourself with people that are smarter than you. That's why I have such a fabulous team. But so now, if you could rewind and go back to when you were actually in the place of so many of our members, what's one thing that you would tell them from what you've learned being on the opposite side of things? Is there something that you've learned from the policy perspective and everything that you've picked up on so far, being in so deep in the policy from what you've learned both at CMS and at HHS? Is there anything that you wish that you had known that would have made it better on the healthcare side of things with being both a builder and an investor in these healthcare companies?
Yeah, several observations in no particular order, stream of consciousness. First, naively outside in, and I knew a lot of people at CMS. I've known a lot of folks across multiple administrations who are friends, by the way, both sides of the aisle, who have sat in these leadership roles, running Medicare, running CMS, folks at HHS. I continue to believe, and folks I think understand this about me, that healthcare is not and should not be a partisan set of issues, and that actually both sides of the aisle agree on plus 95% of what needs to be done. And good leadership is driving alignment on that common set of acknowledgments, understanding that we have work to do, and we don't have time to dilly-dally around. One of the things I naively thought was, oh my gosh, CMS is or Medicare, for example, is a $1.1 trillion program. We have so many resources. We can come in, we can do all the things. And it turns out that we're actually an incredibly lean team. In fact, we're one of the most efficiently administered programs in the US government. Despite being the largest program probably on the planet, we don't have infinite resources. We don't have infinite, we're a little penny wise, pound foolish actually in that regard. I wouldn't mind having a few more bodies. I think we could drive a lot more savings, a lot more improvement for the program. Part of us and leadership then is figuring out how to extend, how to be more efficient with the resources that we do have. But it's not infinite resource. So, before I came in, I probably took 500 meetings. I'm not being hyperbolic, aggregating loads of ideas. And then I worked with our team, who, by the way, had thought about all 500 of those ideas and much, much more deeply than I ever had, because our career civil servants are genuinely extraordinary individuals who are masters of this program and masters of policy, and they understand it deeply. They love their country. They love the programs. They could do anything they want with their time, and they choose to be here and serve. And we came up with our priorities. And then I get meetings all the time with folks who say, well, why haven't you fixed this? And why haven't you fixed this? And why haven't you fixed this? And it's probably the greatest frustration in my job, which is, as an entrepreneur, I want to fix problems. Like, I'm drawn to them like a moth is drawn to the flame. Like, I can't help myself, because once you've done it once, if you've built an organization, you've built something, you saw a problem that was otherwise intractable, that had persisted in the status quo, and all of a sudden you can actually build a solution, and you realize you can rally people, smart people around this, and you can improve the world, you have to keep doing it. You can't stop doing it. I suspect many of you in the audience understand exactly what that's like.
Yeah.
And so it's incredibly frustrating to look at all of the problems across healthcare, to be in a seat of positional authority in Medicare, which, as you know, is the epicenter of policy benchmark and rate setting change for US healthcare. If you want to change healthcare, you start in Medicare. Not because all Americans are age 65 and above, only 68 million of the 340 million are, although 170 million of them are getting their health care from the government between Medicare, Medicaid, and CHIP, but because what we do, 80% flows through and it moves the whole rest of the market. We all know that. So it's frustrating not to be able to do all the things all at once, but we actually have to pick our battles because we have scarce resources. The thing I wish folks understood, though, is Dr. Oz likes to say we're open for business, and we are. We take tons of meetings. We listen. We want to work with private sector. Our job is not to fix the problems. We can't fix the problems. We don't have the resources to fix the problems. We don't run healthcare. We are a payer, yes, but we work through others and intermediaries to get things done. We work through providers to serve our beneficiaries and our patients. Our job is to create the condition set, to create a level playing field. It is to empower insurgents to challenge incumbents in a level playing field, to challenge the status quo, to make the world better, to put those incumbents into the pasture or cause them to become insurgents themselves to solve the problems. Because we have two stakeholders, taxpayers and beneficiaries, no others. That's our job. What I wish everybody in the private sector knew when they came is they come and say, well, I have this amazing whiz-bang widget, you should deploy it. And I sit and think, gosh, I'd love to deploy that across all of Medicare, across all of CMS to all of our beneficiaries. That's not actually how it works. We generally don't procure directly technology on behalf of patients or on behalf of providers. The market does that. Our job is to create the conditions in which you can thrive, but you've got to actually go sell into the marketplace. You need to actually demonstrate a track record and performance and clinical data, so on and so forth. And so I think sometimes folks maybe leave frustrated thinking, well, I've got the solution, I found the Holy Grail, why aren't you buying my product? And it's like, because we're not set up to do that, but we can create the condition set for you to thrive if the market determines that your product has value. And markets generally are pretty good at doing that.
And that's kind of where the chamber comes in. We're all about creating those market-based solutions. And I really do think that there's a really good kind of moment here for us to lead in this space and work really well with you guys to make sure that the environment is stable for this.
And you're seeing us do that, by the way,
absolutely.
Right? CMMI, Abe Sutton, director of CMMI along with Jacob Schiff, putting out the access model. It's the first model coming out of us that pays for outcomes only and using a deflationary payment rate. By the way, the market reaction to that was as expected. The first chorus of voices when we put out the rates, right? We started with 4 tracks, CKM tracks, chronic kidney metabolic disease, and said, we know that if we can hit this outcome, measuring A1C or something else, we can manage it to this target level that will improve the health of our beneficiaries. By the way, that's our mission, is to unlock every beneficiary's potential so that we can unlock the full potential of our country. You can't do that if you're not healthy, so we need people to be healthy. Our job is to help our beneficiaries be as healthy as possible. But this model sits and says, if we hit this target, then we know that we're going to improve the health of our beneficiaries. And here's a price point where it's actually deflationary, where there's a clear ROI. The whole first bolus or chorus of voices on that came from incumbents who had marketing teams and PR teams and said, love the idea of access, love that idea of paying for outcomes, but man, CMS, you got it wrong. You set a rate that's just unrealistic. And then quietly in the background were the insurgents who were doing the work that insurgents do, that entrepreneurs do, sitting and thinking, I think I could hit that outcome. I'm going to have to invent some new technology. I think I could do it, and I could do it for that price point. And then they started to bubble up, and that's exactly what we want. And if you're an incumbent right now, you should be sitting very nervous on these kidney tracks, or on these CKM tracks, saying there are a whole bunch of people gunning for you. And you can become an insurgent yourself, or you can sit idly by, but we're going to destroy the old profit pool, and we're going to create a new one that's even more beneficial for our beneficiaries. Similarly, Rapid, right? FDA and CMS rolled this out last week. Dr. Oz, Commissioner McCary. Another perfect example of public-private collaboration. We've long since talked about this. You're a med device manufacturer. You go through the arduous task of FDA clearance. By the way, FDA's statutory mandate is to clear devices and drugs, AI, on the basis of safety and efficacy. CMS has a different statutory mandate. We care about reasonable and necessary. Is this the right buy? Is it the right thing on a cost-adjusted basis? We got to think about it that way. So different standards. But for a long time, you got caught in this like valley or trough of despair. You cleared the goal line. You got your FDA approval. You had a mariachi band, an ice cream cart to celebrate in your organization, only to find that you were going to wander in the wilderness for potentially decades or years before you could actually get paid. And Rapid addresses that. Rapid sits and says, we're going to create a pathway for you to come meet with CMS early so we can establish endpoints, we can establish the parameters, that you could get paid with as quickly as 60 days after an FDA approval now, that we can be talking about national coverage determinations, that we can parallel track these things. Why do we want this? We want the best technologies going to our beneficiaries. We're not going to give you a blank check that if you get an FDA clearance, then we're going to pay for it. That'd be a terrible idea, because it turns out just because something gets cleared FDA doesn't actually mean it's good for the beneficiary or it's a good use of resources. And that's our job, is to help evaluate that and help the market make those determinations. So those are two examples of things we're doing where we have to work together with the private market. We get to work together with the private market. That's where the innovation solutions come from.
And looking for stability is something that we consistently hear from our members and from our partners just throughout just day to day in the healthcare industry in particular. But I would say one thing that we're also hearing is looking for kind of predictability.
Yep.
And I know that as much as we might hear otherwise, you'll probably end up going back to Utah and wanting to hang out with your kids after this, right? So what is the Trump administration doing to make sure that come the next 2.5 years or however long we have left, that these changes are going to be predictable for the entire healthcare ecosystem, not just for the near term?
Yeah, I've often thought about that before getting into government, which is to say, gosh, it's so interesting that is a staple component of this revolutionary democratic republic that we have, that we shift leadership potentially every 4 years, which is incredible. And I love that, but as I think about it from the vantage point of our career civil servants, that could be a little bit of whiplash. And so how do you think about building in a principles-based decision-making framework with our career team so that there's long-term alignment? When we were coming on board, I remember having conversations with several administration leaders from the prior administration, and with many of them, the first question out of my mouth was, what are the most important things that you're working on right now that I need to be aware of so that we don't drop the ball? Because again, we'll have some disagreements on the margins, but reasonable people disagree, but the vast majority of what we're doing, we need to continue. Similarly, we're spending time with our career team thinking through, well, how do we improve our decision-making as a team? How do we use principle-based decision-making so that we get rid of some of the bureaucratic mire? I had one come to me this morning. There's this like classically obvious answer of something that we want with some stakeholders in the market, and we just denied their petition to do it purely on a paperwork technicality. And it's that kind of stuff we're trying to stamp out. Okay. And we're trying to root into principles to say, well, if this is good for our beneficiaries, if it's good for participants, it's aligned with our mission, it's aligned with our objectives, how do we make the decision not based on those technocratic components, but on the principles themselves, aligned with our mission of being the best payer? so that endures, that leadership, that principle, that operating structure endures long after we leave, and frankly, long after multiple administrations leave.
Right.
How do we get the flywheel spinning on enough of these initiatives so that promotes stability? How do we broadcast to the market the hard messages that require political capital so that persists, so that frankly, we provide air cover to whoever comes next to do the same thing? You just saw this with Medicare Advantage in our final rate notice. There was kind of an interesting period of time between the advance notice and the final rate notice. For those who are not spending their Friday nights reading our thousands of pages of rule sets, the advance notice is what we put out each Advantage plans, which account for 54% of our beneficiaries in the program. And then we get a lot of comments. This time we got, I think, 47,000 comments, the most CMS has ever received on a set of rules. And by the way, a comment is not like, you're terrible, or I love you. It might be 40 pages of deep data. We do actually read all of them, and we consider them, and then we finalize. And we put out a rate that was 2.48% versus an underlying effective growth rate that was about double that. In other words, we're going to reimburse about half as much as the underlying medical cost trend based on our actuaries' analysis. And we sent a loud signal, and we said the thing explicitly, which is the days of unlimited rate increases need to end, and that stops now. And it's not because we don't want to pay you, it's because we need you to come along. We need healthcare to stop growing at twice or three times the rate of GDP. We need healthcare not to grow past the 18 or 19% of GDP that it is right now as a net negative productivity sector of the economy. I have 4 children. I love them deeply. The parental commitment or promise when you have kids that you all sign up for, we all sign up for, is that we're going to leave the world better than we found it for them. And then they're going to do the same thing for the next generation. I don't think any of us in healthcare can honestly answer that question right now and say that we are. Our outcomes are extraordinary. There's nowhere in the world I'd rather receive healthcare than in the United States. But if it's the number one cause of personal bankruptcy, and it is, and it's the leading potential cause of sovereign insolvency, which it is, then something has to change. We have to do things differently, and that's where the entrepreneurial mindset comes into play.
We don't have a lot of time left. I just want to end on one quick note. What are you most excited about looking forward with the time that you have left with the administration when it comes to healthcare and what we could potentially accomplish together with the private sector?
So it's easy to think about, Dr. Oz talked about nihilism. The greatest enemy is nihilists. It's those who believe that we can't change. I'm kind of on the exact opposite end of that spectrum. I'm not sure the word no is a word that doesn't compute for me very well. It hasn't for a long time. I don't understand it. When somebody tells me no, I immediately start to think about all the ways to get to yes if and how to engineer around that no. I have a disdain for it. And I'm an optimist, and I look at healthcare right now. I look at the beautiful, brilliant minds that work in healthcare at every level, in the private sector, in the public sector, the innovators, the inventors, the operators. And I look at people's hearts, and I see good people who maybe forgot sometimes how to make good decisions, but good people who were drawn, usually for deeply personal reasons, to this sector, because there are easier ways to make money. Heaven knows that. But who were drawn to this sector out of a desire to alleviate human suffering.
Yeah.
And it's rare that I meet somebody that doesn't have that origin story. Our job is simply to remind good people why they came and to help them make good decisions. And the privilege of mine over the last year plus to observe people who consistently made decisions that were not in their own economic self-interest because they were reminded of the right thing to do gives me extraordinary hope. That's what I'm excited about. I'm excited that we're hitting an inflection point in healthcare where the challenges are plain and obvious. We can't rationalize our way out of them. They're there, they're knocking on our door. But I think Americans are best, and this is where I choose to bet on American exceptionalism, when you back us into a corner. And I think we're getting backed into a corner on healthcare right now, and that's the time where we shine. We do our best work. And I see all of the talent in this sector in that moment. And I think that this could be our greatest moment with the technology that we couldn't even fathom 5 years ago, with the political will, with the national will to do extraordinary things. And so I'm an optimist and I'm hopeful, and that's the thing I'm most excited about.
I love to hear it. I really do. And truthfully, we hear it a lot from some of the great people that are going to be speaking today. So it's great to hear it from the public sector. So thank you for the partnership, and thank you for always including the U.S. Chamber at the table. It means a lot to us, and it means a lot to the entire business community. Now, we're going to switch things up a little bit and hear directly from the actually Chief Technology Officer and Experience Officer from CVS Health, Tilak Mandadi, who is going to be joined by the Chief Digital Officer from the U.S. Chamber. Thank you,
Thanks
Chris.
very much. I appreciate it.
Hello, everybody. How are you doing?
Nobody responded.
I know. Everyone's just, what's next, right? Great to be here today. I'm here with Tilak, who is at CVS Health right now, where you run really from everything from customer experience to AI to technology. You also run their venture arm as well, so you're a very busy man. Prior to that, you were at various other industries, whether it was retail or financial services. You were at Disney. What brought you to healthcare?
It's a moment of weakness. No, I think healthcare is perhaps the most important industry at this point in the country. It's as Chris just mentioned, a lot of challenges and a lot of opportunity to get better, and it touches every person in the country. So I was excited to join healthcare.
Fantastic. It really, I think from some of our recent conversations, I think it's been, you have an interesting perspective on U.S. healthcare right now. What are your thoughts, both from all the amazing things that are going on, but also things that are concerns?
Look, I think U.S. healthcare is big, $5.1 trillion. It touches everybody. In 1970, per person, we were spending $350 for healthcare. Anybody want to take a guess what we spend today per person? $15,000.
Wow.
$15,000. So if you take the $350 from 1970s and inflation adjust it, it would be $3,000. So you're basically spending 5 times per person compared to what we used to spend in 1970s. It's just not sustainable. Chris said the same, right? It's just not sustainable for the government. It's not sustainable for those of you that are from large corporations providing healthcare insurance to your employees. Just not a sustainable thing. And with that cost increase, access actually dwindled. That's another interesting thing. The average time that you wait to see a primary care physician or a cardiologist actually went up by 22-30% just in the last 4 years. So access is getting really difficult to get, especially if you are in rural areas. Read the stat somewhere, 66% of rural communities in America don't have access to primary care. Full half of them don't have a psychiatrist practicing, which is an incredibly critical part of healthcare. So access is a problem, and not just the cost. And then the experience. For those of you that are from large companies and provide benefits to your employees, navigating healthcare for an average American is incredibly frustrating. 70% of Americans in a survey said, we don't know how to navigate it, so we just don't engage with our own health. And when you don't engage with your own health, the outcomes are going to be really poor. So those are the three real issues, cost, access, and experience, that we need to fix. On the positive side, look, we have a great, all the underlying foundation is great. We have drugs that cure diseases, and we have doctors that are great, well-trained, nurses and pharmacists that are absolutely dedicated to providing great care, but we do need to solve the other issues.
Yeah. Well, with all of those challenges you just sort of described, where can we begin to think of how to fix?
Look, there's not a very funny joke at all, so I don't expect any of you to laugh. Do you know what happens when a pharmacist, a PBM manager, pharmacy benefits manager, a doctor, an insurance person, medical insurance person, and a HR employee benefits person, and a drug manufacturer? Do you know what happens when all of them walk into a bar? Can you guess? Nobody comes out. That's what happens. And the consumer and the patient is sitting outside going, what the hell just happened? Why is nobody coming out, helping me? That's the problem in our healthcare system. We have an adversarial system. The way we set up the incentives in the healthcare system makes the integral health, the healthcare stakeholders, whether that's a PBM, pharmacy, insurance company, employer benefits person, whatever, all those people, it's an adversarial relationship. They're all fighting with each other. When I talk about cost problem, access problem, and experience problem, they all go, yeah, that person did it. I'm good. They did it. Well, that doesn't work. That system is doomed to fail. We need a healthcare system where the healthcare stakeholders are all working together collaboratively to progress to solving the problem, not finger pointing and fighting. That just simply doesn't work. But by the way, if that happens, if everybody works together, then boom, these problems are easily solvable, very easily solvable.
It's really a matter of, I think, folks being honest about where things are at right now, right?
Yep.
From your standpoint, we're sitting here in this beautiful building in Washington, D.C., thinking of solutions, what can Washington do to assist?
So one thing, I used to work in other industries, financial, media, Disney, etc. The one very interesting thing about healthcare industry is this. The type of disruptive innovation that happened in other industries, retail as an example, that originated from Silicon Valley. A small company, started in a garage, suddenly grows into this mammoth company that completely changed retail. That will not happen in healthcare. And that cannot happen in healthcare. That's just the reality of it. And here is why. Healthcare needs innovation, but because of the very nature of the industry, it needs trust. It needs familiarity. And it needs policy. So innovation, regulation, and trust And trust comes with scale and size and scope. All these three things need to come together for healthcare to be transformed. So I am willing to boldly say, sitting up here, there is not a single startup from Silicon Valley I think is going to change healthcare. It's going to be the trifecta, the combination of the three. And a very important part of that trifecta is the government. And not just because government is one of the largest payers for Medicare, Chris was here, he's talking about it, but also because some of the things that are broken, and going back to everybody is pointing fingers at everybody and fighting with each other, adversarial, government can play a very important role in addressing that, in making sure the healthcare stakeholders are all working together to solve the problem, and the government, from a policy regulatory perspective, can make that happen. An example is data sharing. I have a question for you guys. Do you know any other industry where you don't own your own data? Financial industry. You own your own data. That's your brokerage account, your financial information. Do you know any other industry other than healthcare where you buy a product and you have no idea how much it's going to cost? Until 90 days later, you get a bill and you go, "You did what to my nose?" "I came here for kidney." It's a strange industry. You don't know the cost, and you don't know if you are getting the right value for the cost. How do you know you picked the right physician, right surgeon? How do you know you are getting the right procedure for the best outcome? How do you know you are going to the right facility? You don't. You flip a coin. You talk to your neighbor. You read Google. None of those things are going to get you the right information. So the giving the consumer ownership of their data and giving the consumer trusted advice and guidance and options, both for quality and for cost, and giving them an experience that is not intimidating or overwhelming. For those of you that are in large companies and managing HR benefits, et cetera, that's the number one complaint. Actually, number two complaint. Number one complaint is premiums are too high. But number two complaint is, I don't know what's covered. I don't understand my benefits. 66% of employees in America, in a survey, said, I have no idea what my benefits are. A full 2/3 don't understand their benefits, right? So creating an experience where we give the ownership to the consumer, we put them at the center, we give them trusted advice, and we completely simplify the navigation across all the areas of healthcare that they have to deal with, and we hold their hand. We hold their hand, and we do most of the administrative homework for them. If we do that, the consumer would be inspired to engage in their own health. That leads to much better behavior change, and that leads to much better health outcomes. But it all starts with getting the experience done for the consumer.
So really from the experience perspective, one angle I thought would be interesting for us to discuss a little bit is what is always a topic at every event is AI. And thinking of the very consumer-centric model that you just described, how is AI going to change that experience, and what do you think the future of healthcare is with the use of AI?
Well, thankfully, We are past the time where every company says, I'm an AI company, their stock goes up by 10%. We are past that nonsense. We are now down to reality of what AI is, what it can do, which is a good thing. But before I address AI, let me just go back to the three issues we talked about: cost, access, and experience. AI can radically solve for each of those three issues, and I'll tell you how I think about that. However, there are some foundational things that need to change before AI can truly manifest the benefits. On the cost side, folks, the underlying root cause on why healthcare is so expensive in America is very simple. It's the unit cost of care. Unit cost of care is too high. Drugs are very expensive. Hospital stays are very expensive. Specialty surgical procedures are very expensive. Specialty medications are expensive. Specialty visitation is expensive. Unit cost of care is too high. There is no magic bullet to reducing cost. The unit cost of care needs to come down. Pharmaceutical companies need to figure out a way to lower the cost of drugs. They don't need 40% margins. They need to come down the cost, bring down the cost. Hospitals need to bring down the cost of hospital stays. Specialist therapies should not cost as much. Unit cost of care needs to come down. Everybody, as a quick way of saying, well, what about insurance companies? These are lower single-digit margin businesses. That's not where the cost is. The cost is in the unit cost. And I say that as a non-healthcare person, right? I got no horse in this race. I absolutely agree we need to reduce the administrative cost in healthcare, but that's not going to materially move the needle on cost. Once we bring what is the best way to bring the unit cost of care? Creating competition, creating full visibility and competition, right? That's the best way to do it, and give the consumer the options. AI would be fantastic in creating that competition, creating full transparency, and giving the consumer the choice. Same is the case with access. Look, there is a lot of administrative work that a doctor has to do that consumes a lot of their time. Let AI do all the back office work. There's no reason, right? And by the way, the technology is already there. AI can be a strong clinical intern. AI can do a lot of the initial triage. AI can do a lot of the research. AI can come back with potential diagnosis and drug options, etc. At the end, you want the physician, the clinician, to make the final decision. But AI can do a lot of the work that the physician is forced to do today. But let AI do that so physician can spend more of their time actually understanding and following up with the patient. So AI has a great potential in increasing access. The other thing that, as an example, we have 30,000 pharmacies. 9,000 pharmacies, 30,000 pharmacists in the country. Each of the pharmacists is clinically trained to do certain things. If we, from a policy perspective, allow the pharmacists to provide the care they are trained to provide, they're certified to provide, allow them to operate at the top of their license, we suddenly solve the provider problem in the country. We are short tens of thousands of providers in primary care in this country. We can solve that by letting the pharmacists do some of the care that they are qualified to do. These are the solutions, and with AI providing support for the pharmacists can lead to addressing the access issue, as an example. Rural health communities. And AI intent could be the first line of defense in the rural communities before they go see a physician somewhere else. So there's a lot AI can do there. Same is the case on the experience side. An AI chat interface is the future of interface, healthcare interface. People are going to walk away from this traditional app navigation stuff. That's all history. It's going to be just AI chat interface. People are going to have a conversation. And part of that conversation would be triage. Part of that conversation would be guidance and trust and so on. And AI is going to power all of that. We are, I swear to God, I'm not trying to market what we're doing, but we built all these principles into a product we are launching later this year called Health 100. It is a product that's completely open to any payer, any PBM, any pharmacy, any payer. Doesn't matter, it's for the consumer. Consumer owns that product, consumer uses that, and it can be offered as a navigation benefit to the employees. Doesn't matter who the insurance company is, who the pharmacy is, who the PBM is, doesn't matter, right? So it's not a CVS Health product, it's a separate subsidiary, and it's for the consumer. So that's the kind of innovation that puts consumer at the center and uses AI and technology to solve the cost, access, and the experience issues.
You know, I think, one, we need more time, which we're out of time. In a quick, I'll go slightly over. In a very quick response, with all the things we've been talking about, what are like a quick takeaway, a quick thing that everyone here in this room could take from this conversation and think of how they might be able to be a part of the solution?
I think it depends on who is in the audience. If you are representing a large corporation and that provides insurance to employees, I would ask you to force the healthcare stakeholders, the PBMs you're signing up with, insurance companies you are signing up with, and so on, force them to work together. It's not your job to arbitrate. Force them to work together. Offer a fully integrated navigation benefit to your employees. I would like you to offer Health 100, but offer whatever, doesn't matter. But offer a fully integrated healthcare benefit. And C, demand full transparency to how the costs are managed, right? What's involved? What are you paying for? What are you getting? Demand full transparency. I think the healthcare stakeholders should be able to provide that. And listen to your employees, right? That's very important. If you are representing drug manufacturers, you do God's work. I have incredible respect for what you do. Reduce the prices. Unit cost needs to come down. If you are running a hospital system, figure out a way to be more efficient. Reduce the unit cost of hospital stay, right? And if you are, like me, working for a healthcare company, reduce the administrative cost. These are the things we all need to work together to do, and we can solve this issue. We can make American healthcare the best in the country, best in the world, if we do this together.
Fantastic. Well, thank you so much for your time.
Thanks a lot.
Appreciate it. Good.
Thanks, everybody.
Thank you to Tilak and Mike. That was a great conversation. Really appreciated talking about what happens when you really rethink what's possible when you really put consumers at the center of the experience. And none of this innovation happens in a vacuum, right? It happens within a regulatory and legal landscape that we have noticed, just specifically talking to our members across the country, that tends to vary dramatically state to state. So now we're going to look at this from a state perspective. We are joined today by Secretary Bruce Greenstein of the Louisiana Department of Health, who is joined today by Stephen Wagasback, who's going to be very proud of me for pronouncing his name correctly. He is the president of the Chamber's Institute for Legal Reform and the senior vice president of the Chamber's State and Local Advocacy. Here we go. Welcome them to the stage.
good to have you here.
Wags, my pleasure.
Small confession, we've known each other a long time, so if we drift into old stories, just bear with us for a moment if you don't mind. But no, we're going to try to stay on business. And I'm excited to have them hear from you because I think you are such an interesting leader around the country right now at this moment. For those of you who don't know, Bruce, yes, he is the Secretary of Health in Louisiana. This is actually his second stint in doing so. He was a former secretary also under a previous governor. And he's also been in and out of the private sector in an innovation technological spot, both with Microsoft and with LHC. And he's been at the federal government at HHS in his past. And so understanding the federal side, the state side, the private market side, just a true talent sitting there hidden in Louisiana, and someone that we're privileged to talk with today. So thanks for joining us.
Thanks, my pleasure.
Okay, so let's start with, give us a little flavor. What's going on in Louisiana? As Secretary of Health, what are you focused on there? What's keeping you up at night? What's on your scorecard of what you're trying to accomplish right now in Louisiana in healthcare?
Yeah, first I have to say it's, I love when I'm not exactly right after Chris Klump because the guy is so dialed and I'm a huge fan of his. But right off the bat, what I would say is there's really two kinds of public servants, and one's not better than the other, they're just different. But one is the Chris Klump model, very impatient, and I'm in that model as well. The other ones are probably more thoughtful and deliberative, but you never know if you're going to get a better policy or you never get a policy by the time you finish the analysis. But in Louisiana, we've got something fun. I'll just tell a quick story because we have some time. I got a call on Monday from a national behavioral health organization, and they were going to put on a big webinar because they were announcing the most stressed state in the nation. It's published by WalletHub, by the way. I don't know if anybody here is from WalletHub, but I would probably make a disparaging comment because they put Louisiana as the #1 most stressed state in the nation. And you're a Louisianian as well, so this is kind of a layup.
I think we actually need more stress down there, to be honest with you. So we're a little too laid back.
Yeah, that's exactly right. We could use some stress. But so I started to think about what really, this is the tension between the economy and health at the same time. And I started to think about it. Our health outcomes are definitely not great. We're in the bottom 10 for most things. And they talk about where a per capita income is low. But then I thought about, well, what creates stress? What would lead us to that? Because I just didn't buy into it. So I started to look up some of these key features. We have a very vibrant economy. We have one of the lowest levels of unemployment in the nation. And that's one of the major stress drivers if all of the families out of work, or at least one is. We have very low uninsurance. And this is something when we worked together almost 20 years ago now, we really focused on addressing the gap in access to care to bring down the rate of uninsurance or bring up coverage. We have low cost of living, 44th lowest in the nation. And by the way, if anybody here is thinking about moving, at the end of this, always make a comment because we're in recruiting mode in the Department of Health. We can guarantee high humidity and low pay. Absolutely. And we look at some of the outcomes of these economic stressors, and even our eviction rates are among the lowest in the nation. So all these pieces put together with, there's not a measure, there should be, for what's the number of festivals per capita. We just finished Festival International last weekend.
Jazz Fest right now?
Jazz Fest right now. Crawfish Fest, Rice Fest, Rain is the frog capital of the world, by the way, and Frog Fest is coming up. So when I think about where is Louisiana at, I feel like the expansion of the economy and in the managing of problems is where we're at, and it feels like we're in a very good place. At the department, we have 3 major themes that we're focused on: improving health outcomes. We're helping people move from dependence to independence. This is really about getting jobs and using public benefits not as a crutch or not as a place, a cul-de-sac in life, but as a tool to help people reach prosperity and for us to help people do something that maybe in 3 generations, people today may come from a household where single mom, no one worked. The kids didn't see anybody put on a uniform, pack a lunch pail. We're really trying to break those. And the last thing is we call championing patients over bureaucracy. And this is about making it easier, helping all Louisianians navigate an incredibly complicated system, that with trying to take the administrative burden off of providers to make it easier to serve their patients. And in our health outcomes piece, we break that down further into two separate areas. And we talked about this last night. I need help on the marketing side. We ask people to die later, which is different. The other side is to live longer. We have a lot of health promotion programs, but we think about, we've had high opioid death rates in our state, and in the last year, we've brought that number down by 31%. We have a high burden of death in cancer rates. We've brought our cancer screenings up to in the top 10 in the nation for breast cancer, colorectal. So we're trying to help people die later. And on the area to do health promotion, the CEO of Chobani was really inspiring to me because we have a health first overall approach. In our SNAP waiver, which is the old food stamp program, it's about 20% of the state's population. We've taken out soft drinks, energy drinks, and candy. We've established the Center for Health and Nutrition, bringing all the state government assets that have been operating food programs separate from the chronic disease programs. We're bringing them together. One of our universities established a food as medicine program where you can get a degree in that, and we're also paying for outcomes in hospitals in a variety of quality measures, but one of them is also to establish food pharmacy. So we've changed the orientation of just being a passive payer and a sort of value agnostic regulator. And we've leaned in really hard, to some degree causing friction with our provider community, but we make such a big investment that we're going to demand the kind of outcomes that we want to see.
Yeah, I find it so interesting on the comparison between how you handled that question of what you're working on as compared to Chris. You know, Chris is a private sector guy, comes in and says, hey, I'm not an internal guy, I'm not a policy guy, I'm a private sector guy. You kind of have that mix of everything. And I kind of took from him, his goal is to set the right lanes, and set lanes thinking of the consumer at the end of the day. So set the lanes for that. You went right into driving certain outcomes and solutions. And so at a state level, when you're a secretary, you're getting the lanes from the feds, you got your consumers close to you because they're your neighbors, and you've also got legislators, governors, attorney generals, other folks all around you. Do you feel like you have a ton more freedom to operate within those lanes to drive outcomes, or do you feel there's restrictions there that is a challenge as a health secretary?
You know, it's funny. So I was thinking about that too when Chris was talking. We've known each other for a while, and Chris has always been in the entrepreneurial, smaller startup, more nimble. And I've been at Microsoft in the last 8 years in a big publicly traded company, and we eventually sold it to United. And when I think about the private sector, I think about the constraints. I think about if anybody is in a large corporation, we're always chasing quarterly earnings, which really distorts our ability to make big innovation, so we would just buy other companies. In being the Department of Health, we kind of have this monopolistic position, at least in state government, but we act maybe more oligopolistic in terms of our behavior. And sometimes it could be distortive. You know, if anybody has been challenged by the FTC or DOJ in this room, you know what that's like. But in other ways, it can allow you to make investments that maybe are not balanced by what the stakeholders want because of what should happen. And I think about what we've been able to do, and a lot of this is different because we get to talk, whether it's Chris from a different background than mine, or just me 15 years later, starting as Secretary of Health again. And I think I'm just,
Are you the old man on the porch who's saying how things used to be?
Get off my lawn.
Yeah, that's right.
I mean, I'm 15 years older, 15 pounds heavier. You just have a different point of view of doing it. And part of it is scale. So it's about, you establish all these goals, you hire really, really smart people. And I'm not kidding about the high humidity, low pay. We're really open for business. We brought in people from all over the country, some of the nation's most expert people in these different domains. With that type of team, it's the only way we're going to be able to tackle all these myriad problems and run 53% of the entire state's budget. It wasn't like that when we worked together. So 53% of the entire state's budget runs through this department. You need to run it like basically a big portfolio company, like the way GE was back in the past, where you have consumer products and you have aerospace and financial services. very disparate programs. On any given day, I could be signing orders that open up or close down oyster beds off the coast, and we could be doing something in payment policy for GLP-1s. We need people expert across the board.
So if I hear you right, since you're not necessarily in the guardrails business, you're in the solutions within the guardrails business because you're at that local level. Let's talk about how the private sector can engage to be helpful on that front. If you go back a decade ago, kind of what I feel like most of the discussion was, okay, there's federal teams for companies and there's state teams for companies. And those state teams are out doing their thing, making their connections, working on reimbursement rates and things like that. And the federal team was working on what's going on in DC and regulations and all that. I feel like there's a merger happening right now, and it's because what we're seeing is states are entering a policy, I don't even want to say void, but gap maybe, and being aggressive about it. And so as we talk to companies, they're like, how do we handle this? Are the states a myriad of risk? Are they a myriad of opportunity? If so, how do we engage on either one of those? And as we try to give advice on that, I'd be curious to your perspective, because I'm sure most of the meetings you get are people saying, I need this, I need that, I need this. How do you enter that door and say, Bruce, we want to be a partner for you. We want to come in with solutions and help you get those things you're trying to accomplish within the guardrails?
First of all, incredibly insightful question. I think you answered most of it in your question. It was so good. But let's, there's really two dimensions to this. This is like a bit of a Rubik's Cube. I go back into the 1990s. The U.S. Chamber was so instrumental as a voice in healthcare reform during the Clinton healthcare reform days. Helped to some degree not move forward with something that could have crippled the economy. Fast forward to today's day, we don't see enough business interaction in policymaking going on in the states. And I don't know to what degree it was last summer during HR 1, but I could just make direct observations at the state level. And so while the economy is good, there's only one kind of lobbying that we've been seeing, which is the more, more, more. So existing providers and organizations want higher pay to do the same thing. And then there are those that want to expand existing services. And then there's a third one that wants coverage for what's not being covered today. And they don't just ask for it for Medicaid, where no one in the state is directly paying for it, but this is for private health insurance as well. And as we know, Blue Cross Blue Shield Louisiana is the largest private employer, or private insurer for employers in the state. So every time there's an expansion or increase in payment rate, it's direct impact to businesses and to individuals. Getting back to your point is there's been this slow and quiet migration where the nexus of activity or the locus of analysis is happening in state capitals more so than in Washington, D.C. The D.C. piece is episodic, and it happens, and there's a predictable kind of rhythm, whether it's around, draft rule comes out for X, Y, and Z, and then everybody does comments like Chris was saying. But at the state level, it's happening, the drumbeat is more like a snare drum where it happens really fast and really compressed once a year generally. And what we see is people from their Washington, D.C. office, they fly in, somebody does a meeting, maybe drops off a check here, and they think, oh yeah, well, we did our work at the state capitol. It's not how it works. It's not credible. They'll take your money, but they don't really listen to you. You really have to have a good ground game. You have to understand the dynamics and contours of the state and the state capitol. You have to show up a lot more often. These micro-level decisions are being made not just in the legislature in a bill, but oftentimes it's pushing something out of a bill into a resolution, or at the agency level into policy, or maybe a regulation that's going to be written, or maybe it's completely under the surface and it's a contract amendment that no one ever sees, except for whoever's under contract. These are the pieces that I'd encourage all of you to really think about, and think about how your strategy lines up today with the amount of policymaking happening in state capitals today, and just look in the mirror. Are you pleased with where you're at, or could there be some improvement? And I'm sure there's a lot of assets at the chamber to be able to help organizations figure that out.
Well, if I could brag on my colleague for a second, Lexi, who is leading our health center here and is kicking off this inaugural event, she and I have been connected at the hip for that very reason, because of the state chamber network we have there. Because when people say, hey, what about this state or that state, we can give our opinion all day long, but the fact that we have a state chamber partner on the ground who understands that space and we connect them with that, it really does help navigate all that a little bit. Another piece I would maybe recommend for thought on that is maybe where the private sector can be helpful at a state level is, I'm sure a lot of times you get directives, mandates, requests from legislators who maybe see something online or whatever, and all of a sudden it goes viral and it becomes a big issue. And where the private sector can come in very quickly for a state regulator and say, hey, look, I know that's an issue. Let me give you a market-based solution for that. Let me give you another answer for that. Let me give you another way to address that same concern. Because a lot of times what happens is a viral social media post can turn into a state policy overnight, and by the time the company walks in with a solution, the cat's out the bag. And so I know a lot of companies want to be part of that thought, center on that. If you ever see a role for that, please don't hesitate to reach out for that. We got a few minutes left. I want to tap into your expertise kind of in the innovation front, if you don't mind. As you're constantly going through your daily basis, how to make the budget work, how to deal with providers and all those things, you're also a visionary on the innovation side. And I know a lot of times in DC what happens is when you talk about AI and innovation in healthcare policy, we talk the big macro, where the market's going, where's the nation going, and that's cool to dream about. But you have to worry about how innovation can change lives at the local level, change your neighbors' lives, things like that. How do you wrap your head around that? Do you have time to stop and think and prepare to how to embed that in what you're trying to do to solve outcomes in Louisiana?
That's a very, very good question. Timely as well. Let's put it into three buckets: administrative, clinical, and innovative. We'll go reverse. So across the nation, we're lucky that this administration is really leaning into the deployment of AI and keeping this nation at the forefront of AI, both technology and from a computer science perspective at the top of the list. But in state legislatures across the nation, there are many bills and regulations, policies that are being promoted that are absolutely distortive to progress in the deployment of AI. And a lot of it is to protect labor, where people can't lose jobs because of the deployment of AI, which I think is wrong. And then there's also maybe an overreach with regard to protecting, in my case, patient privacy information, so clinical data, as well as personal information, but could be financial data. So I would ask people in their companies and in their states to pay attention and listen. And I'm sure the Chamber is leaning in at the national level. It would be good to have state organizations look as well. We've seen even states that you wouldn't imagine it to come from, like Texas, I think very distortive policies. You might expect it in other states that have maybe a heavier union presence to protect on the labor side, but I'm concerned about that, and we're trying to block and tackle this legislative session in Louisiana to keep innovation afloat. On the clinical side, it's happening. Like, the idea is don't get in the way, because it's being done for the right reasons. And we're seeing sort of this escalation of war games between the provider world and the insurer world. And I'm kind of standing back watching from the cheap seats, because I like this fight that's going on, and I think it's healthy. The last part is on the administrative side. There are myriad ways for us to take costs out of the system using AI, and if you don't do it, you just either leaving money on the table or you're not the best steward of your company or government's money. Perfect example, we run several very large call centers, maybe one, for example, Medicaid. We spend $24 million a year, $8.81 per call handled by a human. Pretty good at what they do. It's a lot of looking up data. When is my eligibility up? How much do you have? Is my income this year? What's my address that you have listed? I haven't got anything from you for a while. We're moving that to an agentic AI platform. We're going to drop our cost per call handled by over 50%. We're going to let people be repurposed to do other things. We have to do work requirements under HR 1. We're going to not hire any more people, but we're going to use the savings to address what otherwise would be increased costs. There are multiple avenues to use AI to bring down your administrative costs and make that consumer experience much better than it is today.
That's interesting. So in our last few seconds, I'm going to ask what One last personal question. So you have 2 kids. I know your kids. I have 3 boys. You know my boys. My youngest is a freshman in college. He wants to go pre-med. We'll see how he does on organic chemistry to see if that sticks or not. But let's say he does well on that. He's on that track. He goes through undergrad, med school, et cetera. 10 to 12 years from now, he's maybe beginning his life in practice. Will the innovation in AI in the market make, is that an industry on the rise for a kid like that? Or is it going to be concerning in your mind for jobs and placements and things like that?
Well, I hope it's on the rise because my daughter takes the MCAT in 2 weeks.
Okay, well, there you go.
We're just a couple years ahead. I think what you're going to find, we're not producing enough doctors as it is. And we've been producing a lot of NPs and PAs that are going to work under the supervision of physicians. So docs are still going to have that position in their in the community, in society, and in their profession. And I think they'll be the leader. They'll have to know how to utilize AI, or else they'll be a country doc seeing a lot of patients, making them feel good, but not solving as many problems as they otherwise could.
That's the wrong answer. I thought you were going to save me money on med school, but you did not. So please join me in thanking one of a great state health-based leader in the country, Bruce Springsteen.
Thank you guys so much. Now we have talked about consumer health, the patient experience, and the policy landscape on both the federal and state side of things. But here's something that doesn't get enough attention in rooms like this: the infrastructure that actually gets healthcare to the patients that need it most. The most groundbreaking diagnostic doesn't matter if it can't reach the patient who needs it. Supply chains are the backbone of healthcare delivery. And our next panel, Health Innovation That Delivers, is going to dive into exactly that. I want to show you what this looks like in practice first. So let's look at the screens for a moment and let's roll the video.
You don't really know what kind of impact you have as a UPS driver.
Originally, we were 4 people at launch. We would meet the UPS driver. Everyone was so excited. UPS is here and they've got 6 boxes today.
As the company grew, at some point, there was too many to fit in my truck, so they had to put them on a semi. The growth has just been astronomical. These are kind of speechless. That makes me feel good.
Well, good morning. John, we're going to start with you. You lead a $12 billion business, and you're also a long-time expert in the pharmaceutical industry. When most of us think about UPS, we think about brown trucks and delivery, but UPS is doing so much more in the area of patient care. Will you talk a little bit about the healthcare side of the business and how you're doing so much more these days?
I'd be glad to, but before I do, thank you for this opportunity, and thanks to the Chamber for putting on such a great event. It's going to be a great day, and as many of you know, there's probably no one in the room here that hasn't met or seen their UPS driver or seen our brown package cars, but as you pointed out, we're doing so much more as a healthcare business because we've decided many years ago that giving access to patients is incredibly important to us, and partnering with companies like Abbott, Exact Science, is incredibly important. So we've built a vertical within our company to make sure that as access and as healthcare becomes more prevalent to patients in their homes, that we're creating logistics networks from transportation to warehousing to brokerage to international freight to ensure we're focused on healthcare with quality in the right way, the same quality that a pharmaceutical company, a lab, or a medical device company would require in their own organizations, to delivery, final mile in the US here, touching every single individual, making sure we create access. So for us, healthcare and access is incredibly important, and we often look at ourselves as a healthcare company that knows logistics, and that's really important to us in UPS Healthcare.
Jake, before Abbott Exact Sciences, you have a long history in healthcare too, from Quest Diagnostics to co-founding Cleveland Heart Lab, among others. What does innovation mean to Abbott? How did teaming up with Exact Sciences accelerate cancer diagnostics?
Well, again, thank you for the opportunity to be here, and I appreciate the question. Maybe I'll catch everyone up if you don't know. Exact Science, well-known, established company to help patients prevent cancer, detect it early, and guide treatment for those unfortunate people who have cancer. And we were at it for 10 years and would continue to go at it the way we are. Abbott, many of you know in healthcare, probably Abbott for its cardiovascular products, its diabetes products, but you did not know Abbott for cancer and for screening. And so I believe Abbott's #1 in the world in many things, and now through the acquisition of Exact, we will be #1 in the world in cancer diagnostics. So that acquisition was completed just a couple months ago, and it's just been a great opportunity. I now have the honor to lead a new division at Abbott called Abbott Cancer Diagnostics, and that's why we're here. Now, we're most known for this thing. I hope everyone has seen it. Hopefully many of you have used it. But Cologuard is really what we're known for. And when you think about innovation, while I'm new at Abbott, with this new division, there's two things that are certainly not new for Abbott. And that is that patience is really at the center of everything the company does. Innovation is all about what the patient can do and how we can get these tests and these tools and these devices to patient care. And I think at Abbott and at Abbott Cancer Diagnostics, we don't just think of innovation as how wonderful the tests perform or the technology that we're using. I think we don't use the word access enough next to innovation. And that's why we're here with John and UPS, because we can invent the best inventions, we can come up with the best tools that perform the best, but if we can't get them to the patients, if they can't access them, then we don't do our job. And so that's really at the core of innovation for our company.
Well, you make a great point. Abbott innovation is breakthrough in preventative care. John, let's go over to you. How has the UPS partnership ensured that the patients continue to be well served?
Great, thanks. And Jake, I think you said it well. At UPS Healthcare, we talk every day about the fact that there is a patient at the end of every supply chain that we serve. We also talk about the fact that Jake pointed out this box. This is not a package for us, this is a patient. And every package that goes through our network in our healthcare business is a patient, and that's critically important to us. Our job, working with innovators like Jake and Abbott Cancer, is to make sure that we close the gap between the innovative product and delivering it to the patient in a frictionless way to make sure they get access quickly, but also, equally importantly, ensure that we supply the opportunity for them to be compliant, take the sample that they are required to take, and then also create a frictionless mechanism for them to bring it back and get it to Abbott so that they can test the product, get the result, and then administer the care or the relief associated with the test that works in the patient's favor. So we create that network to ensure patients get the product, the kit, and then make it easy for them, as an example, to return that kit to a UPS store. And a UPS store, there's 6,000 across the US. 90% of every one of us in the US live within 5 miles of a UPS store, if you didn't know that statistic. So a patient can bring this product right back to a UPS store doing their normal daily activities, or if necessary with the UPS app, order a pickup. Your UPS driver will come to your house, pick up your package, and get it going so that we can sort it and deliver it back to Jake's facility for testing. So our goal in working with partners like Abbott Cancer is to ensure that it's frictionless for patients and the innovation that they bring can be completed final mile and through reverse logistics. So it's a privilege to be able to do that.
Well, let's talk a little bit more about the patient. The UPS partnership with Cologuard is giving you a real view into how to solve patient problems. Can you talk a little bit about patient adherence and the other aspects of care delivery, are you seeing any patient outcomes in this process?
We are. Tremendous outcomes, and maybe I'll set up the problem a little bit more, and then we'll dive into what we're doing to solve it. Today, colon cancer is still widely known as the most preventable, yet least prevented cancer. Just think about that, right? Most preventable. 9 out of 10 survive when caught early. Most preventable, but least prevented. And the only reason for that is the stigma of what you have to do to get screened. Most people think, I have to get a colonoscopy. I don't want to do that. Many people think, I'm not at risk. I don't have any signs or symptoms. I don't want to do that. So we've got to break through that stigma to be able to really stand tall and say, let's prevent this cancer that is preventable. There's 50 million people in the US today that are due for screening. Wow, that means some of you, by the way. And like you're due for screening for the most preventable cancer. Just get screened. And so what we really thought about is like, how do we go and lean into that stigma? How do we get people screened in a way that is comfortable for them, that's at home, that's non-invasive, that's private? And that's where Cologuard really comes to play. And so this massive gap in what's happening out there, we've got a solution. But the thing I want you to think about is a patient versus a consumer. The patient in their home, they don't feel like a patient. Not when they're thinking about colon cancer screening. They don't have signs and symptoms. They're actually considering themselves to be a consumer at the home. They become a patient when they go into the office. And so we have to come up with tools. We have to approach them. We have to have partnerships that make them feel like they want to consume. That means the process has to be frictionless. That means that it has to come with high trust. That's why we have commercials. That's why we have partnerships. That means it has to be really easy, and it has to feel like whatever product they just bought online the last second. We're not competing with a colonoscopy in an office with sedation. We're competing against whatever they just ordered. And when I say competing, I mean like for the ability to make this easy and seamless and frictionless. And so that's what we're really working on, and that's why this partnership is so important, because not only is Cologuard the trusted brand, people know it, but so is UPS. And so when a Cologuard kit shows up through UPS, or when it's picked up from UPS, it seems just like the product you just purchased last week, and that's exactly what we want. We want you to stay feeling like a consumer to get you screened, and we know more people get screened. So to your point, since Cologuard's been on market, we've seen a 77% increase in screening rates for colon cancer. We've seen an 11% reduction in mortality for colon cancer. Like, this is working. But you heard me say we got 50 million more people to go. And so that's really why we need to make sure that we continue to innovate and we continue to make this easy and accessible. We've had meetings on the Hill the last 2 days. I don't know, John, how you feel about this, but like we walk in and we've had people say, I've met with like a UPS and I've met with like a company like Abbott, but why are you here together? I've never had that before.
That's right. So why are we here together? Because when we talked earlier, we said with great innovation comes the need to get it to the end, to the patient, and then the reverse logistics of bringing it back. And it's the partnership that's so important, and the belief that Jake has in UPS and that we have in Jake, that we're going to do things consistently, culturally, from a quality management system perspective. So many of you that are in healthcare, and I'll talk about it in a minute, quality and compliance is important, and making sure the trust in the consumer and the patient they have in us together. So it's a great partnership, and together we're going to be able to serve patients and consumers in a very different way than we have in the past.
The last thing I'd say is adherence. Just because we get an order, just because it shows up, the innovation we're working on too is like, how do we prompt a patient to do what, again, they don't have signs or symptoms, they maybe don't have some urgency to do, and we need them to do it. We sent out 91 million text messages last year. We know that one word in a text message changes behavior. We know that if we send a text at 2 p.m. versus 6 p.m. on a Saturday or a Monday, it changes behavior. And so we're also investing in human behavior. We're really trying to change behavior of a consumer who, you know, we can also think of as a patient if they're positive, and how we get them to adhere and complete the kit that has showed up at their door.
And I think, just quickly, if I could add to that, the adherence portion of the partnership is incredibly important too. Early on in the introduction, it was stated I'd spent a lot of time in the pharmaceutical industry, and I have. Most of my career has been in pharmaceuticals, and part of the value of UPS Healthcare in my leadership is I understand the pharmaceutical and the healthcare side of the business, so I'm empathetic to what we're trying to deliver to patients and consumers. But adherence is incredibly important. So with all those text messages and all the programs that go together with ensuring patients don't just get a box, consumers don't just get a box, but they understand what they need to do and why they need to do it and how, and make it frictionless. Partnership between the things that Jake and his team are doing, and almost everybody, and I hope you all do, have the UPS app on your phone, and when you're scheduling your pickup or it's communicating with you that your package is going to arrive, we envision, and we're working on pilots right now that will allow you to get text messages to ensure adherence happens too, compliance, reminders, in partnership with our partners like Abbott Cancer Diagnostics to ensure patients see it and understand how important it is. And together that partnership creates a value and an avenue for patients to drive adherence.
Well, Jake, you said frictionless twice, and John, you said frictionless once. So let's talk a little bit about the attributes that are important to logistics. We move forward with innovation in diagnostics, what do you see as important for attributes when people think of logistics?
Yeah, so the most important ones for me, and I think they're attributes that you're all consumers and you find valuable too, whether it's healthcare logistics or logistics for other products. It's trust, and I think, Jake, you mentioned UPS is an incredibly trusted brand, much like Abbott is. Reliability. Are you going to get that package when we say you're going to get it? And I mentioned the app earlier, and you can tell when that package is coming and when it's going to arrive. And then compliance. I've talked a lot about quality. So those three attributes are incredibly important: trust, reliability, and compliance, and ensuring that when we work with partners and we work with each of you that are waiting for those packages from your UPS driver every single day, you can count on us to ensure that they're going to be there. The other thing that our healthcare business is doing in a different way is creating new products that ensure that you can enhance your trust, and the reliability takes us further. We have products that track and trace in a very different way. We're launching products with GPS on the packages. So for those most important healthcare packages, whether they're diagnostics, cell and gene samples, radiopharmaceuticals is an amazing example of a product that decays over time. So whether it's a diagnostic or a therapeutic, the longer that product is in the supply chain, the bigger the risk it becomes less efficacious. So what we are doing is tracking products real time, in some instances with GPS, to make sure we keep it on track, and if it happens to go off track, we recover it and courier it. Precision logistics partnered with precision medicines is incredibly important for UPS and our partners from a reliability perspective. And we're creating new products every day to make sure we enhance that reliability, that trust, and most importantly, the compliance that we're entrusted with every day with patients and consumers.
Well, as a stay-at-home mom, or lots of friends who are stay-at-home moms, I really am interested in this future of at-home screening and personalized care. Talk to us a little bit about what role you're playing to think through how your pipeline can play a big role in that.
Yeah, the home is, where everything is. And the more we can get care to the home and the more we can keep you well in the home, the better. We've had this breakthrough. We do millions of these a year now in the home. This was before COVID. We were in the home. And now that's been accelerated. People come to expect it in the home. And so now that we have the trust and credibility, the question is, what else can we do here? We've broken through. We've made it easy. We're communicating 91 million times. Like, what can we do now that we have for all these other potential chronic conditions, or how do we keep you well? For example, can we look at your diabetes at the home in a different way? Is there a way we can put a finger stick or something in the box that we're there for those that aren't going into the system and aren't getting screened and need to know and monitor their A1C levels? We can do these things. We're working on a test in our pipeline in our cancer diagnostics division for an at-home women's health screening test. Think about this as at-home stool. Think about an at-home swab or a tampon for a collection of women's health cancers that we can screen for, but not a lot of women are going in and screening for them as routinely as they should. We can do these things. And so I think, from my view, Maria, it's limitless, actually. When we think of the most important thing, non-invasive, we think about the most important thing, convenient, And what we're doing in our company, our research and development, we can achieve these performance levels that are on par with imaging and diagnostics in a hospital setting. That also really alleviates some of the other things you've heard from the panelists, or you'll hear today, which is we've got this backlog of colonoscopies. We've got patients that we're trying to get to complete and stay up with their screenings, and we just don't have the facilities, their infrastructure, or the time, or the resources to do it. So once we're in the home, I think it's limitless of what we can do.
That's really exciting. John, what's on the horizon as you hear Jake talk? What do you think?
Well, listening to Jake, but also listening to so many of you as well, healthcare is changing in a transformational way for patients. So you're hearing an amazing example today from Jake on the diagnostic side, but not just patients needing and requiring access in the home, but statistically, as an example, on the pharmaceutical side of the business, 65, pushing 70% of all new therapeutic products are going to require cold chain transportation. And that's very different, and we see it in the experiences that we have, and that's driving a whole different requirement from a distribution perspective. So we've enabled our network from a cold chain perspective to be able to drive that value to patients. You heard me mention earlier that precision medicines requiring precision logistics, and UPS Healthcare also has an entire division focused on white glove courier network that ensures, in the example of radiopharmaceuticals that I mentioned earlier, we are able to drive time in transit down so that the most important thing for a patient and a consumer is getting a product, whether it's a therapeutic or a diagnostic, and starting to administer care. So transition to in-home, but also a requirement for precision medicines that drive precision logistics are some of the things on the horizon that are going to be impactful to patients and are going to drive different solutions from a logistics perspective. We very recently, as an example, opened a business in Louisville, which for some of you may know, many of you may not. It is our largest air and ground hub in the US, and we have healthcare logistics and distribution buildings in Louisville at the end of the runway. So we've just opened a product in one of our buildings that allow laboratories to test inside our facilities, their laboratories, their people, but testing inside of our facilities. And why is that important? What's the value? Well, the value is when you pick up a specimen or a sample from a lab on a UPS route where a driver picks it up, it's injected into our system, it gets delivered into our hub sometime between 11:30 and 12 o'clock that night. It gets off the plane and immediately transported to the laboratory sitting in our buildings right at the end of that runway. The tests happen, and you as a patient who may have taken your sample at 3 or 4 o'clock in the afternoon are getting results at 8 or 9 o'clock the next morning. And those types of partnerships, we call that LabPort. Our big hub is called WorldPort in Louisville. We have a LabPort facility. We're getting ready to launch a second one. Those are the innovations on the logistics side that we can help partner on the innovations from the pharmaceutical and the diagnostic side to really make healthcare more accessible and impactful for patients, and hopefully drive down incidence of disease and drive up the care that we can provide in advance. So that's the value that we see in this evolving industry and this evolving future of healthcare.
Jake, I know you're thinking about innovation in Abbott. You're thinking about the next 5 years. As you have reflected in DC this week and in your work, are there things you'll scale? Are there things you think you need to scale up? Are there things that Abbott should be scaling back based on what we're seeing in the market?
Well, certainly not scaling back, no. And again, Abbott's acquisition of our company shows how committed they are to conquering these big health issues globally. I know we're talking here in the U.S. Chamber of what's happening in the United States, but we've got a big effort to expand our products globally. Cologuard is not available outside the United States. We have a test called Oncotype. We're famous for kind of two tests, Cologuard and Oncotype. Oncotype is used for early stage breast cancer patients. I didn't quite realize before I joined Exact that 80% of early stage breast cancer patients do not benefit from chemotherapy. Yet before our test came to market, everyone was getting chemotherapy. We've now spared 1.2 million women from getting chemotherapy who did not need it. And thank you. That's innovation. I mean, that's innovation, right? And to come up with the genomic signatures and do the clinical studies and do, so where we're innovating is really the science is improving. The science is improving, right? We're on the cutting edge of that. There are other companies on the cutting edge of that. The science is improving. How you innovate in your clinical trials to get patients enrolled quickly, to get a diverse patient population, to make sure that the performance is for all patients, and how you speed that up is really where the innovation needs to matter. Then you get an approval, then you got to get paid, as you've heard from other panelists. But then to me, it's all about access, right? Access. We make Cologuard available for all, right? This test is at FQHCs, federally qualified healthcare centers. It's covered by Medicaid. This isn't easy. And so I think I don't want to discount like science and technology and innovation. I don't want to discount our, research and development team. They are awesome. But in order for those to come true, the clinical trials need to pick up the pace. They need to be more innovative. We need to recruit through social media. We need to make sure that we get all patient demographics into our studies. And then we've got to get this out quickly. Sometimes that means that we actually have to go out and actually ask a consumer to pay for it first because there is no reimbursement. So we're also working on innovative ways to lower costs to the system so that we can be ahead of the curve and not wait it out for an insurance company or wait out because we know we'll get Medicare coverage eventually. Like, what does it mean to bring tests right to patients or consumers, and how do we reduce the costs so that they have access to this early? Now, sometimes you get a lot of crap for that. Well, only someone that can afford it. That's not the goal. The goal is not to hold it back and to get it out on the market to generate more evidence, to generate more outcomes so that then when you're in front of the government and you're looking for Medicare or Medicaid coverage, you've got a lot of data to do that. And so that's where we're really, really focused.
You just mentioned the government, and John, you said when you walked into some of the offices in Washington this week, they were surprised to see you together. Any questions or any information you can share with us about how public officials, policymakers are reacting to this partnership?
Yeah, from what I've seen today and what I'll probably see this afternoon, the reaction has been good because they're creating the connection in their minds now around innovation and access and creating opportunities for patients to get it quickly, to get it in a frictionless way, and to have a reverse logistics, in this case, opportunity to move fast to diagnosis. And I think that's a connection that oftentimes I'm seeing today and yesterday public officials weren't making. But that's our goal, to work together with our partners to make sure we get this product to patients. And I think that's the light bulb going off. All the innovation working together on both fronts, make sure that we move fast. And you talked, Jake, about clinical trials, and we work as a UPS healthcare business way up front in the clinical trial business too. As simple as helping our customers recruit, providing things even on the front end, whether it's iPads or wearables or the network of nurses that is externally contracted, but we can help facilitate to ensure we move quicker through clinical trials with our partners. So I think having officials hear that and understand how these partnerships work, and oftentimes people will ask me UPS Healthcare, they'll see me wearing this, well, is that the health insurance for UPS? And it's not. It's a distribution network to ensure patients and consumers get access. So the more we can talk about what we're doing in partnership with companies like Exact Science, Abbott Cancer Diagnostics, is really valuable for us.
We went into a congressperson's office today. They looked at the map and stared and said, rural, 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 right. Rural, rural. Tell me, can you say definitively that you can get these products to my constituents? And we said definitively yes, together. That's why these meetings were so great. That's why you saw these congressmen smile and say, that's what I need. I don't want to hear products that aren't accessible outside of these urban locations and these major academic medical centers. And I think that's the uniqueness. That's why they were surprised to see us together in a very heartwarming way.
That's fantastic. Well, a lot of us in this room are politicos. We watch the polls and issues that voters care about. And the number one issue that we know that will be driving people to the ballot in November is affordability. Mm-hmm. And it feels like you guys are onto something. Can you talk a little bit about cost and affordability as we move into the next cycle?
Affordability, I'll just start, and Jake, throw it over to you, but affordability is incredibly important, and building out a network and utilizing the UPS totality of our business across not just the US but the world has driven costs down for many of our partners because we're using our buildings, we're using our network, we're using our planes in different ways than we ever have to transport these products, to drive cost and improve outcomes. And together, that's really valuable.
Not all technology is created equal. Some is really good and really expensive. And so as a company, you have to balance the trade-off, right? I can get another point of sensitivity at a lot more money. That's really hard. How do you make that trade-off? Who doesn't want the best performing test? But if you put the word access and affordable, those two words, back in the equation, you need to have the best test that is highly affordable. There's new innovation and technology that has some of the best, slickest technology out there that's 3 times the cost of the current standard of care. There are people, I think even here at this meeting, that like 3 times the cost. Okay, is that really what innovation means? Innovation is not just the performance of the test. Or we're going to burden the system, we're going to prevent access, people are going to get a bill, the panelists you just saw are going to say, I can't afford this anymore, and that's going to just shut down everything we did to work so hard. So yes, that trade-off, it sounds weird, but that trade-off between performance and access, it is a very fine line. We can always have something perform better at an extremely expensive cost. That's hard, but sometimes you have to make that trade-off. That's the trade-off that we have to make, and we feel really good about how we approach it. And we say, let's get the best technology at the best price that's totally accessible, and it's kind of that trifecta that we think really makes a difference.
That's a really great point. Last question. This is a solution that I think Republicans and Democrats can agree on. Can you talk a little bit about how you're seeing your solutions work in a New York or work in a Louisiana? Very different states, rural, urban, Republican, Democrat. Can you talk just a little bit about the benefit to those patients?
Yeah, I would just say from a UPS perspective, looking across the United States, it doesn't matter what state you're in, it doesn't matter what side of the aisle you sit on, it doesn't matter whether you're a man or a woman, it matters that UPS can get a product to you. And Jake's already said it, whether you're rural, whether you're urban, we're going to get that product to you. Remember the statistic, 90% of the US population lives within 5 miles of a UPS store. So for us, it's all about creating access in a way that everyone can attain it, and we can partner in the right ways with companies like Abbott Cancer Diagnostics.
I'll say the next million patients we get screened for colon cancer are going to be harder than the last million. It's going to get harder and harder and harder. And so I think this is a great box, but it wasn't designed for an apartment building in New York City. So we have to innovate by making it smaller. I think it's great that we get orders and we send it to people's homes. Well, what if you're transient? And what if you don't have that location to go to? And so I think what we're also addressing is how can we innovate even in the box itself or even how we ship it to make sure that, again, that next million patients that are going to be a lot harder than the last million still have access to this cutting-edge technology. That's the real work to do.
Yeah.
Well, thank you for your time. This has been really interesting for all of us to hear, and excited to see what these two companies do together moving forward.
Get screened for colon cancer, please. That's my only ask today.
Absolutely.
I don't care how you do it. I have a preference, but I don't care how you do it.
Just do it.
Do it, please. Just please do it. Thank you.
Thank you.
Thank you.
Thank you.
Okay, now we're going to take a quick break for lunch. It's going to be in the room right next door. Don't go too far though, because right after we have a special announcement. Thank you guys.
Please take your seats. Our program is about to begin.
Welcome back, everybody. I hope everyone made some great connections over lunch. We're about to get started again, so please make your way to your seat if you haven't already. I promised you guys a special announcement after lunch, and I promise this won't disappoint. I am going to go ahead and announce something big, so please direct your attention to the screen and let's roll the video.
America stands at a crossroads. We, all of us, have a choice to make. Not just about healthcare, but about who we are as a nation. At the U.S. Chamber of Commerce, we know that America moves forward when innovation leads and competition thrives. America's employers, the businesses that drive scientific advancement and power innovation, have always pushed the standard beyond. For decades, they've provided healthcare to millions of Americans. Together, they've invested in better benefits, expanded access, and they've solved problems government alone never could. That leadership is America's advantage, and it's worth protecting. That's why the U.S. Chamber launched the Health Policy Center, to tell the stories of the employers delivering for workers, their families, and their communities. Because America's greatest health breakthroughs didn't come from control. They came from daring, striving, and ingenuity when free enterprise leads the way. America's employers are here to lead, to advocate for policies that empower innovation, that save lives. That is America's health advantage.
I am incredibly proud to announce the U.S. Chamber's Health Policy Center launch. This is something we've been building towards for a long time, and as you heard this morning, business is the backbone of healthcare in this country. And it's time we had a dedicated platform to match that reality. This Health Policy Center is that platform. Our mission is straightforward: to be the leading business voice in health policy, grounded in solutions, driven by data, and focused on outcomes. We're organized on 3 pillars. Have you heard me say that yet today? Employee health, consumer health, and emerging health. And in year 1, we've built something with incredible promise, thanks to my wonderful team and many of you in this room. The truth is, we are just getting started. Most of the organizations here today are already a part of this work, but if you're not yet, we want you to be. Talk to me or anybody on my team about how to get involved, because this only works if we build it together. And since we're talking about what's next, I have one more announcement. Please mark your calendars for the 2027 Health Summit. It's going to take place on April 29th, 2027, and we're coming back, and it's only going to be bigger, so plan to be here. Now, let's put this mission in action with our next conversation. It's going to be talking a little bit about what happens when you put the patient at the center of everything. We have a really great panel for this one, and it's led by a former colleague and friend of mine, Dr. Mike Ybarra, who is with Pharma. I'm going to turn it over to Dr. Mike. You can call him Dr. Ybarra if you want, but I call him Dr. Mike, who is going to introduce his fellow panelists. Thank you.
Good afternoon, everyone. How's everyone doing? Good. It's a pleasure to be with you all. My name is Mike Ybarra. I'm the Chief Medical Officer at Pharma. I'm an emergency physician by training. I see patients in the ER here locally in Washington, D.C., and we've got a fantastic panel of experts that are here to discuss the concept of patient-first innovations in care delivery, which is a great title, but there's a lot to dive in on that topic. And as everyone knows, there's so much changing as it pertains to the healthcare system. A lot of it is technology-driven, certainly from the pharmaceutical industry perspective. Incredible new treatments. We were just talking about amazing categories of treatments, things that when I was going through medical school 20 years ago were not even on the horizon. So really, really exciting stuff. But at the end of the day, my goal for this panel is to make you feel like you've been on an episode of The Pit, because I have 4 incredible doctors here, and hopefully we can talk a little bit about how partnerships are able to change the standard of care for patients. So why don't I let our panelists introduce themselves? I'll go down the line, and I'll start with you.
Great. Hi, everyone. You didn't tell us about The Pit at the in the prep session, so
I hope you watched.
Now we're going to disappoint. So my name is Robert Plenge. I'm the Chief Research Officer at Bristol Myers Squibb. I have a clinical background as well, so I trained as a clinical rheumatologist and saw patients for a number of years. And I'll weave that part of my background into the conversation as we go forward, because it's a really important part about how we think about treating patients and how we think about inventing the next generation of medicines.
Great. Dr. Lloyd.
Good morning, everybody, or afternoon, I guess it is now. I'm John Lloyd. I am the chief of the Division of Neonatology at UT Dome-Ed in Austin, but I'm here speaking for Pediatrics Medical Group, which is the largest provider of high-risk obstetrical care and high-risk neonatal care in the country. I'm still an active practicing clinician. I work mostly in a level 4 unit. So as we talk about technology, none of my 2/3 of a pound babies would survive without so much technology. There's nothing that's natural about that. So I'm pleased to be here to be part of an engaging conversation that brings all these people together. Thank you.
Excellent. Dr. Burke.
Hi, everybody. I'm Ethan Burke. I'm the Chief Medical Officer of Teladoc Health, and I lead our integrated care delivery system for the U.S. I'm a family physician and an epidemiologist. I have practiced in a large number of settings. I'm also a medical officer with on a disaster medical assistance team with the U.S. Department of Health and Human Services. And we'll talk a little bit more about what Teladoc is and the services as we go forward.
Perfect. All right, we got 4 medical specialties covered, so we could almost run a hospital.
Almost.
Which is great, but really, really good kickoff. And I think we wanted to dive in with this concept of patient-first innovation. And each of you sits within a different aspect of the healthcare system, whether it's care delivery, if it's bench, if it's bedside, if it's a Zoom virtual bedside. And so it means different things to different parts of the healthcare system. And I guess going back down the line, just open up and describe exactly how your organization is approaching the concept of patient first and sort of meeting people where they are.
Sure. So think of Teladoc Health as an integrated virtual health system, just like the health systems in the community. It's not just acute 24/7 cold and flu type visits anymore in the telehealth space. And over the last 20, 25 years, we've seen a remarkable advancement in what we're able to do in the home and in a remote setting, a virtual setting, and provide a lot more care. So beyond those acute visits, which we still do millions of per year, we're a full primary care practice. Where you get a physician or a nurse practitioner that you get to know for years. We provide chronic illness management. We provide specialty care in the moment often during your primary care visit, as well as mental health visits. So it has all of the components of an integrated system that works together. And I think when you think about patient-centeredness, we all have our own healthcare ecosystem. We each have different medical needs. We each have different social needs, financial needs. I am traveling. I can't get off of work. I don't have childcare. I don't have transportation. So how do I assemble the care that works for me? And that gets into issues of access and making sure that people stay engaged in their healthcare and follow through. And the solution for many is a hybrid combination of things that you can do virtually, things that need to be done in person, things that can be done more and more with AI. And together, all of those pieces coming together deliver your holistic healthcare experience.
That's a really great way of thinking about it, and I know we've all experienced that, whether it's making an appointment at a doctor's office, trying to get in and having to work the system into your life as opposed to the other way around. And I know when I'm working with residents, one of the most common questions or one of the most common comments that will come at me is, I don't know why this person's here. they could have gone to their primary care doctor. And that, unfortunately, what I often have to say is they're here because we're the only place they thought they could get care, and we have to be really open to that. But it's good to hear about the sort of innovations that you're driving to try to meet people where they are. Would love to bring you in because I don't know how much telehealth we can do with half-a-pound infants, and what you all are doing is truly miraculous. So how are you thinking about sort of the patient-first evolution for little babies?
We'll get to it a little bit later, but there are a few places that we can use telemedicine to try and improve the care. At time of discharge, we actually have a tele-NICU, a lower level 2 unit in a remote. It's about 90 miles from our main base, but we have nurse practitioners on the ground, and the integration of that smaller unit into a large system with clinical care guidelines and order sets and all these things, it just makes care better and allows many people to stay in their community. That's for me the key point, that we bring not just a patient, because none of my patients can advocate for themselves, it's a family into the conversation at every single level. And so to do that, we have navigators that we have philanthropy dollars to pay for. And so I'm so glad to do this in a business environment because we rely on the philanthropy to support our navigator system, to help parents and families move through a system that says you have a complicated diagnosis, you have a congenital diaphragmatic hernia, you have to meet with a surgeon, you have to meet with the GI physician, the neonatologist, all this before you deliver, then delivery and on through the system. So we have navigators to help bring the families into that process. We also engage them in all the different places where we create policy for our unit. So they sit on our clinical care guideline committee. They participate in our quality improvement process. They have 24/7 access to their baby in the unit physically. We have places for them to sleep in there with the baby. We also have cameras that allow them to, on their phone, look at their baby 24/7. With pediatrics, we have the ability to take pediatrics medical group. I wish that the whole pediatrics with the X and the C, it can get confusing because my discipline is pediatrics. The company that takes care of all these patients is Pediatrics Medical Group. We have data sets that nobody else has, and we're trying to leverage those to take the patient and improve their care and then bring it back to each family.
So important. I've got a 14-year-old daughter. I'm hoping you can teach me how to keep an eye on her too at all times. But that's really, really important. And even though the babies can't advocate for themselves, the parent experience is so critical. Quite honestly, totally life-shaping too, depending on how serious the condition is. So it's really great to hear about all the ways that you're trying to improve that experience.
Well, and it's not just the babies, but it's the mothers.
Yeah.
Really, I'm here advocating for young women who have babies and for then all the children that they produce. And so we have proven again and again that we don't see patients the way they see themselves.
Right.
And I appreciate the humility that we bring into medicine now that was different than when my father practiced. And so we are now able to ask formerly premature babies how they feel about what we call a diagnosis of a disability. Vision, hearing, movement disabilities, we have names for that. But through the research of amazing people like Suraj Segal from McMaster's, we ask questions of our patients on an ongoing basis so that we can try and tailor the system to meet their needs.
Perfect, yeah. And moving to you, Dr. Plenge, I know that in the pharmaceutical industry, obviously the products that we're making are intended for patients, but we can certainly do a better job of developing treatments if we engage patients throughout the process. So I wonder if you can just talk a little bit about how Bristol approaches this desire and goal of patient engagement.
Yeah, so I'll speak on behalf of Bristol Myers Squibb, but I think I probably speak on behalf of the pharmaceutical industry when I say that patients are our North Star.
Yeah,
so every time we think about a program in research, which is where I am, but also in development, is how do we make the lives of patients better? I'm going to actually go back 25 years to talk a little bit about my training. I promise not to go year by year for the next 25 minutes, but to go back 25 years, when I started my rheumatology clinical training, most of the waiting rooms were filled with patients who had major disabilities. They were often in wheelchairs, they needed assisted devices to get around. Because their joints were destroyed by an autoimmune condition. A class of medicines was introduced which totally changed how patients live their lives. And I realized at that time that not only patient care is important in the different ways in which we've talked about it already, but that medicines are a really important part of that. And medicines are a very unique part about changing the patient journey. So as I went through my training, I would have conversations with patients, a young woman, childbearing age, new diagnosis of lupus, and there'd be this sense of relief when I would tell her that I understood what was going on with her, and she has this diagnosis of lupus. And then I would say, we have these medicines that we could potentially offer her to treat her disease and get rid of the inflammation and make her feel better. And then at some point in the journey, she would say, well, when do I come off of these medicines? And I would have to say, never. Like, you're going to be on these immunosuppressive medicines for the rest of your life. So not only did I realize that they changed the face of rheumatology in the early 2000s, but we needed a step change for the next wave of innovation. And it was around 2013 when I joined the pharmaceutical industry. And we call it the pharmaceutical industry, but really the medicine invention industry. Right. That's what we do. We make these new medicines. So now at Bristol Myers Squibb and other companies as well, we have the potential to create these new medicines that can reset immune memory and get patients off of any of these chronic medicines altogether. So it's just an example of how 25 years ago, medicines changed the lives of patients. Where we are today, 25 years later, I think we're on the cusp of another revolution, and we're continuously trying to do that. We're trying to understand the unmet medical need. We're trying to understand science. We're trying to integrate it in the context of a business, but really delivering medicines that matter to patients.
Yeah, so impactful. And actually, as you were saying that, I'd heard similar from other rheumatologists, just what waiting rooms were like 30 years ago before biologics were available and the amount of disability. And medical students today, including myself, I graduated med school in 2008. I'm not a med student anymore, but we didn't see the end stage effects of a lot of those diseases thanks to biologics, which is really, really incredible. But one thing that I think often gets missed in policy conversations is that drug development doesn't stop at the introduction of the first medicine. So additional innovations on top of maybe the core molecule can be really important for things like patient adherence. You mentioned the patient asking you if they're going to have to be on the medicines forever. Well, you might now, but there are also different ways of administering the medicine, less frequent. There's lots of ways that you can improve on medicine delivery in addition to coming up with totally new classes. So really, really important points. That to me is an area of friction, and we want to get at the issue of pain points that exist in the system for patients. Maybe we can just go back down if you want to maybe dive in a little bit further at how you identify those pain points that patients are experiencing, the friction in the system, and how we're all trying to work to remove it.
Yeah, so one of the biggest pain points that we face is just the sheer cost and magnitude of the problem. So it takes, and probably some of you have heard these numbers, but it's worth repeating, it takes about 10 to 12 years to go from I have an idea to when a medicine gets approved. But it's not just 10 to 12 years, it's often billions of dollars. And there are different quotes about how much it is exactly, but I think a number that I tend to use is about $3 billion to invent an entirely new medicine. But what makes that so expensive is not the cost of the successes, it's the cost of the failures. So for every 10 medicines that start a clinical trial, only one, so 10%, ultimately will be successful in the course of clinical development. And for every 3 medicines that are approved, really only one is commercially successful that really leads to transformational benefit. And the number is even smaller when you ask what has changed, like as we're seeing with GLP-1s and other classes like anti-TNFs, really sort of fundamentally changed how patients are treated. So there's huge risk that we accept over a very, very long period of time. But fortunately, our industry is so passionate about the science and helping patients that people are committed to doing this. But the friction, to your original question, is just the cost and the time and the risk that we take to bring a new medicine to patients.
Yeah, definitely. So going from bench to bedside, I guess maybe bringing in Dr. Lloyd, what do you see as some of the biggest friction points for families that you're interacting with?
Well, I mean, I think pediatrics is a microcosm of the challenges that we face more broadly as a society, but they're just all compounded. If you look at the Medicaid, Medicare pay differences. There's a different way we compensate and drive value, drive innovation in the pediatric world as compared to the adult world. It's 1 in 4 of our population, but it's only about 8% of our healthcare spending. If you look at the dollars towards innovation, it's different. The potential that we have with whole genome sequencing within my world, which has clearly been shown to be cost effective for about half of the admissions. If we did it on everybody, you'd be able to talk to a family and say, this is what's going on with your baby. About half of those, you have something you can concretely do, which leads to a decrease in NICU days. And so there's a lot of data on the cost effectiveness of it. We struggle with getting it funded, getting it paid for. So a state like California has the Baby Bear program to pilot this in several of the large children's hospitals. But when you see some of the gene therapies change babies that when I was training in Chicago just died, so Wernicke-Hoffman spinal muscular atrophy, which we can now cure, basically. So this was the progressive disease here for a type 1 is at birth they're normal. They gradually begin to lose developmental stages by the 2 to 3 to 4 month range. Their mind's fine, but they get to the point where they can't breathe. And when I was in training, they died. We now have the ability to, with gene therapy, treat that disease. And when you, like someone who's done this for as long as I have, when you see that first video of someone with SMA1 running and playing with their brothers, or seeing a family where they've got 2 kids, each affected but developing normally, it will bring tears to your eyes. It's powerful. But the friction that we see, and that's not even getting to the pipeline question of the dollars that drive the innovation, drive the training of the clinicians, they're real.
Yeah, interesting. So, I mean, you kind of have time and cost of bringing new treatments to market. What I heard a lot there was sort of access, coverage, getting to the diagnosis, maybe lack of access and coverage for diagnostics in the case of whole genome sequencing. What about from your perspective? I mean, you clearly sit in a bit of a different spot with respect to telehealth. What are some of the friction points and how are you guys overcoming it?
Before I get to that, just reflecting on the comments, more and more we need to be moving to pay for outcomes, right? And process steps. The drug itself is great, but if the person doesn't take the drug, then you don't get the outcome from it. So how do we start to assign value to an endpoint? And we're starting to see really exciting models come out of Medicare and Medicare Innovation and other programs. And I think that will also help move the needle then on really focusing our energy on where we're going to see the best outcomes, the best value, the best return, and that results in more efficiency in the system, more patient access, et cetera. So you have to get the flywheel spinning, and I think we're trying to find ways to do that. And it's really, really hard. We've been trying to do that for a really long time, and I'm confident we'll get there. For us, and for me as a family physician, I've practiced for over 30 years now, is access. And when a system is so complex as ours is, and patients' need is not being met, they will find some other way to do it, which might not be the way we want them to do it. And then they go get inappropriate care, they go online and get the wrong advice, they try something that they saw on TV, they don't do anything at all, and a condition is not taken care of. That's on us because we created a system that was too complicated for them to get what they needed in a timely manner. So a lot of what we try to do, given the advantage we have of being in a virtual space where we have very high access, and now we have a broad range of capability, is how do we bring that together so we can resolve as many things as we can in that first visit resolution, knowing that people have busy lives, and any opportunity of contact with a patient is an opportunity not just to take care of that cold or do that well physical, but also address their gaps in care, address their other needs. So we have ability with our technology to see gaps in care. We're able to assess colon cancer screening gaps, even though they came to see us for something else. And we can go, by the way, while you're here, want to talk about that? Let's save you some time. And that's just really good medicine. That's what we all do in our practice. The other place where we've seen some really great success is our leveraging of specialty care. And we have the ability to bring providers together in the moment of a visit to talk about potential specialty expertise And on average, we bring that specialist into the visit in less than 30 seconds. So instead of waiting 6 weeks or 6 months to see the endocrinologist for a question about a drug change in diabetes, we're able to connect those two providers together, give the primary care provider the confidence they need to make the medication change, and that patient's medication management is handled in the moment as opposed to having to wait for weeks or months, not being treated, a lot of worry, and then the additional cost of those visits. So it's removing complexity, it's bringing the care resolution closer to that initial event, and that's a huge satisfier for the patient. It keeps them engaged and coming back, and that's how you start to get them to look at the other preventive issues that are important to their health as well.
No, I know there is a tremendous hunger for those solutions, so that's great to hear. I think you've all sort of lightly touched on it, but it is like against the law to do a panel without asking an AI question in healthcare. So I wanted to pivot to that topic and just sort of try to understand how, from, again, each of your perspectives, telehealth, clinical care, pharmaceutical, how you're integrating AI or demonstrating it, and then also thinking about it from the lens of the end user, the patient.
Yeah. So I've been thinking a lot about this. We have a very comprehensive care team, and I think it's important in the world of AI. I like in my brain to divide it into three big buckets. One, which I think is a little easier for us to get our heads around, is the much more administrative uses. It's been used in the world of fraud, waste, and abuse, and revenue cycle management, and things like that part of the business for a while. Machine learning, natural language processing approaches, and now AI to find that administrative efficiency. So let's put that one aside for a second. In the clinical space, this is where things are moving very fast and extremely exciting, and I would say maybe extremely scary at the same time, but we all see the opportunity. And how we use AI in different clinical use cases, I think, drives a lot of the questions about what's the policy, how do we manage this, how do we pay for it? So I like to think of it like a restaurant. We're all here in the front of the house of the restaurant where we're interacting with the staff, we're eating the food, I'm seeing the patient, I'm interacting with the patient. There's a back of the house side where I go back into my little pod, I look on the computer, I try to digest notes from 16 different hospitals, a chart that used to be this thick back in the paper days. I've got a minute and a half to do it, and let alone find gaps in care, duplicate medications, all of that. Separate AI into those two. They're both clinical use cases, but one is, how is an AI capability a member of the care team, like an AI companion, that is working with medical assistants and nurses or physicians or APPs. The other side is, how is the AI in the back of the clinical house, back in the kitchen, helping the provider do better, digesting records, identifying gaps, identifying potential errors in prescribing. And when you divide it that way, then I think the regulatory issues become really interesting, which maybe we'll talk about later, is how we treat it in the back and how you treat it in the front differently, because one is interacting with the person and one is just helping the system do better to take care of the person. So that's how we're thinking about it, and we're in all of those spaces in telehealth, and we are finding a lot of efficiency, and we know we'll extract more as long as we do it in a safe, responsible way. That's part of the clinical team and not deviating and against that clinical work.
Yeah, I really love that, and that speaks to my own experience working clinically. Is if you're getting a patient that's transferred to you from an outside facility, for example, they will come with about 6,000 pages of paper, and you need to distill in 15 minutes or less, what was their hospitalization like over the last 3 weeks. And that's where AI, you could take a lot of information, synthesize it down, because I often say, like, can somebody just write on a sticky note, what are the key things I need to know? So pulling that out is great. And you are literally having this experience potentially, or how are you seeing it play out in your patient population?
Yeah, so I think you described the buckets really, really well. I won't get into the RCM bucket, but our pediatrics medical group is using that to try and ensure that the people providing the care are getting appropriately then compensated for the work they've done. But but with the clinical bucket, I would add another element of communication with the family. So for the clinical guidelines development, I just want to make a plea that as we're running so fast and using so much data, that we don't forget the pediatric data. We don't want to be in a position, however many years from now, where we're trying to reverse engineer clinical care algorithms that were designed on adult data now for pediatric patients, or let alone my neonatal patients. Now, we're a small piece of the pie, and so I recognize that, but I think it's important that we have that front of mind as we go into this. The other piece of the clinical care guide, so that first actual decision-making has its own challenges in neonatology. The ability to communicate better with our families and to document more accurately what we've done is tremendous, and I think it's worth stating several times. For the diagnosis of hypoxic ischemic encephalopathy, so you're going to be born and something happens around delivery, and there's a period of time where the baby suffers a decrease in oxygen. It's unfortunately a common problem, but it is we have systems now in our EMR document that allows us to make sure we're doing the exams at the right time. It prompts you to put all the pieces in there, and has really helped standardize the documentation and then the care around a really high-risk group of patients. We're beginning to extend that into the way we communicate with the family, just very basically, but I think has tremendous potential. One of the things I hear frequently from families is Dr. A said this and Dr. B said that in the ICU. When we sit down and talk about it, a high percentage of the time, Dr. A and B were saying the same thing. They used different language that just sounded different to the family. And I think AI has the power to help us be more consistent in that communication with families, which is so important on how they experience us as a system. And then at the end of all of this, so that I can communicate with the primary care physician, a 10-month hospital stay, which we start with charts that are this big. Now we send them home at 12 months with charts that are this big. But to put it into
way more than
the more than the baby at times, for sure. But we have so much potential, or so much opportunity, to do a better job of communicating with the fractured healthcare system that we then send our babies out into, and make an advantage, and make a difference with it.
Really good point. And I think in med school you learn, you're taught by pediatricians like you, that children are not little adults, so we need to teach the AI that's the same as well. So data in is really, really critical. From a pharma perspective, you mentioned at the very outset we want to decrease sort of time to bring a medicine to market. I'm sure AI has a role to play, and I guess maybe piggybacking on, how do we make sure people sort of trust the process, since there is sort of fear and skepticism around AI in some pockets of the population?
Yeah, so I think AI is going to be truly disruptive, and I think you're going to hear that from probably all the panelists, not just here, but throughout the course of the day. I mentioned the cost, $3 billion, 10 to 12 years, very, very high failure rate. And the simple application of AI is to hopefully reduce all of those things. So reduce the cost, compress the timelines, fewer failures. And the challenge with AI is that, the challenge of making medicines is there aren't just like 3 or 4 steps. It's not like you're booking a flight, you plug it in, you get your response, and you're done. I mean, there are hundreds, if not thousands, of steps to making a medicine. And it's not just an information exchange, putting in a text and getting it back. You have to make physical things. So you're making medicines, you're testing those medicines against cells, and you're putting them into animals, and you're trying to figure out if they actually work or not. So there's only so many things you can actually compress with AI, but that's the ultimate goal, is to make things better, faster, and cheaper.
Got it. And it does sort of dovetail to the last topic that I wanted to bring up, because we're in Washington. Policy plays a role in innovation. I'm increasingly a believer that a lot of most innovation happens in the real world, so to speak. But living in Washington, we obviously have a key role to play in terms of either advancing or maybe slowing down in some cases. So would love to just sort of wrap up with the last question is, how does policy play a role in your industry's approach to improving care for patients? And maybe I can start with you.
Yeah, so I'll just start by saying we're all committed to trying to lower the cost of healthcare, and I think novel medicines can actually do that. I also think we're very committed to reducing the cost, out-of-pocket cost of patients.
Yeah.
And that's something that's very important to all of us. Most favored nation pricing, which has been introduced, is not that, in my opinion. So I believe that there's actually much greater risk to the innovation ecosystem than there is benefit overall to patients in the healthcare system. And the basic reasoning is that when you do price controls, which effectively what MFN is, you're reducing the overall amount that goes back into the system, and in our case, to make new medicines and to fund research and development, and you're taking it out of the system that takes all of the risk. So I've mentioned these numbers, $3 billion, 10 to 12 years, very high failure rates. That's the risky part of bringing a new medicine to patients. And by using MFN as a mechanism to lower prices, it's basically not rewarding the people who are doing the innovation. And I think long term, that's going to be very bad for our healthcare system.
Yeah, I agree, and obviously coming from the same industry, echo those points. I think, we saw what happened when other countries like in Europe implemented really aggressive price cuts. A lot of the R&D that used to happen in Europe now happens in the US, and so we're not going to, for example, beat China by copying Europe. And I know right now we're seeing a lot more R&D happening in China. If you followed the AACR meeting that was out in San Diego a couple of weeks ago, really incredible data coming out of Chinese biotech companies. Incredible data because they've invested a tremendous amount of capital into building that ecosystem, and so we certainly don't want things like MFN to really set us back. So I agree. Would you like to jump in with your policy thoughts?
Yeah, no, putting the dollars where the risk is. In my world, we need to put the dollars where the providers are, and the disparity between adult pay and pediatric pay for the same subspecialties is creating a pipeline challenge for us, which will be a bigger issue over time. And so I want us to see our young mothers of childbearing age and our pediatric patient population, in particular our NICU, as not a cost, but an opportunity for investment. The return on investment for the tiniest babies in my unit for potentially 8 decades or 80 years of life, but 60 productive years is tremendous. And so I think that we need to put our money where our mouth is a bit. We'd all say we love children and babies and mothers, but I think it's time for us to again put our money where our mouth is.
Very good. And Dr. Burke?
Two things. One, like I said in the very beginning, the faster we move to value, the better. Value is quality over cost, with appropriateness. I think that's always important to remember. You could do a lot of inappropriate, high-quality, low-cost things. So you don't want to do that either. But the more we have skin in the game around delivering high-quality, low-cost care, and are willing to sign up for upside and downside risk to do that, then that will force the system to really, focus on the things that matter, focus on the things that give you that ROI, focus on high quality and good patient and family outcomes. I think the opportunity is great. Care integration, like we're doing, is really helpful. Primary care is a backbone. We all say it, and I think it really, we need to double down on that as part of that risk-bearing entity as we deliver care in the community. The second piece is back on the AI piece, because you can't not talk about AI policy.
Right.
In Washington. I think there's going to be a need to figure out how we regulate it, understand it, license it from a safety and management perspective. Is it a medical device? Maybe it is, maybe it isn't. Is it more like a clinician in that world of licensure and credentialing? Thinking about the buckets the way I was laying them out, you can kind of argue that things might sit in different places depending on what the use case of AI is. There's not just going to be a single AI policy. I think that's going to take a lot of work from the people in this room and elsewhere to think about how to find that balance and what is it, because it doesn't necessarily look like a glucometer and it doesn't necessarily look like you. It's kind of somewhere in between depending on the application, and that's going to be a bit of
very, very well said. Yeah, lots to think about there. Well, we're wrapping up our time. It's been an amazing discussion having sort of such a large ecosystem represented. One final word from each of you, starting with you, Dr. Burke, from the telehealth perspective.
Well, first, thank you for a great panel. I think the more we find ways to just remove that complexity from a system and engage patients and families and communities in the process of care and make it easier for them to get what they need is a goal that I think we all strive for, and finding any modality that can do that, whether it's telehealth or intensivists or pharma, all of those pieces are critical to a fully functional and rational health system.
You're here, Dr. Lloyd.
Yeah, thank you for being here, or allowing me to be here. Really appreciate it. Our children are our future. They're going to be the people sitting up in here in these chairs in 20 and 30 years. So let's invest in it now.
Perfect. And Dr. Plenge?
Reward innovation. Medicines make a difference in all of our lives, whether us individually or to our family members and friends, and the companies like ours that take on all the risks should have appropriate financial benefit from that, while at the same time, again, continuously trying to bring down costs for the healthcare system and making sure we also bring down out-of-pocket costs for individual patients.
Yeah, absolutely. And my last word, I always tell medical students I'm working with, there are diseases today that you think you know what the outcome's going to be, but because of innovation, we can really change the trajectory. I'm so excited about what's happening in pancreatic cancer. If you read the data from AACR, we can really change the standard of care for patients. So this has been incredible. Round of applause to our panelists. Thanks so much, and have a great afternoon.
Great, thank you so much to that panel. Now, as I mentioned this morning, one of the priorities of the New Health Policy Center is protecting and strengthening the employer-sponsored coverage system. That's the mission behind PACT. It's a coalition that we are a part of that is focused on protecting Americans' coverage together. It's a coalition of business voices united in support of the workplace coverage system that 180 million Americans rely on today. And today we're doing something exciting. We are presenting the inaugural PACT Champion Award to recognize a leader who has been a true ally in this fight. To present the award, I'm bringing to the stage the Chamber's Senior Vice President for Policy, who oversees the entire policy division, which means that he's also my boss. So I'm going to welcome to the stage Marty Durbin. Please join me in welcoming Marty.
Thank you, Lexi, and good afternoon. It's an honor to present the very first PACT Champion Award, and we couldn't have chosen a better recipient for the inaugural award. As you've heard, our Protecting Americans Coverage Together coalition brings together some of the most influential voices in American business: the Chamber, the Business Roundtable, the National Association of Manufacturers, the Council for Affordable Health Coverage, and Vermeer. And we're united in a simple but critical conviction: employer-provided coverage works, and it's worth fighting for. More than 180 million Americans get their health coverage through the workplace. That's not just a statistic. That's families, workers, and communities across this country who count on the coverage their employers provide. Protecting that system isn't just good health policy, it's good economic policy. And it requires champions in Congress who understand what's at stake. Which brings me to our honoree, Representative Morgan Griffith from the Fighting 9th District of the Commonwealth of Virginia. Representative Griffith serves on the Powerful Energy and Commerce Committee and chairs its Health Subcommittee. There are no more important committees when it comes to the future of American healthcare. He is the person driving the health policy agenda in the House. So it's hard to overstate how important his role is to the future of employer-provided coverage, and Chairman Griffith gets it. It's not just numbers on a page. He understands when Washington gets health policy wrong, it's real costs that are passed on to real businesses and real workers. He's been a steady, principled voice for policies that strengthen the employer-provided coverage system that is the backbone of American healthcare. So on behalf of the members of Protecting Americans Coverage Together, it is my privilege to present the inaugural PACT Champion Award to Chairman Morgan Griffith.
Good afternoon, and if I suddenly race out, it means I got a notice on my smartwatch that we're voting and I have to get back to the Capitol. We have a few little matters we've been working on. Today it's DHS and FISA. It's a great honor, and thank you so much. The inaugural award, that's a big deal, and I really, really appreciate it, and thank you. I understand that the panel before me had somebody who was an expert on telehealth and was talking about that. I love telehealth. I actually had the first bill. The Senate stole it from me, but I had the first bill that dealt with telestroke, and we can bring down healthcare costs if we do it wisely. Telehealth doesn't solve every problem, but it's a really good tool in the toolbox for healthcare providers, providing more care at a lower cost. And as I was telling some of the folks in the back when they mentioned that, I said, yeah, CBO, Congressional Budget Office, often gets it wrong, and they'll say it costs more money. And they do all the time. Oh, that costs more money because more people are going to get health care. Now, you can factor in, as everybody says, yes, but we're going to identify problems earlier, and that's cheaper, and it's true. But you don't even have to go there. All you have to do is look at what the cost is of transporting people from their homes in a rural district like mine, which is bigger than 9 states by landmass, from their home to the healthcare provider and back. You take that cost away on every visit that's done by telehealth, and you have saved the entire system money, and it will save it will save not only the federal government money, but health insurers money, which doesn't always work that way, should reduce the cost of employer health care. All right, I got all this speech to give. Hopefully I'll give some of it and won't give too much of it. But I am committed as the health chair to continue working to find ways to help support employers and healthcare needs of our workforce. As the chairman of the Health Subcommittee on Energy and Commerce, we are all everybody on the subcommittee is looking for ways to make our healthcare system more affordable and efficient, and that's a top priority for many of us. That's why we focused on affordability this Congress thus far. We've got all kinds of other issues. I was speaking with somebody earlier today about trying to get the drug programs right because they had a situation where an anxiety medicine was given, but they didn't know the person was also on one of the opioids that helps you get off methadone, helps you get off of opioids, and they had a reaction that killed the patient because the patient's doctor didn't know that they were also taking methadone, and as a result of not having that information. So we're trying to, all kinds of things we can sort, but affordability has been the main issue thus far this year. We've had numerous hearings, insurance CEOs, the pharmaceutical supply chain, hospitals, et cetera. Coming out of these hearings, we focused on ways we can increase competition and give consumers more choices. One of the pieces of legislation we're working on is increasing hospital transparency, allowing consumers to shop for the best price and to know exactly what to expect when they receive care should empower patients to find care that is best for them, bringing more competition and hopefully lower prices. We are also looking to codify many things that the Trump administration has already done. I'm particularly interested in allowing a plan to be on the Affordable Care Act exchanges without being required by the federal government to have a network. There's a company that's been working on that, and it's a disruptor, and this will bring, if we do this, it'll bring more disruptors into the marketplace, increasing competition and giving consumers more choice rather than restricting them to only certain providers or hospitals. The House, and I underscore the House because the Senate hadn't done all this, so it hasn't passed into law, but the House has already passed great work through the Lower Healthcare Premiums for All Americans Act to help bring down healthcare costs, many of which aim to help businesses provide healthcare coverage. The bill expands access to association health plans, which allow small businesses and self-employed people to band together and purchase health insurance. For most of my career, and you may wonder, how did a country or small town lawyer end up in the health chair? It's because I love healthcare policy. But I was a solo practitioner or a small firm lawyer for most of my career. That meant that there was no way for us to have a group plan, per se, for my employees, even though I only had 3. But if all the small firm lawyers in the Roanoke Valley had been able to band together, or across the Commonwealth of Virginia, we could have done something. So I'm a big fan of having association health plans, whether it be through the bar or through the chamber or something else. It's the right way to help small businesses that aren't at a point where they can get into an ERISA plan have a way to benefit and get group purchasing power. Small businesses and self-employers, like many of you all as well, lack that bargaining power to help lower premiums. However, allowing small businesses to join together can address that. Another policy we passed codifies a 2019 Trump administration rule that allows employers to give tax advantage dollars to their employees. These arrangements would give employers another avenue, another tool, to help employees with health coverage by letting them determine contribution amounts and allowing employees to choose the coverage they prefer. Yet another flexibility in the bill exempted stop-loss insurance from the definition of, quote, health insurance coverage, end quote. As many of you know, stop-loss coverage is a type of coverage an employer can purchase to protect them from unexpected catastrophic health claims if that employer has chosen to self-insure their employees' health care. I always think of it in terms of Lloyd's of London or Chubb, two insurance companies that do a lot of this kind of work. This allows an employer to limit the financial risk imposed on them if an employee or a few of them have unusually high medical claims that exceed the employer's budgeted amount. Some states have attempted to regulate these plans, which makes the self-insurance option less viable. This bill clarifies that this coverage is exempted from the definition of, quote, health insurance coverage, unquote, meaning states would be limited in how they could regulate stop-loss coverage while maintaining the ERISA option. Another policy in the bill we also worked on in the House version of reconciliation last summer would lower ACA plan premiums by roughly 11%. Now, the Senate didn't approve this, but what we would do, and it could lower it by as much as 11%, by appropriating dollars for cost-sharing reductions. Now, I heard in the introduction that, I know that if we get it wrong, it can cost a lot of money. Well, this is one I got wrong. I thought when in the Obama administration, they had created in Obamacare this cost-sharing reduction plan. And it was only supposed to last, I forget now whether it was 2 or 3 years. Well, they continued funding it through other funds, as executive branches will do from time to time, and I was all outraged. How can they do that? They don't have authority of Congress. So we finally got rid of it, only to discover that that encouraged the insurance companies to do what's called silver loading. They pushed everybody off the bronze plans into silver plans, making the cost of health care go up, which is why you had the tax credit issue that came up as well. Our plan was we would restore the cost-sharing reductions. It saved billions of dollars because it gave people a better chance to shift off of Medicaid or Medicaid expansion onto a bronze plan, because there was you didn't go from having a situation, and this happened to one of my employers. They offered in a medium-sized grocery chain in my district, more than 100 stores. If that's medium or large, I'm not sure. Y'all would have to decide that. They offered this employee an opportunity to move up into lower management. And the employee came back after a month and said, can't do it. It killed me on insurance premiums because I moved off of Medicaid expansion in Virginia into a plan I couldn't afford. So what the plan with cost-sharing reductions does, it disincentivizes insurance companies to push people to the silver plan, and it incentivizes people who are working but are on the Medicaid expansion program to move off of Medicaid expansion at a cost to the federal government of 90% of the cost in the Commonwealth of Virginia. It's a little more, it's actually more than that because of the games they play, but on paper it's 90%. From 90% of being paid for by the federal government, it moves them into buying health insurance in the exchanges on the bronze level, which is acceptable, except they can't afford it if they're just moving off of Medicaid expansion. So this would be helpful because we would give them that cost-sharing reduction. So that was one that I thought was bad policy 8, 9 years ago that time proved I was wrong. And that's something that Congress often does not do, in all fairness, is that people lock into a position and they don't think they can ever change their minds. You bring me the facts, I'll tell you. I was a state legislator before I became a federal legislator. I've made plenty of mistakes. And the way you can be a good legislator is to go, okay, I thought that was going to work. It didn't work. Let's try something different. Let's go back to something that did work, in this case, the cost-sharing reduction plan, or let's try something new. And we have to do that. And too many of my colleagues on both sides of the aisle, I'm not picking on anybody in particular, They lock in and they think, wait a minute, this was a plan that I invested in. I can't change my mind now. No, if you bring me evidence that what we did didn't work, I will work with you to get it right, because we make decisions. If we get it wrong, it costs money. If we've gotten it wrong, let's not double down. Let's figure out how to get it right. And so that's one of the things that I'm committed to. And then this one we did get, House and Senate, the biggest PBM reform and transparency package in the history of the United States, signed into law just a few months ago. I can't remember now if it was January or February, so we'll just say a few months ago. I'm excited about it. It doesn't mean it's the end of the line. Doesn't mean we don't need to do more in regard to making sure, and PBMs have a place, but if you create the rules, and this is part of being a lawyer, I understand this. If you create the rules and the company takes advantage of those rules, you got to change the rules. That doesn't mean the company in and of itself is evil. It just means they use the rules you created to make money. But when it's causing costs of healthcare, and particularly pharmaceuticals, to go up, it's my job as a health chair to try to sort that out and get new policies that will not allow those companies to make costs go up. And I do believe in many cases, PBMs will accidentally raise costs. And I had a bill a couple of years ago. I don't know how much time they gave me. I'm probably over it already. But I had a bill a couple of years ago I thought made common sense. And it was just this simple. If the insurance company, through its PBM, pays $10 for a medication, when the employee or the insured comes to the pharmacist, they can't charge more than the $10, even if their copay says $30, because it's not fair to make an extra profit when you've been able to squeeze down the price of that medication. That's not right. I mean, I see the insurance company in that case being, and the PBM, they're supposed to be looking out for the interest of the patient. I don't mind them making money. It's America. They should make money. But they shouldn't do it when they've gotten an advantage on a medication that somebody needs, particularly a lot of these medications are things they need to stay alive. You shouldn't charge more than a greater cost share or a greater copay than what you actually paid for the medication. That said, we're just going to keep working. We're going to try to make sure that we get it right. And when we don't get it right, I need your help. Oh, it's got right there how much time I got. I'm out. When we don't get it right, don't fuss at us too bad, but do tell us about it. Because, you know, nobody likes to get fussed at too much. A little bit's okay. But we need your input as people on the front lines, people paying for insurance, people paying for their ERISA plans or paying for their employees. We need your input on what you think we might be able to do to make the system better, not just for your employees, but for all the employees across this great land. God bless you all. Thank you all for being here today. Thank you for letting me be here with you. And thank you so much for this inaugural award. It means a lot to me. Thank you.
Good afternoon, everyone. It's nice to see you. I know you're post-lunch. First of all, I'm really pleased that I am not the first person to say women's health in this room today. We've already had it mentioned a couple of times. I'm Katie Schubert. I'm president and CEO of the Society for Women's Health Research, and we are a nonprofit founded in 1990 to advocate for the inclusion of women in clinical trials and to make sure that researchers are studying the differences between men and women. We sit at the intersection of science, policy, and advocacy, sort of snug inside that larger healthcare system that all of us depend on so much. And before I bring out someone who needs very little introduction but deserves a pretty amazing one, I want to just take a couple of minutes to talk about something that's at the center of why we're all here. That's supporting our workforce. We're ensuring that we're all living better, longer, and well, and to continue to position America as leaders in the world. And we believe that the key to this is women. Women as employees, we make up about half of the workforce. Women as caregivers, we're 2/3 of unpaid caregivers for our families, and we often serve as the chief medical officer for our families, making 80% of healthcare decisions across the country. And yet, for decades, the medical research that underpins our entire healthcare system was conducted predominantly on men and just extrapolated out to women. It was thought that women are little men and it's not a big deal, we'll figure it out and everyone will be fine. And I think we all know that that's not necessarily true. We are very different from each other. It wasn't until 1990 that women were required to be included in clinical research, and it wasn't until just 10 years ago that researchers had to even consider sex differences in research at the very basic level. So what the result of this is a women's health gap, but it's a knowledge gap that actually hurts all of us. It hurts men and women. And so just a few examples for you. Our maternal mortality rates in this country are rising. 70% of all women suffer from uterine fibroids, which can interrupt work and life. It takes an average of 3.6 years to diagnose, and it impacts fertility in some cases. 10% of women have endometriosis, which is a debilitating condition for which the only way to actually diagnose it is invasive surgery, and there's no true treatment and no cure for it. And that's about the same proportion of women who have diabetes. There's definitely a gap there in terms of knowledge and research. 2/3 of Alzheimer's disease patients are women, and we are, though, finally finding out through research that the symptoms of that are showing up 20 years ahead of when you initially think. And guess what that puts us at? Midlife. That's when people are in the height of their careers. So what does this look like in economic terms? Deloitte found that women with employer-sponsored coverage incur about $15.4 billion more in out-of-pocket costs than men. And before you say, hold on, what about prenatal care? This is adjusting for that. So that's without having maternity care involved. Our own research found that women were making the decision to leave the workforce or to not pursue leadership opportunities due to menopause symptoms. And McKinsey research found that overall women spend 25% of their lives in poorer health than men. The healthcare gap costs the world an estimated $1.8 trillion annually. That's in lost economic productivity. It's not just in healthcare spending, it's in absenteeism, reduced workforce participation, and untreated conditions that progress because they weren't properly studied, much less diagnosed and treated. And as a nonprofit CEO, basically running a small business, I'm a mom of 3. I'm concerned about my sons and their futures. I'm also concerned about my teenage daughter who has a lot of healthcare questions that just honestly I can't answer, and her doctors aren't able to answer it either. But there is hope. Right now, we are living in a historic moment. The business community is not, nor should it be, a passive stakeholder in the work to close this health gap. The return on investment in women's health is just too big to ignore, from maternal health to autoimmune to menopause and all of the other issues I've already mentioned. Even in heart disease, which, by the way, is still the #1 killer of men and women, all of us are in this together. So it's going to take us together, working together to close the women's health gap and to keep all of us healthier and to future-proof America's healthcare ecosystem. There's many ways that this can be done, but I know that in the collective wisdom of everyone in this room, you all know this too, data moves policy and people move everything else. For all the white papers and legislative briefings and economic analyses, nothing changes hearts and minds like a voice that meets people where they are. A voice that's honest about the gaps in the healthcare system, compassionate about the people those gaps hurt, and loud enough that you cannot look away. And that is who you are about to hear from. Dr. Jacqueline Walters, or Dr. Jackie as you may know her, is a board-certified OBGYN, a patient advocate, and one of the most recognized faces in women's health in America. She built her career at the intersection of clinical excellence and fierce patient advocacy, treating women across communities that have too often been underserved by a healthcare system that just wasn't built with them in mind. And through her platform on Bravo's Married to Medicine, she's done something that no policy brief has ever managed to do. She's brought women's health into living rooms across the country, making conversations about all of the things that I mentioned, fibroids, fertility, menopause, and mental health, feel urgent, relatable, and real for millions of women who needed to see themselves reflected in those discussions. So in a room full of people who shape healthcare policy, employer benefit strategy, and health system innovation, Dr. Jackie is bringing the perspective that really should be at the center of it all, the patient. So please join me in welcoming to the stage Dr. Jackie.
Good afternoon. Thank you much, Katie. To the physicians, the providers, healthcare leaders, insurance executives, policymakers, who else? Everybody, pharmaceutical leaders, everybody in the room, I want to say thank you, and I'm honored to be here. Now, I want to do a little bit of housekeeping and qualifying before I get started, because I'm sure you heard it, that I am Dr. Jacqueline Walters, board-certified OBGYN, practice all day, stay up all night. But you also have Dr. Jackie. Dr. Jackie is from reality TV. So if you happen to hear a little drama today, you got to remember I'm from reality TV. So, blame it on her. Now, when I finish, I hope that I can end this talk making everybody aware that we should see our physicians and our female providers and all providers differently. We should see burnout differently, not as a personal failure, but as a sign that the healthcare system may be imbalanced, and with this ecosystem in the room, we're all responsible for realigning it. We also have to understand that the benefit of being a healthcare provider is making sure we take care of our patients. So if we realign the system, we're doing exactly what we want to do, is take care of patients. And when I look around the room and I heard about everybody's in the room, I'm like, well, this room doesn't just talk about healthcare. This room helps to decide exactly what healthcare becomes. So I want to start with the question, what happens to the people we have entrusted to hold our healthcare system together are struggling to hold themselves together? I want you to think about that. What happens to the people we have entrusted to hold our healthcare system together are struggling to hold themselves together? Ladies and gentlemen, we are in a crisis. Today, we are in a healthcare workforce crisis. This is no longer theoretical. We're losing doctors and nurses and healthcare providers at an alarming rate, faster than we can replace them, and definitely not as fast as the system is still asking for them. This is not just a staffing issue. We often say everything's about staffing. This is a patient access issue. This is a quality issue, and it is a direct threat to the long-term stability of our healthcare. We're living where healthcare providers are not just burning out quietly. I can say for myself, I've been practicing 29 years, and you kind of talk about it, but we do it quietly. We're in a time now where the providers are telling it out loud. If you look at social media, and I'm want to look at social media. Hopefully everybody in the room is using it a little bit. We're living in a time where the providers don't leave at the end of their career. Some of them are leaving at the beginning of their career. We had social media, I hope everybody saw, where this one physician was very loud about it, very open about it. He had practiced, or he had worked 15 years, 4 years of undergrad, 4 years of medical school, and 5-6 years of training. He became an orthopedic spine surgeon, and within 6 months, he left. He decided he would become a content creator and a pre-med coach. There was also a physician who, on social media, because his story sparked other providers talking. And when I say providers, I'm not just talking physicians. I'm talking nurses, physical therapists, orthopedic, occupational therapists, everybody who is a provider. His story got everybody talking. There was an ER doctor who came up very loud And when I say loud, they weren't hiding anything. They were on social media saying, I'm in the ER, and everybody in here knows that the ER is a high-stress, adrenaline-driven place. She left the ER because she said she could not deal with the shortages and everything that came along with being in the ER anymore, the pressure of charting, being in the ER. She left. She left because she said they kept asking for more. There was also another physician on social media that left, but she needed grief counseling because when she left medicine, she said she left a part of who she really was. Training that long, working that hard to become a physician, and she could no longer do it anymore. I think this should make everybody in the room stop. I think it should make everybody say, as a matter of fact, everybody say, Because the people that we're asking to hold others together are actually needing someone to hold us together. And this is not just their crisis. This is our crisis. This is going to affect everybody. And I want to do something. I like telling stories, and I see my monitor here, but I want to take you on a journey. I'm going to need your permission to take you on this journey because it's a little uncomfortable, and if you don't like it, we're going to blame it on Dr. Jackie. So it's uncomfortable, it's not exaggerated, it's not drama for drama's sake, it's just uncomfortable. So I need everybody in the room to just bear with me because this conversation is being held and had in hallways, in call rooms, in chat rooms. Everybody's talking about it. And I would like to say, before I go any further, I want to act like a flight attendant. You know how they kind of walk up to the exit row and they kind of smiles at you? They're serious, but they're smiling at you. So I'm a flight attendant right now because I need your permission to take you on an uncomfortable journey. So if you go on this journey with me, I need you to be ready. I need you committed. And I'm going to ask you yes. So on the count of 3, I need everybody in the room to say yes. 1, 2, 3. Absolutely. Let's go on this journey. So the first thing I need you to do is just take in a deep breath. Let it out. And then I want you to think of the person that you absolutely love the most. I want you to picture this person. And whether this is your child, whether it is a spouse, a mother, a grandmother, a niece, a nephew, just picture this person. Close your eyes. I want you to see their face. I want you to see their smile. I want you to see that expression when they're tired or when they're happy. I want you to hear the sound of their voice and the one thing that softens you immediately. I want you to hold that image and just hold that feeling you're feeling. Now imagine you walk in the room and this person has a medical emergency. Whether they can't breathe, they've collapsed, or they're hemorrhaging. I imagine right now your heart is racing, your thoughts are not lining up, your body is moving before your mind can catch up, and you don't know exactly what's wrong, but one thing about it, you know something is wrong. And you need help, and you need it now. So you rush this person to the car. You buckle them in the seat, you start driving, you're running through red lights, through stop signs, weaving in and out of traffic, and I can imagine you're praying, dear God, I need help. Try to think that this panic that you have is taking over. This fear that you have is sitting right in the middle of your throat and nothing else matters. You have your focus is singular and all you know is, I need help. And then all of a sudden, there's an announcement that comes across the radio. Breaking news, your local hospital is overwhelmed. Patients have been waiting for hours all outside of the emergency room because 80% of the staff is gone. Your stomach drops, but you're smart. You're thinking, okay, I can get to the urgent care. I'm taking them to urgent care. And the radio continues, the urgent care centers are also down by 80% of their healthcare workforce. Your hands are tight on the steering wheel. Your mouth is dry. Your mind is racing, and you're thinking, where can I go? Who can help me? Because I need help with the person that I love the most. And there's another final announcement that comes across the radio. This is not just happening right here in Washington, D.C. This is happening all across the United States of America. 80% of the healthcare workforce has opted out of providing care. You see that face you're seeing? I want you to open your eyes. And on a scale of 1 to 10, 1, I wasn't worried at all, and 10, I was scared out of my wits. Where would you be in that moment? This is not just an imagination, guys. This scenario could soon be happening. This is a warning. Again, ladies and gentlemen, we are in a crisis. And the crisis that we ignore today will show up in someone's emergency tomorrow. And I'm sure you're thinking now, is this Dr. Jackie talking right now with this story, or is this Dr. Jacqueline Walters? And as I look around, I'm sure you're wondering, well, who's the 80%? And I want you to stay with me on the 80% because I'm going to tell you exactly what I mean. You may know me as Dr. Jacqueline Walters. Some of you know me as Dr. Jackie. Some of you know me for advocacy, philanthropy, and all of the work that I do. But the reason I can stand here today and make it as simple as this is I am a physician. I am an OBGYN, and I live in the high pressure points of medicine. I'm with women when they're at their strongest, but I'm with them also when they're at their weakest. I'm with their families through pain and laughter and joy and fear and recovery. I am also a woman provider. So if you know anything about being a female provider, we live inside the healthcare system where it depends on our excellence, it counts on our empathy, and it ensures and assumes that we have endurance, and it rarely stops to add the cost. I wanted to show you, if I can, I'm not sure I can show you this, a reenactment that I did. I walked in my office one day after being on call, and anybody knows about a 24-hour call, it's a lot. And when I got to the office, the practice manager had a list of things for me to do. My most valuable nurse had called out. The patients were wearing me out because I was late, and I was just consumed with the day. And I don't think I can get it there for you, but anyway, I got to my desk and I sat and I started thinking, dear God, what can I do? Because as a provider, we are probably in the one profession where you can rarely make a mistake and not pay for it. I decided to pack my bags, I got in my car, and I left because I was feeling really dangerous and I could not be my best. A few years ago, I was diagnosed with breast cancer, not once, but twice. And finding out that I had breast cancer on February 23rd, it was a Monday. I actually picked up the phone and I called pathology because I knew it was going to be nothing. And what he said on the phone is, you have infiltrating lobular carcinoma. As a physician, I'm like, is that cancer? And I knew what infiltrating lobular carcinoma, but when they use that word with your name, you have to wonder. But they said to me, you have infiltrating lobular carcinoma, and in that breath, if you know anything about Dr. Walters, I was scheduled for surgery on a Thursday. Most people would, in that time, would walk around and make sure they're wrapping their head around the diagnosis, calling their family, and just getting ready for what's next. But no, in my 3 days as the managing partner for a small OBGYN practice, I was making sure everybody was going to be okay. I wanted to make sure my patients would be seen at the level of expertise that I would see them. I wanted every employee to be okay. So I was not wrapping my head around that, I was getting ready. In that same week, I had a patient who was also due for a medical induction, which was going to take place on Thursday. And as you know, I wouldn't be there, but I made sure as a responsible physician that I would get my partners to get this patient delivered. And as it has it, she went on, she delivered, the baby was fine, the mother was fine, and clinically I thought everything was okay, or so I thought. I returned to work in 6 weeks after having had 2 procedures, getting ready for chemo and knowing I had radiation. And I walked in the office, and coincidentally, the patient that had been delivered also was there for a postpartum visit. And as OBs, we walked in, and I'm excited, and I'm goo-goo gaga with the mother. She's fine, her exam is fine. And I turned to look at the father. I could tell immediately that he was upset. And he said he was upset because I did not make their delivery. I looked and said to him, and I'm not sure why I felt compelled to tell all my life. I'm like, I've been diagnosed with breast cancer. I've had 2 surgeries. I'm starting chemo on Monday. I have radiation. I'm just sharing everything to make this man happy. I said, I just had a pregnancy loss, and I just found out about breast cancer. And he turned to me, and I'm hoping he would retract his statement, he would have some sympathy, or would be silent. Nope. Words that he said to me, I'll never forget. He came very close to my face, and he said, Ann, you couldn't have called and told us you weren't going to make my wife's delivery? Guys, I stared, and I didn't know what to say, but I apologized again for having had breast cancer to make him happy. And what I want to tell you, this was a horrible response for him. It was cold. It was upsetting, but it's not random. As providers, especially female providers, this was a normal response. So yes, it was wrong, but it is not random. I started thinking deeper and deeper. What in the world would make someone respond like that? Because as a physician, we tend to study patterns, we study symptoms, and I wanted to study what kind of healthcare system have we created to make a person hear that their doctor has cancer and they respond as if a disruption of service to them is all that matters? I want you to think about that. We've built a healthcare system in which exceptional care has become routine, routine care has become expected, and expected care has become invisible. And so when I say 80% of the healthcare workforce may come up missing, in fact, I'm talking about women providers. Women providers make up the vast majority of healthcare. We are the backbone of healthcare. And without women providers, if they give up, cave in, cut back, retire, and stop practicing, we're not going to have a staffing problem. We're going to have an access to patient care problem. We're going to have a quality problem. We're going to have a trust problem. Women providers spend 2 to 5 more minutes with patients. They tend to have better outcomes, and they get diagnosis fast. I don't know if it's because we talk more, but women providers tend to get better outcomes. And this thing that I'm calling burnout is not one thing. It is not just I'm fatigued and I'm tired. It is not just that my mental wherewithal is not there today. It is actually cumulative, it's layered, and it's structured. First and foremost, I want to dissect the layers. I've written them down. Clinical demand. For the physicians in the room, nowadays with the clinical demand is the days are tighter, the visits are shorter, the inboxes are fuller, the charting is longer, you're up all night making sure you get the charting done. The pressure is heavy and the stakes are high because the people at risk are the patients. It's a relational demand. Women providers are asked to do medicine and to manage emotions. We have to diagnose and reassure. We have to still feel present, but hurry up and get through this visit. We have to be direct, but don't be too direct. You have to be warm, but don't be too soft. You have to lead, but don't make anybody uncomfortable. And this is labor, and this labor takes energy. It's an organizational mismatch. The system now is asking us to give quality care, prevention, connection, but it's telling us to hurry up, volume, visibility, and speed. And whatever we continue to reward, we're going to reproduce. So if the mission is telling us to care deeply, and the model is saying move fast, you're going to lose 80% of your healthcare workforce. And then layer 4, home, sweet home. Everybody in the room can relate to what it feels like to go home. Women providers leave one shift and they go to the second shift. We are momingers in that we manage the kids, and we're wifingers because you can't find your socks. We are taking care of everybody. We're remembering, we're making plans for everybody, we're caregiving, we're getting the kids everywhere. And I will say, not all tired is the same tired. Or should I say, not all tired is equal. It's not the same. And then lastly, there is silence. So many women providers do this and we make it look easy. We come in, we smile, we put on makeup, we make sure everybody's happy in the office or in the hospital. And the system that we have cannot fix what it cannot see. So the question is not, is burnout real? Burnout is really real. Everybody knows it. It's costing us retention, continuity. It's costing us patient care. And for some of us, it's costing us money. The healthcare system that we've built on this invisible labor that we have is running on debt, and the debt is coming due. Trust me, the question I have is, what are we going to do about it? And we're in the room with the right people now who can tell us, because when women give up, women in healthcare, and the workforce is gone, again, we're going to have a loss of leadership, we're going to have a loss of patient care. So it is my charge to each and every person in the room to tell us, what can we do about it? I started with saying we have providers, we have got healthcare leadership, we've got executives from insurance companies, policymakers, pharmaceutical leaders. What can we do? Because for each layer in this room, we have something we have to do. Being on the phone, calling to get prior authorizations, following the rules, trying to make it happen is a lot. And I just said, when we leave one shift and we go to another. So don't ask us, how can we endure the burnout? Let's ask, how do we stop it from happening? So if you lead, I need you to lead better. If you design better. If you pay attention. And if you regulate with reality in mind. To go into the room and spend 15 minutes with an annual visit is unheard of. First of all, women talk way more. And to walk in the room and take care of her from her Rudy to her Tootie takes more than 15 minutes. And if you teach our new generation that they don't have to inherit this health care, that they can change it, that they can make it different. And to the young people in the room, let me say to you, don't give in, don't cave in, and don't quit too soon. We need you. If you see something that is broken, say that it's broken. Broken is not permanent. It doesn't have to stay this way. The next generation is needed. I want you to stay in the room, stay in the conversation, stay in rooms like this where leadership changes, where leadership matters. I need you to stay here. And to the 80%, don't stay silent. Don't accept dysfunction. Make sure we're saying something. Speak up, get involved, and be a part of it. We don't suffer quietly anymore. And before I close, I want to say, protecting your healthcare workforce is protecting the patient. These are not two conversations. In order to protect the patient, I'm asking you to protect the healthcare workforce, the 80%. Because the crisis you see today may show up in that face that you saw when you closed your eyes. Thank you.
Thank you to Dr. Jackie, and thank you to Katie for that wonderful introduction. It's a great reminder that at the center of all of this is a patient and a person, and from the U.S. Chamber perspective, an employee. Now, we're going to shift a little bit and get back to the business of this. We're going to talk a little bit about the leadership that is changing things at the highest levels. Now, our next conversation is led by a U.S. Chamber board member that has been a fantastic mentor to me. His name is Ray Cairns, and he is the CEO of the Next Solutions Group. He's going to introduce the panel, but I encourage you to welcome Ray to the stage.
Good afternoon, everyone. Very nice. That's a lot of energy for folks who've been in a room for a pretty long time. My name is Ray Cairns. I'm a board member of the U.S. Chamber of Commerce, the CEO of Next Solutions Group, a reputation management firm, and I'm a chair of the Center for Disease Control Business Roundtable. We're really excited to be with you guys here today. We have a number of CEOs here up on stage who are going to talk about areas for us to all focus on going forward, because the reality is healthcare, as we know, is interchangeable and interdisciplinary. Everything we do and the decisions that are made at any point, whether it be a payer, provider, diagnostic firm, those decisions then have an impact either upstream or downstream. We're going to talk about that here today. But as we look at it, you all, the concept of America's health advantage is something we're also going to focus on, because there's no doubt America is the greatest country in the world when it comes to innovation. But how does government impact innovation, either good or bad? Nothing we want to talk about. However, let's talk about our participants up here who agreed to do this today. I want to thank them for their time. We know they have a lot of things to work on. We'll start at the end. Bob is a leader of one of the nation's largest health systems. So he's going to come from a perspective from that end. Amir Ali, he co-leads a company who directly impacts both payers, patients, and providers. And Luis runs an organization that is at the epicenter of both insurance and technology. So we're lucky to have these folks up here on stage with us. So let's start closest next to me. 13 years. 13 years of innovation. How did you get there? What made it start? What was the decision you did to actually start getting involved in an organization such as the one you're running these days?
Yeah, so it's great to meet everyone. Obviously very excited about this opportunity. I represent Oscar Health, and as you alluded to, we are a individual health insurance carrier that has the privilege of serving over 3 million members across 20 states in the US. And we are a technology company, a data company, an AI company, but then a health insurance payer and work across the spectrum. We view it differently. We put the member at the center of everything we do. You heard a lot of the panelists earlier today about how do we make the member experience, how do we make employees of business owners get the best health care, and I think that's the way that we're able to actually influence care. And I know we're going to get into this into the technology and innovations section. We're seeing a lot of things of how people are talking to us through AI chatbots and telemedicine and things of that nature, and there's so much more that we can learn where people are feeling comfortable of sharing. And there's just a ton more that I'm excited to chat about there.
Well said. Interesting enough, I think your company is also 13 years old. Is that correct?
Yeah, approximately, yeah.
I mean, how did you get into it? What made you start? What problem were you trying to solve when you started the organization?
So I'm co-CEO of Guardant Health. We are a liquid biopsy testing company for cancer patients, blood testing for people who have cancer already, to helping their oncologists what treatment is going to work, what treatment is not going to work, and all the way to cancer screening. Blood test that got FDA approval with the first indication of detecting colorectal cancer. The history of last 13, 14 years has been amazing. When we started this company, less than 10% of cancer patients were getting diagnostic tests that we call them precision oncology in terms of managing and giving them the right treatment. And those people were getting tested based on a tissue biopsy information. Like, to paint you a picture, a lung cancer patient, sometimes they needed to go to a rebiopsy through the chest with about $15,000 cost, and more importantly, a material amount of complications that happens at the time of biopsy. There were some kind of scientific evidence that these tumor markers are also in blood, but we didn't have technologies to detect them. So what our company did was bridge that gap. We built an American innovative technology that effectively we have blood tests that we can detect and characterize tumor with that simple blood test. Fast forward, now this is a standard of care. About 30% of all cancer patients in the US are getting tested by our blood test. The 10% that I mentioned in general, and like getting the right amount of testing done now, about 80% of people are getting tested properly, which we are very excited about.
Bob, how do you innovate when you're a health system? I mean, you've got a lot of people, a lot of facilities, technology coming and going. You've got governments telling you what you can and cannot do. How do you innovate?
First of all, I want to say, as we've studied organizations out there, the organizations that can really innovate at scale have been the most successful, the most sustainable organizations. And our guideposts for innovation, Ray, are really 3 or 4 things. One is it needs to be consistent with our mission, and our mission is to transform healthcare to be a leader of positive change. Second, it has to have the opportunity to improve quality and patient outcomes, because that's what's first and foremost on our mind. It has to help with the patient experience, make the patient experience more favorable. Also, a couple other attributes on innovation would be, does it improve access to care? Is the innovation allowing more people to access the care that's available out there? And then, last but not least, is it something that can bend the cost curve to make healthcare more affordable? So just a couple, examples there. And I think this was probably one of our biggest innovations at scale. Was we started our own medical school about 5 or 6 years ago, and it was founded on the principle of innovation. First, we have a shortage of physicians, particularly primary care physicians. So this was an opportunity to train more physicians, and hopefully they will stay in our state, in New Jersey. About 50% of our graduates have. But what I'm most proud of is the innovation that goes on there, because medical schools that have been around for 100, 200 years, they don't have that blank slate, if you will. We had kind of this whiteboard, and we put in a very innovative program for physicians that we call the Human Dimension Program. So how that works very simply is, if you're in medical school for those 3 or 4 years, you're assigned to a family, and you follow that family, mainly in underserved communities. You follow that family for 3 or 4 years. And what does that do? It gives you a focus, because you're empowered to help some of those families stay healthy. And some of the challenges they have are some of those social factors that we hear about all the time. It could be food insecurity. It could be unstable housing. It could be that they don't have transportation getting to and from their doctor's offices. And what that does is it's producing a generation of physicians that are focused on prevention as well as on treatment. And that's kind of an example of innovation at scale. We have some very exciting partnerships also that help us innovate, and I'm really proud of that. Just one I'll mention is with Amazon. We have a division of Amazon is called One Medical, and what they do is they provide primary care services in brick and mortar settings, and we've signed an agreement with them where we're going to establish 20 of those throughout New Jersey. Think about this: 1 out of 3 people in our state and across the country don't have access to a primary care physician. This is a way to really expand that network. We also have a partnership with an organization called K Health, and what that is to set up a virtual primary care network. Guided by AI, people can access a primary care doctor 24 hours, 7 days a week without having to travel anywhere. So that's, to me, that's how you innovate at scale. Whether it's in medical education, which really is important because that sets the foundation for future healthcare, or through exciting partnerships that are available.
Yeah. Luis, we were just backstage watching the representative talk about insurance and the need for ultimate change. How do you evolve from where you are right now? I mean, you're pretty innovative as it is, but how do you go to the next level?
Yeah, I was very interested in a lot of the commentary you had and agreed with quite a bit of it. And I think we're in a unique position. So Oscar Health, again, is an individual carrier. Part of the reason that we're excited to be here is that we want to talk to the chamber. We want to educate on what individualized products can be. And I think a lot of the topics that we just talked about, the products you represent, the innovation that you're talking about with One Medical, is really we should be purchasing healthcare as individuals. We're not looking to break up the employee-employer relationship. The employer still has a paternalistic instinct. You want to recruit top talent, you want to be competitive in your benefit packages, but you could be the funding mechanism. You don't need to be taking the risk or how you manage your population. And what you can do is you can take a wallet, and it came out of the Trump 1 administration, is you can take those dollars and then purchase what you want for your family. And I think that's really where there's a lot of things with the administration that are happening today that we believe in that can actually change. And then when you put more power in the hands of consumers, it forces people to compete. Right now, if you're just buying through an employer, you're being told what 3 plan designs you have, and nothing wrong with an employer. They're doing the best that they can for the population they serve. But wouldn't you rather give a stipend through a pre-tax benefit, employee-employer relationship, to buy one medical product, to buy a product for colon cancer screening, to buy longevity medicine, or buy a rich plan design because you're expecting a baby, right? You actually will choose the choice, and I think that's really where we need to go in healthcare, and we'll see a lot of changes if you put more power in the hands of the individual consumer.
As a former executive at Pfizer and Bayer, when yes, you had all these great plans, and now as a small business owner, I thank you for those comments. Please keep it coming. Mirali, here's a question for you. When we talk about the word innovation in general, the concept now of a diagnostic that could potentially intellectual property be stolen. How do you protect yourself?
So I think, as I started earlier, like a problem that we solve is, we were dealing with some unknown biology, like looking at tumor biomarkers in blood. There were not good databases around that. Our level of understanding were very limited. But over time, with the data that we captured, in real world, so far we tested more than 1 million patients. And we believe, that took us 13 years or so, we believe the next 1 million data is going to get generated in less than 1 year. So that amount of data, advancements in human genome sequencing that we can look at these markers in a very comprehensive way, and the power of AI, is giving us really an advantage to understand that biology better, make our test better, and make the indication broader. Maybe I give you an example to hopefully make it a little bit more tangible. We have a blood test now which has FDA approval for colorectal cancer. Through the data that we captured, then we did real-world analysis, we used AI algorithms, and we showed that looks like there are about 10 other cancer types that we can detect using the same blood test. So that's a very strong pipeline activity for us in terms of improving the impact that we have. At the end, at Guardant, we are putting patient first. We want to make sure we develop the test that is going to have clinical utility. We are going to generate the evidences that help health systems and payers to embrace those technologies. Because we are not just after providing innovation to the people who can just do self-pay, the most maybe high net worth individuals, that they can get access to this kind of innovative technologies somehow. We are after making sure we bring this kind of innovation in an accessible and equitable way. That's why we have to go through FDA process. We need to generate randomized studies at very large scale to convince not just regulators, some of the policyholders and other stakeholders to provide access to this American technology and their beneficiaries.
So this is a question for all three of you. You guys can decide who goes first. When we're looking at innovation and attempting to innovate, and the fact that almost the ground moves on a daily basis underneath our feet. It could be a change in policy. It could be change. You mentioned AI, Mirali. There's so many things that are coming at us on a regular basis. Then you add a pandemic in the middle of that whole thing, which again felt like it was a long time ago, but it wasn't that long ago. How do you navigate that change, that innovation, and try to continue to be at the forefront from where you are now? Because you've been doing it now for a while. You guys didn't just start this today. This is an experiential opportunity for you. I'm looking at you, Bob, because I think you
Okay,
want to jump
I'll get it started, yeah. I would say that, certainly throughout my career, there's always been challenges, there's always been opportunities, there's also been major developments out there. But I would say, Ray, that right now, we have a lot that is happening out there that's, impacting us. I think, from an organizational perspective, I like to say that we want to stay the course, but you also want to take into consideration those factors that are out there. So let's take AI as an example. You mentioned AI. It's something that we have embraced. I don't think healthcare systems and hospitals and other providers are going to be able to function in the future without a tool like AI. It's probably the most transformative technology that we've seen come along in many, many years. So I do think it's something that we have to embrace as part of our core mission. It's something that can help us to innovate. I would say this, though. I don't see it as a replacement for the providers that are out there. You know, when I talk to physicians and I talk to nurses in our health system, you know, maybe at the beginning they were certainly a little fearful of AI, but more and more coming around now saying, you know what, it's going to make me a better doctor. It's going to make me a better nurse. It's not going to necessarily replace me. And I think that's how we go into it. With respect to policy changes, boy, I tell you what, I mean, you know, I could probably spend the next 2 hours on that one. But, you know, if you think about just H.R. 1, the One Big Beautiful Bill Act that was passed last year, you know, and the amount of Medicaid cuts that has resulted in, and for a health system like Hackensack Meridian, where we take care of 20% of all Medicaid patients in the state of New Jersey, it's significant. But, you know, I've heard maybe colleagues out there talk about, well, you know, maybe the political winds will blow a different way and this will go away. I don't think that's a strategy. I think you have to be proactive, put a mitigation plan in place. So what have we done? We haven't changed our strategies. We've doubled down on some. So a good example there is we have doubled down on building an ambulatory care network because more and more healthcare is being provided outside the four walls of the hospital. So if we think about our revenue stream in the future, it's going to be more in the ambulatory care network. So that will help to mitigate maybe some of these cuts from Medicaid. So currently, as we speak today, we have about 500,000 square feet of construction going on to build urgent care centers, surgery centers, primary care physician offices, specialty offices, and then what I would call one-stop shopping medicine, health and wellness centers where you have a lot of services under one roof. People want, and this goes to consumer choice too and consumer preferences, people want care either in their home or closer to their homes. So we have to kind of follow those trends. So I don't think you have to abandon your overall philosophy. You don't have to abandon your strategies, but you have to take into consideration the environment out there because you can't live on an island. But that's just one example, and it's working. I mean, just yesterday, just quickly before I wrap up this comment, just yesterday, we dedicated one of these health and wellness centers, first one in the nation, at a major metro station, at one of the big metropolitan train stations in New Jersey, Metro Park. And think about the unprecedented access to care that people will have. So if you're living in downtown Philadelphia or midtown Manhattan, you can get to this health and wellness center, which is that one-stop shopping concept, within 30 minutes. Think about how much more convenient that's going to be for providers, physicians, nurses, others. So that's the future of healthcare, and you know what? That's not going away. Those are consumer preferences. AI isn't going away either. So, you know, we need to embrace it, but we need to also reassure, you know, our providers that it's not going to replace them, but it's going to enhance what they do.
Yeah, and I think that's a great point. Like, there's certainly no substitute for physician in actually bedside manner, and we're actually seeing consumers and physicians become more educated when you actually have your primary care visit, because people are I put my Quest results into ChatGPT, and that's probably like outdated now, but now I have a trend line and it tells me to eat a Mediterranean diet. But like we've become more sophisticated at Oscar, where we have a program called Oswell, which is a clinical chatbot that's actually tied into your health plan, that is tied into your deductibles, your prescriptions, the care you're receiving at your provider, and you'd be surprised. We've only rolled it out to 30% of our population, so still several 100,000 members, and you'd be surprised how much people tell you, obviously finding care and what is my deductible and basic things, but I'm taking this drug and I've researched that this is another good drug, and we immediately tell them that those don't mix. Mm-hmm. So we have ways that we can educate people that until you talk to your doctor, you would have never known that. So I think there's a way that AI is if it's tied into a health plan, a health system, it can actually make consumers even more educated. So you get the access to care, as was just explained, but then even getting more education about what it costs you financially, and then how can you access the system more easily as well.
Maybe I can offer actually a couple more tangible examples. One, building on this AI notion. Like just with the power of this technology advancement, what we've seen is as long as you have high quality data and you use this technology in an effective way, you can speed up the rate of innovation. The state of the union of innovation in this country is great, and we can even make it better with the use of this kind of technologies. I give you an example. I mentioned the same blood test can detect maybe 10 other cancer types. We are seeing that not only you can detect cancer, looks like, you can detect neurodegenerative diseases, autoimmune diseases, like COPD or Alzheimer, and some other conditions. We are going to focus on the ones that really have clinical utility at the end, but just it's fascinated by the rate of science that we are learning. On the other side, maybe connecting it to some of the changes in the policy and how it could impact innovation. When we are talking about make America healthy again, it's very obvious that if we can detect cancers at early stage, it's proven, as like you can detect at early stage, specifically for colorectal cancer, 91% of them you can cure. So you can add a lot of quality life and you can save a lot of costs. Our test and CMS and was very proactive that right after we got FDA approval, the day after CMS covered our test for Medicare beneficiaries. But now younger patients, which really colorectal cancer is becoming a disease of youth. It became the leading cause of cancer-related death in patients at age 50 and below that. They don't have access to this American innovation. Why? Because there is a government guideline body that decides what kind of preventative services US citizens and average population need to get. The problem, they haven't started looking at this thing 2 years after FDA approval yet. And there are examples that sometimes their process takes 7 to 10 years. So just imagine such an innovative American technology, the impact it could have on young patients. We are seeing great impact for Medicare beneficiaries. Some of the international countries are seeing more benefit on the young patient testing than what we are doing in the United States.
If I just pick up on that, I think you could argue outcomes in the U.S. healthcare system. You could argue about whether we have the best quality in the world. You can certainly argue whether we're the most cost-effective country from a healthcare perspective. But I think you can't argue about American ingenuity and innovation, particularly in the healthcare space. So my message out there to regulators and legislators is don't stifle that innovation. Let's not lose our edge. Certainly in Europe, we're seeing heavy regulations that are really impeding the development of technology, of innovation, of AI. And I think we need to strike that right balance here. I'm not saying that we shouldn't have any regulation. I think there needs to be some guidelines. There needs to be regulation over a technology like AI because we want to make sure that the public has faith in it, that our provider community, our entire healthcare ecosystem has faith in it. But I do think that the regulations can't be overbearing. And then the other piece that I've been talking about is updating regulations. We have regulations, whether they're on the federal level or the state level in the US, that go back to the 1970s and 1980s, and they have not been updated. We were at a dinner last night together, and I talked about this, but the Stark laws are, as a good example, is really impeding collaboration between different parts of the healthcare ecosystem. And it needs to be updated because back when that legislation went through and those regulations were promulgated, the healthcare system looked a lot different. It was just entirely a fee-for-service system then. It has evolved since then. So regulations need to be updated as well.
Well, I'm glad you brought the topic up because this is called America's Health Advantage, correct? And this is the whole why we're all here today. And so the concept of what can government do, or what should government be doing or not doing to help advance innovation inside this country? Who wants to take that one?
Maybe I can start. I mean, the good thing, like we heard from Deputy Commissioner Chris Klum, that really HHS is open for business. And this is what we are experiencing too. I think the first thing we need to do is build the knowledge about some of the red tape and unnecessary processes that we have that literally just does not add reasonable value. But then single, company can never make a change. So what we've done, for instance, about some of our policy matter, we put a consortium of about 50 different individuals, some patient advocacy groups, some health systems, some payers, some other companies in the industry, to go and educate and bring the knowledge about some of the issues that exist in the last mile of bringing this kind of American innovation to patients. Sometimes the bottleneck is delivery. Sometimes the bottleneck is making sure people get equitable access versus they don't get access with the ways that we want to build to make sure everybody get access to this kind of innovation versus the most financially stable patients that we have in our high net worth individuals.
Maybe a different policy perspective. So we've seen states across the country, Indiana, Ohio, Mississippi, take up small business tax credits to employers that offer healthcare coverage through this healthcare wallet or reimbursement that I mentioned earlier. And I think what better way for a state and hopefully at the federal level to actually help small employers compete and actually give them some dollars to this HRA reimbursement and wallet. So we are seeing some progression. We expect about 13 states. There's a national coalition that is behind it. I've been to probably 20 capitals across the country, on both sides of the aisle, and there's no regulator that says I don't want to actually help small employers afford healthcare, because innovation is amazing and we need to keep doing it, but it does come at a cost. And I think helping small business working Americans is probably the best place that we can actually put our tax credits. And I think just going back to some of the innovation piece, some of the other topics and conversations we have with CMS around innovative plan designs. There's plan designs for diabetics to make sure that their insulin is capped every month, for folks with COPD, for premenopause plans, to make sure you get free bone density screenings for people at that stage of life. And I think the more individualized we can create these products, again, with network partnerships and unique products, the more innovation and cultivation we can actually bring to consumers. So I think those would be the two pieces, the tax credits for small employers and then continuing to allow innovation for specific insurance products.
If I could just pick up on what Amir was saying a few minutes ago, my experience is that CMS is open and is listening to people at the ground level in terms of what their challenges are, where there are opportunities. And just to give you a real life example, we just had discussion with some CMS folks earlier today. We have a partnership, our health system, Hackensack Meridian Health, has a partnership with the largest private health system in India, Apollo Health. They happen to have a surplus of nurses. We have a shortage of nurses. But there are visa issues, there are a whole bunch of issues that get in the way of those nurses either practicing remotely through a virtual nursing program or even coming to the United States to practice nursing. But the folks at CMS are listening to that, and they are working with us to try to come up with a regulatory solution. And I thought that was really very good, very healthy. I think they're looking for innovation. They're looking for ways that they can get things done. They don't want to be the agency that says no. They want to get to yes, but they want our help in getting to yes.
You bring up a good point, because obviously there's to be a change. We are at a very critical point as a country. Not enough doctors, not enough nurses. So how can you actually have the American advantage if you don't have folks who can administer it? Let's talk about the future. For each of your organizations, what does the future look like 5 years down the road?
So can we go here? Please. Okay, great. We want healthcare to be as easy as it was for me to book my flight and Uber to come to this event. I think with the AI tooling, there should be a way that each year in open enrollment that I can actually look at my claims history, my children, and I'll still make the decision, but it'll be AI-led to what is the best outcomes and the best products that I can buy for me and my health. And I think more consumerism is better for individual Americans.
I think within the next 10 years, we are going to see precision health for consumers. Diagnostics and services in general that would tilt the current healthcare of managing sickness really to managing health and wellness and longevity. We have those opportunities. The doors are sometimes open to listen to ideas, but sometimes we are missing action too. And this administration can really help to make sure such a vision become a reality by looking at some of the bureaucratic process that we have that are making innovation technologies to stay in some of the review process for over a decade.
As I think about the future, I see a future where technologies like AI are going to be making such a profound difference, whether it's in early disease detection or, as you're saying, precision medicine. It's going to be a dramatic change. I think we're really only in the infancy, and think about what's already been done over the last couple of years. So I do think that technology will absolutely transform the healthcare system as we know it today. I will also say that the trends that already are happening, where more and more healthcare is going to be delivered in people's homes or close to people's homes, will continue. You're going to see the hospitals as being less and less of the center of the universe of the healthcare system, and more healthcare, and rightfully so, will be delivered outside the four walls of the hospital. That'll make healthcare more convenient. It will make it more accessible and actually more affordable as well, which is a really big piece. And then the third area I would say is collaboration and partnerships. I think there have been a lot of really barriers out there that have really not enabled us to partner like we could or we should, but I think you're starting to see some of those barriers break down. I mentioned, Amazon and One Medical as one example. I wouldn't have thought of that 5 or 10 years ago. But there's others out there. We have a partnership, as an example, with Clear that you see and I know they're represented here at this meeting. That you see at the TSA lines. I mean, Clear is helping us streamline the registration process and the check-in process for patients. We have a partnership with Uber to make sure that patients can get to and from our care sites with much more ease. Those kinds of innovative partnerships, I think, will become more the norm. So people will get out of their own little space and think a little bit more broadly about how to deliver healthcare more effectively.
Excellent. We'll give each you 60 seconds for closing comments. Who wants to go first?
Start on this side this time.
Next go.
Closing comments. So the state of the union of innovation in this country is very strong. And based on the trends that we are seeing, we talked about it, for instance, genome sequencing, AI, advancements in radiology and imaging, some surgical intervention, med devices. The future could be very bright for the patients. It does not make sense to us, I believe many people in this chamber, that with all the spend and investments that we are doing in healthcare and all the best innovations that we have, the quality and the outcome of healthcare system here does not match some of the best developed countries. We can do better. The path is there, but it needs strong public-private and government partnership and some actions, and we can bring those days forward.
Well said.
Come back to me, and then I'll let you close. I think healthcare is local. A lot of what was said from Hackensack is the more that we can provide accessibility, access, it actually leads to affordability. It'll have better outcomes, better experience, people that aren't afraid and feel more comfortable accessing the system. And I think that just ties back to the payer-provider relationship and innovation. And the more that we can get people out of the four walls and just getting to the doctor more regularly and consistently on a preventative measure, the more success we'll have as just an overall system.
I would say my closing comments are one of optimism. I'm an optimist by nature, but I have to tell you that as I think about the challenges today, and there are significant challenges in the healthcare system, whether it's regulation, whether it's new legislation, whether it's workforce shortages, I think for every one of those challenges, there are many solutions, great opportunities out there. And I think, shame on us if we don't leverage those opportunities moving forward, whether it's new technologies like AI, whether it's really transforming the healthcare system and bending the cost curve, working together in a collaborative way to come up with creative solutions. I really think that we will really garner the might to be able to do this going forward. I really have the confidence that, just on this stage alone, the three of us probably could, after this session, could probably form 2 or 3 partnerships, and I think that's the kind of conversation that makes me very optimistic, because I think we can partner and we have the opportunity to really do something great. And I agree with you. I think our healthcare outcomes could be better, and I think they will get better. I think we just have to harness those opportunities and don't let the challenges discourage us. Take advantage of every every challenge and turn it into an opportunity. Turn the lemons into lemonade.
Well said. Again, just a thank you to our panelists here for the conversation. You know, when you get up on these stages, the amount of work that gets done before folks even show up here is pretty significant. Members of the team is trying to talk through how to make sure it's the most innovative conversation you can have. The second thing I'll throw out there is, if you're not a member of the United States Chamber of Commerce, as I said, I'm a board member. I'm a volunteer board member. The power of the Chamber, for those of you who may be new to it or don't understand it, is the ability to convene, to bring people together like this, to have direct conversations that help actually support our great country. We're all about making sure that innovation can thrive in this country and not be held back by regulation. So congratulations to everyone up here. Thank you guys for everything you've done today, and good luck in your careers. Outstanding work.
Thank you very much.
Thank you.
Yeah.
Thank you so much to that panel. I know we're trailblazing along. We have a really exciting afternoon, so stick with us. Next up, we're talking about something really unique in healthcare today, leaning in on AI and digital identity. So we're going to be joined by BCG, Boston Consulting Group, CMS, Clear, and Hippocratic AI. To lead the conversation is Priya Chandran with BCG.
Awesome. So I think this has been an exciting day, and we've spent the morning hearing about all of the innovations, all of the challenges, and we've heard a lot about technology. So in this panel, we're going to examine something that's very, very important for any of these technologies to actually, truly meet their full potential, which is trust and identity. So I have the pleasure of having three people who are playing a very important role in setting up the infrastructure, in driving a safe and safe environment for patients, for healthcare providers, for all of us to engage in this system. So it's my pleasure to welcome Munjal, Alberto, and Jane. I'm going to ask you to introduce yourselves because I think that'll be better than me introducing you. But maybe take a minute, tell us who you are, and tell us a little bit about your organization.
Start?
Yeah.
So I'm Munjal Shah. I'm the co-founder and CEO of Hippocratic AI. What we do is we build clinical AI voice agents that call patients on the phone or in-app and conduct various clinical activities like pre-op calls, discharge calls, care gap closures. And we sell to health systems, payers, and providers in the US and abroad.
My name is Alberto. I'm the Chief Health Technology Officer at CMS. I'm like the alter ego of Amy Gleason, so she and I work together. We've been working on a portfolio of technology projects at CMS. Most importantly, we've been working as part of the health tech ecosystem and launching this initiative with industry and many of you.
My name is Jane Stanton. I'm SVP of Operations and Marketing at Clear. Many of you may be wondering, why is Clear here? But by the end of the conversation, you'll know exactly why.
Yeah, and I will be honest, I looked it up and I was like, why is Clear here? And I read a lot about it, so now I know a lot more, Jane. Yes. So maybe let me start with Alberto, just at the 20,000-foot level. You are establishing this health tech ecosystem, and I know that you started with 60 partners, but now you're at 700 organizations that have signed up. Tell us a little bit about what you're trying to do.
Awesome, yes. How many of you here are aware of the Health Tech Ecosystem Initiative? See a few hands. So last summer, like 9-ish months ago, we reached out to industry. We talked to data networks, health applications, ACOs, providers, everyone out there that's involved in the healthcare experience. And we said, like, tell us what works, what doesn't work. We don't want to keep assuming that we know what works. We want to work together and figure it out with you guys. So we published a request for information. We got a lot of feedback, lots of ideas. We met with many of you. And then as part of that, we launched, at July last year, the Health Tech Ecosystem Initiative. So basically, we wanted to get the Lego interoperability blocks, right? Like if you look at healthcare, the truth is today you still get like, I got a letter 2 weeks ago asking me to fax my medical record to process a claim from my doctor. So this is the state of affairs in 2026, right? So we know there's some digital work that happens that actually it's successful. So what are the pieces that work? What doesn't work? Let's bring it all together, right? And if we were working together to build something new, like put your Legos, what would that look like? So the Health Tech Ecosystem Initiative, it's our effort to do that. So we basically want to empower patients to get access to the data real time with the patient, with the app of their choice, no more portals and logins. We're partnering with Clears and others to simplify this experience. We want to enable providers to get access to the patient's data, get real-time clinical data at the point of care, kill the clipboard, axe the fax. And then we want to do this using standards that work, right? So we're using like looking for all the standards, all the interoperability Lego blocks that actually work, bringing them together. The things that doesn't work, we have stood up working groups, and we've been working with many of you trying to figure things out and making everything actually connect end to end. And then we've been pushing the boundaries a little bit. So we said, like, let's talk to payers. We want to bring payers to the table. This is something we heard loud and clear from many of you. So we're trying to push new payments and operation use cases that traditionally haven't moved that fast. So we want to enable access to clinical data for claims that have been submitted in 60 days. And we want to also allow payers to share data that can enrich the whole healthcare experience. We created our interoperability framework. Basically, this is a way where every network that exists, the Rails that we know, the QHINs, the health information exchanges, but also more modern, innovative networks, many of them like private efforts and new projects that have come up, can participate. We can all speak the same language. We can all communicate the same way. And then we create this backend, this tissue that allows data to flow. We can get access to the information that we need, really at the point of care, and basically reduce the burden for patients, providers, and all of us involved.
Awesome. So that's a wonderful vision. So the backbone of it is actually identity, right? And being able to verify identity. So Jane, tell us a little bit about what you're doing in this space and what you're trying to do and how you're contributing to this vision.
Totally. So CMS and the health tech ecosystem in general are bringing to life and accelerating what we've always known to be true, which is that identity is infrastructure. And so when we look at the airport, for instance, that's a really good example of when you think of the intersection of security and experience. Really, identity is right there and is one of those core pieces. And so while we started in the most highly regulated environment where nothing can come at the expense of security, it has always been our mission and our vision to expand to other places where identity matters. And it matters in different ways to different customers and different types of businesses. And so, when we look at our B2B SaaS business, which is called ClearOne, and that is the product that CMS has integrated on their side. When we look at that, it appears in a couple of different places. For businesses that want to advance trust, like LinkedIn, you can verify your profile there. If you want to eliminate fraud, waste, and abuse, we're seeing that in the real estate space. We're certainly seeing it in CMS. And then others, like if you want to protect your business. So our friends at T-Mobile, for instance, use us to verify their entire workforce in a time of in an era of AI where nation-state hackers and synthetic identities continue to create real security risks for businesses. And so the reason that I highlight that is, I think that there are two pieces to this conversation and two reasons why the health tech ecosystem is so important. One is the actual experience piece. So when I am creating an account, when I'm checking in for a doctor's appointment, when I'm trying to reset my password, this friction isn't just an inconvenience, it's actually a barrier to care. And so we have this patient vision here, which is, alongside, the interoperability frameworks, how can I go to a variety of different health systems, and how can I get care in a way that is focused less on the information that I'm filling out and the information I'm providing, and more on the accessibility and the rapidness that I am able to consume and procure care. And then the second piece of this is, listen, patients are always top of mind for us. But the other people that are top of mind for us are you guys. I mean, what we want is for health systems and for CMS and for digital healthcare to be able to spend less time on administrative burden and more time on powering and providing care. And so, the GAO report that came out in December had some striking data in it. And one of it was, the billions of dollars that were lost to fraud, waste, and abuse. And one extreme example that was shared was that, one Social Security number alone was associated with 125 health insurance plans that were taken out. Now, that's not a fraud problem. That's an identity problem. And so I think at the core of so many of these issues that we see, whether it is, healthcare or you're renting a tool at the Home Depot, the root cause of a lot of these problems is identity. And I think moving forward in all of the work that CMS has been doing to really educate the industry, and frankly other industries who are picking up a lot of that information, really reinforces the concept of identity being infrastructure and the importance of it.
Thank you, Jane. And so if we think that the human identity is the problem, let's go to Munjal, where you're creating these AI agents, and these AI agents are actually going to provide more and more of our basic healthcare, I think, at some point. Tell us, Munjal, a little bit about what your agents can do and what do they not do?
Yeah. I think one of the biggest insights we had a long time ago was that all of healthcare has been premised on clinical scarcity. We've literally designed healthcare since probably the dawn of time, assuming we don't have enough clinicians. The word triage is an example of that. We're not like, oh, we're going to take care of everybody who walks in. We're like, well, we're going to save some and not save others. Population health ultimately always also ended up that way because it was never really the whole population you could address. You always figured out the sickest 2%, 3%, but really that was an economic thing where you just couldn't afford to do it for everybody. And I think that our first insight was the thing to do here is to bring this abundance to healthcare. That, there's an ideal. The ideal is every person should have their own clinician looking after them. And you probably would keep improving outcomes if you got to that. And actually, only healthcare and education, I think, have this property of being able to absorb the abundance because the ideal staffing is one clinician to one person. And in the case of education, the ideal staffing is one teacher to one student, right? But I don't know that giving you an infinite supply of accountants is going to make the world any better, but I do see that with clinical. The second part, though, was, we named the company Hippocratic after the Hippocratic Oath, because we made the tagline, do no harm, because we really were serious. I mean, I said, it's just not worth it if we're going to hurt people with AI, and this pledge that doctors take is maybe the right approach here. Let's make sure nobody gets harmed, if at all possible. And so in doing that, we set some boundaries. So we said we're not going to do any diagnosing or prescribing. And so we created our agents to operate up to the scope of practice of a registered nurse, which in the US does not prescribe and does not diagnose. We did things below that. We would do a care manager, we would do a dietitian, we would do a genetic counselor, doesn't diagnose either, by the way. But we said we're not going to go beyond that without some sort of FDA approval or something bigger. And I think that, but we also set other limits, like we don't do outreaches for kids under 2. We won't do mental health. So many people have asked me to do mental health. They're like, please, and people are using ChatGPT for mental health anyways, but I said, the problem is in physical health, there's a protocol you can follow. Like for congestive heart failure, check in. I see if your ankles are swollen. I see if you gain more than 2 pounds in a day or 5 pounds in a week. If something goes wrong, I can say I followed the protocol. In mental health, it's a lot squishier of a protocol. He said his dog died. You didn't follow up on that, and and then he ended up harming himself. Like it's just a very ambiguous area to, I think, really build a safety trust brand in a safety trust model. And I said, we'll do that later. So we don't do hospice. There's numerous things that we've just learned over the years to have the self-discipline to not do. And I think it's served us well in terms of building trust, with a lot of the people who use our products and with the patients themselves.
Thank you, Munjal. So, so you're setting guardrails in what you will and won't do, starting with things where you feel like it's much easier for you to be right.
Right.
Okay, so maybe let me ask you a question. In this age of AI, like it's going to be an AI agent counseling me about something. How do you think of identity?
Oh, sure. I mean, we think of it a couple of different ways. I do want to touch on one thing that Munjal said that, brought to light last night, the first time that I met him, something that I hadn't thought of, which is, right now, healthcare is so much of a pull. Like as a patient, or in my experience as a caregiver, like I'm constantly seeking out information. And what Hippocratic AI is doing, like turns this into a push model, where there is more that is coming to me, there is more that is empowering me. And that's not dissimilar to how it is that we think about AI as related to identity. And so there are two sides of this. One side is some of the work that we're doing, right now with the LLMs via our partners at BeWell and HealthX, alongside, Anthropic and OpenAI, which is when I am looking to access and use my own healthcare data, I'm verifying that I am the patient who has access to that information via my biometric identity. And so that is one piece, which is empowering me with my own information in a way that is secure, but is also seamless. And then the other side of the coin is that obviously AI introduces a number of security vulnerabilities and risks that are otherwise unprecedented in the cybersecurity space. And so what we focus on a lot is this concept of, you hear a lot of people right now, it's kind of becoming a buzzword of like a human in the loop. But really it is like, what is the moment in time that an actual person needs to give access to an agent or make it okay for an agent to act on my behalf? And we feel really strongly that that is a place where identity is going to continue to play. So I think that there is both the experiential component of this. It goes back to kind of like the two pillars that I talked about before, which is like the patient, how do we empower them with what they need? But then also the security, like how do we protect this data, where it's going, how it's being utilized, how somebody can leverage it, and how are we able to defend against bad actors who are maybe trying to leverage that information and use it for nefarious reasons. And so identity really plays on both sides of those, and I think when implemented correctly, it maximizes security and minimizes friction for the people who at the end of the day are the beneficiaries, which are the patients and the providers.
So Alberto, maybe let me ask you, you guys announced the access model. I mean, and Chris Klum talked about it this morning too. And it's really thinking about how do we drive outcomes, right? And health technologies and digital technologies and technologies like what Munjal has and things that you are doing, all of these become really important for that vision. So tell us a little bit about the vision behind this and how you think technology is going to play a role. And how you're going to enable all of those people who are going to now be paid differently to actually deliver on that promise.
Yes, so to speak of access, I think it's important to explain how we think about things at CMS, right? Like Dr. Oz wants to lead by example, and we acknowledge that we have responsibilities as an agency that we need to do for industry and for the people we serve, right? So one of those was, we said going back to the identity piece, we said we're not only asking people to verify their identity to have more secure data exchange, we want to lead by example, so we brought this into our Medicare.gov experience, right? We implemented CLEAR and a few other services to make sure that we can make it more secure for beneficiaries and also reduce the burden, right? And serve as an unlock function for the rest of the ecosystem. And then as part of the ecosystem, we brought the different patient-facing app categories. So we have 3 main categories that we started with, which is kill the clipboard, just to make things simpler, to reduce the paperwork and the actual clipboard at the point of care. We brought conversational AI, which is how can we bring innovation, right, and explore new modalities of care that can be unlocked in a secure way. And then we also emphasize chronic conditions. For us, chronic conditions are important, so we have in specific diabetes and obesity as the 2 main conditions that we have a category of patient-facing apps. But what we heard was there's a lot more in terms of chronic conditions. And even though we're doing these things and commitments that CMS announced and has been delivering on, the missing piece was what about payments and incentives, right? So it's something we heard very loud and clear as part of the RFI process and talking to many of you. So CMS, the Center for Medicare and Medicaid Innovation, they put together the access model. We've been working very closely with Abe and the team over there. Basically, we wanted to improve the way we do care. We want to bring and use technology to enable care. We're not in the business of replacing the doctor, but how can we empower the doctor, right? Like move away from this scarcity model that I agree a lot. And then how can we bring that technology and how can actually we properly pay and incentivize, right, everyone involved in that experience of care. So the access model is like our first response to that, right? So we have four categories there. Basically, early cardiometabolic conditions. We have mental health, and I'm blanking out on the fourth one. But basically, the idea is that we bring outcomes to the table too, right? We're not in the business of like just moving the paperwork and the amount of work to a digital world, right? So it's like even more expensive. We want to be, good stewards of tax dollar payers and actually enable care. So access model is like thinking about it the way we like to think about it, which is like put outcomes in the table.
Yeah.
So we have outcomes and we're looking for ways to improve. Participants in the access model need to tackle all the conditions that have been identified for each track. You can participate in more than one track. And the idea is that we bring this technology-enabled care closer to the patient, right? Like providers can participate, they can review and be part of the care review model. They can also refer these technologies to like their patients, and it creates like a new experience and a new flywheel to bring that digital care closer to the patients.
Great. Let me ask Munjal a question. Whether it's these technologies, whether it's your technology, which will obviously play a role in this kind, delivering this type of outcome. We talked about guardrails, but what about the other side? What is the inflection point to improve adoption? Because what you see is trust in AI, consumer trust in AI is kind of low, adoption is not where it should be. What is the other side of it? What can improve adoption?
Well, I mean, first, I think AI adoption is fantastic. 900 million people a month use ChatGPT. I mean, in what product has ever gone zero to 900 million?
To plan their vacations.
Right? In 3 years, like never.
Right.
So the second thing is we are seeing a surprising adoption by patients in it. Our average patient rating is an 8.95 out of a 10. If we call in their native language and it is in English, the average patient rating is a 9.8. Because if you live in America and you get a call in your native tongue, you're just happy you got a call in your native tongue, to be honest. So I think they're adopting it. And I think the central idea of why they're adopting is that this isn't about AI versus a human call. The truth in healthcare is that no human's calling. And so I think we framed a false kind of conflict there of, well, is it the human calling or the AI calling? Well, I mean, I'll tell you the story of my mother, who's 83 years old now. And 6 years ago, when she was 77, she went to her doctor and she got diagnosed for high blood pressure. She didn't like taking the pills because they made her dizzy, and so she just stopped taking them. She also told all of us that the doctor gave her a perfectly clean bill of health and said she was the healthiest 77-year-old she knows. And thanks to good old HIPAA, I didn't know, right, that she had these pills. Fast forward 6 years, I guess 5 years, about a year ago, we end up in the ER for 220 blood pressure, and she has the beginnings of congestive heart failure because she didn't take her meds. And, you feel awful as a child. You're like, oh my God, I should have done it. I don't know, I should have snooped in her medicine cabinet. I should have figured this out. Like, she would have snooped in mine when I was a kid. She would have made me sure I took it, right? You feel so horrible. But I think at the same time, her doctor knew she didn't get a refill for 6 years. How come nobody called her? Said, Mrs. Shaw, do you need a refill? What's your blood pressure? Can you take it right now? But our system isn't set up to be outbound proactive like that. It's set up to be inbound. So I think, we've now done 180 million patient interactions and seen no safety incidences, partly due to the architecture of how we built the safety. But we've also just seen patients talk to AI. And I bet you even by the end of this year, every single person, maybe not every single, but like 80% of America will have talked to AI, because the other day I was at Taco Bell going through the drive-thru and AI took my order. Don't judge. I was going for a friend. But but it literally took it. And it did a better job than they normally do, because normally my tacos always get messed up. And I bet the banks, the insurance companies, like by the end of this year, everybody's going to have talk to AI in some setting, and it's just going to be comfortable. And AI does something that no human does, at least anymore, thanks to the cell phone. It absolutely gives you its undivided attention. It hangs on every word you say. It's always empathetic. It's never tired. It memorizes everything you said to it before. And we've actually trained our AI to bring up like, oh, last time we talked, Mr. Shaw, you were having back problems. How's your back? Is it feeling better? And like, there's just a different level. And I think we've formed our opinions in the IVR world, and this is not your father's IVR. That was like a 60 IQ product, and this is like a 120 IQ product.
So we have 2 minutes left. So I'm going to ask Jane a question, because the infrastructure for me is so important, right? Take 1 minute and tell me, what would you tell people in terms of how do they choose a partner for identity? How do you think about it? Because there's still lots of choices in the United States, right? If you go to China, there's one choice, but here there are lots of choices. How do you think about it? Just take a minute, and then I have a 1 minute question to close out with Alberto.
Totally. It's a great question. It's a really important question. The identity provider that you choose is critical because it is infrastructure. So what I would say is, like, the very first thing that I would do is step back and look at, of your priorities, do you have a security gap? Do you have a trust gap? Do you have an experience gap? If you have any of those, you have an identity gap. So like that's the first place to start. And then the second place is really centering it on the patient or on the end user. It could even be the provider. You should look for a trusted provider that is known to the consumer, that prioritizes their privacy. That is really, really important, that the end user has control over their information. That information is too important. And the second one is that it is a tremendous user experience for them. And the third is that it is a reusable identity. What that means is that you verify once, you don't have to go through the same steps over and over, and you can continue to verify with a selfie. It's best for the patient, but more importantly, it's best for you, and it provides interoperability.
Thank you. Alberto, since you pay for most of our healthcare in this country, you'll have the last word. Tell us, you said we have 700 organizations that are participating now, more should. What is your 1 minute pitch for why more organizations should join this?
Yes, just go to cms.gov, look for the health tech ecosystem, read about it. There's a form there. If you're interested, come and join. Like, we have heard many times that very loud voices have set the tone and direction of healthcare in the past. Now this is an opportunity to show up and be at the table. We want all the voices to participate. We have like Clear is a friend of the ecosystem. They've been working with us, with providers, with EHRs, and everyone. We've been solving these hard technical problems. We're looking for providers. We're looking for payers. We're looking for more people to join this movement. Next time, I don't want to receive a letter from my insurance telling me to fax again, right? I want like this data to flow. I have a daughter that has type 1 diabetes, and next time I go to like, I don't know how many portals that we have and how many applications, like we just do it once in one single place, all the data comes, and she has a more simpler experience, not only for her day to day, but for us as the parents. So that's the future we want to build. Please show up, come, join us, help us build it.
Awesome, and I think that is definitely a future all of us want for ourselves, our kids, our families. So thank you with that. Thank you all. Really appreciate this. And this is a topic that is, honestly, I think you could go on for days. So, but it's going to be very, very important. So thank you all.
Thank you.
Thank you. Thank you.
Thank you so much to that panel. Love the conversation and where we're heading with these new technologies in healthcare. And we're going to dive a little bit deeper into that. And to lead this conversation is a fellow colleague of mine from my earlier days in healthcare. It's Kyle Zebley, the president and CEO of the American Telemedicine Association. He's going to talk with some really great colleagues that are going to be talking about the tools reshaping how care is delivered and experienced. So welcome to the stage, Kyle Zebley, who is going to be introducing his fellow panelists.
right, I hope everybody's having a fantastic day and learning a lot. How are you feeling? Good? Perfect, perfect. Well, you've had so many great panels, and there's a few things to follow us, but this is going to be the best panel of the day, so I really hope you're plugged in and ready, because I've got three really wicked and smart folks to my right that will have a lot to say. We're, of course, talking about continued innovation in healthcare and about what is changing right now, given the moment in time that we're in. I want to, before we begin, thank Lexi, who's a great friend, and we go way back to Capitol Hill. I want to thank the U.S. Chamber for pulling this together and bringing so many great minds up on stage. I'm Kyle Zebley. I'm CEO of the American Telemedicine Association. We've been around for 33 years during the innovative pioneering days of the dream of virtual care up through today, where so much of that's a reality. And there are so many opportunities before us, but also so many challenges. We really see ourselves at the ATA as a catalyst for change in the U.S. healthcare system. We can identify so many problems in healthcare, but we know that the solutions won't be identified without the use of technology and virtual care. Right now, we're at a really critical moment in time. Virtual care and digital health are no longer theoretical, of course. They're very much well underway, and they're the core of how healthcare is delivered today. Support to date in areas of virtual care, telehealth, connected devices, they have been largely bipartisan and, frankly, largely uncontroversial. I'll take some credit for that at ATA. We've definitely never taken that for granted. But I think we're actually moving now into a moment that will be more contentious, more divisive, because we are seeing some divisions. We're seeing this up on Capitol Hill. We're seeing this in communities around the country, pushback on AI, concerns about displacement, concerns about data centers, which is the necessary infrastructure for this to happen. The concerns around AI are around clinical decision-making and, of course, in workforce implications. The discussion, of course, then is how we can scale responsibly, balancing innovation with trust, safety, and real-world implementation that ultimately puts patients at the center of decision-making. With that, I want to get started with our conversation. Would just start to my right and ask for each of the gentlemen to my right to talk a little bit about yourselves, your role, and then, of course, give the audience a little bit of a sense of how your organization is helping define or redefine the modern health system.
Yeah, my name is Jose Arrieta. It's an honor to be here. I'm formerly the CIO and Chief Data Officer of Health and Human Services during the pandemic. I founded a company called Imagineer upon leaving, and I've been focused on post-quantum security, the ability to cryptographically wrap data assets and allow them to leave a system of origin with integrity, as well as building out autonomy programs and targeting systems in the Department of Defense environment. One of the things that I've been doing in particular in the health space is actually separating the logic and decision-making from the workflows. So how do you create a centralized decision-making authority where, whether it's Palantir, Oracle, whatever Anthropic, how do you create a separate centralized decision-making authority where you control your data, you control all of the pieces of intellectual property around your data that you're providing to the software company, they access it with those controls through an API, and then their software can execute on behalf of the values and the outcomes that you've embedded in your centralized control plane. And I think that's the only way you can democratize healthcare data and allow organizations to modernize themselves and have flexibility downstream.
Great. Sean Brown, Chief Information and Technology Officer for Zimmer Biomet. Again, really appreciate everybody being here and to the U.S. Chamber for hosting this event. Zimmer Biomet's the largest orthopedic company on the planet, and I think the journey and why it'll be important for this conversation is historically, next year will be the 100th birthday of Zimmer Biomet. That is going to be a big moment, and historically the company was built around metal and plastic, life-changing, movement-gaining hips and knees and shoulders, extremities. And what has occurred over the last 10 years is really the introduction of robots. And what's occurred over the last 4 to 5 years is the introduction of data. So when you start to think about how to connect the physical world, both with metal and plastic implant. Also, then you start looking at the robotic world. It's really connecting that physical world with the digital world and the insights that can be gained. And then ultimately, the most important part is how do you connect that to the human world? How do you connect that to the patients? How do you empower patients with that data? How do you empower care teams with that data? And ultimately, how do you recommend and drive decision-making up into those work streams to add efficiencies and outcomes that can affect the trajectory of healthcare? And right now, that's a critical moment for us as you think about the overall inefficiencies of, especially inside the US and other parts of the world, the healthcare system. We have the silver tsunami approaching, and my kids point out the more and more silver hair that's being added to my head every day. These two forces are coming together. And so how do we make sure that we are taking the physical world with the digital assets of data and AI, empowering the surgeons, the care teams, and the patients appropriately to make sure that we're set up for success, that the nurses are set up for success, and that we're able to handle this growing challenge of healthcare across the globe.
My name is Ricky Bloomfield. It's an honor to be here with you all and to talk about such an important issue. I'm the Chief Medical Officer at Aura. My clinical background is internal medicine and pediatrics, as well as clinical informatics. And at Aura, we're really focused on how do we take these 24/7 physiologic signals and turn that into actionable information in a way that is significantly different than traditional healthcare. I don't think anyone here would disagree with the idea that our healthcare system is fundamentally broken in a number of ways. When you have insurance premiums going up 10% per year, far higher than inflation, eventually the math doesn't math there. And we know we have to find solutions to that, and we're excited to try to help with that. One of the things that I think is really, really exciting is going from this reactive break-fix type system to one focused on more proactive nudges and information. And many of you, I'm sure, have been to a doctor, maybe recently. And in the traditional healthcare ecosystem, you have these sporadic visits, these points in time where you can collect information. Maybe it's once every few months, maybe it's once every few years if you're pretty healthy and you don't really need to go to the doctor. But despite that, all of us still have things that are going on, maybe brewing, that we're not aware of. And so trying to look at the world differently, where we have these 24/7 signals that we can act on, more like a check engine light on a car, so we can tell you proactively when something's going on. We believe that that's going to be a key part of changing how health is practiced, so that we can be much more proactive, which has always been the vision, focused on prevention, focused on value, focused on improving health outcomes and reducing cost. And we're excited to see how that will play out over the next decade.
Virtual care is about expanding access and meeting patients where and when they need care. But of course, one of the big game changers right now is data and what we can do with it, with wearables, remote monitoring, AI, and healthcare technology. It's creating the potential to move from reactive care to bespoke precision care in a lot of ways that these gentlemen are leading on. But there's a tension. How do we improve outcomes and reduce human error while being honest about data gaps, over-reliance, and current limitations? So I'm going to start with Sean. In your mind, Sean, and from the work you're doing and leading on, where is data actually improving outcomes, efficiency, and access at scale today? And almost as importantly, where is it falling short?
Yeah, that's a great question. I think at Zimmer Biomet, we really have a focus on solving the 4 most meaningful challenges in healthcare. One of those is around awareness, again, really empowering the consumer, maybe before they're a patient. We have hired our Chief Movement Officer, which some of you may know the name, Arnold Schwarzenegger, really to get out and talk about movement and how important that is. The second is around safety, and specifically around infection. There's a big challenge, and it can be life-changing in the wrong way around infection, especially with a lot of the orthopedic procedures. And then the last 2 are around efficiencies and outcomes. And this is really at that core of how do you start to drive precision medicine. And when folks think about precision medicine, I think it's definitely been at the forefront from a pharmaceutical perspective. But when you think about all of us, we're different. We grew up differently. We have different aspirations of what our normal life should be. We have aspirations of what our life will be in the future. And oftentimes when consumers are on that journey towards potentially needing a new hip or knee, in our case, they will go to their primary care physician and ultimately to a surgeon. And the surgeon often will pause and say, how are you? And it's literally a question because they don't have any data of that individual, certainly not data over multiple years, maybe passively being captured in their own consumer applications. And so that question is a very important one. And the applications that we've deployed, we call it our agentic AI layer now. We got some marketers in our firm as well. But it really is about, it's called MyMobility, and our overall layer is ZB Edge. MyMobility captures the phenotype of those patients as they're coming in. Gait analysis starts to look for degradation around range of motion. So when that first conversation happens with the surgeon, it's not how are you, it's how are you? I see some of the challenges that you've been going through. I see that you're a marathon runner. I see that you love downhill skiing. I see that you want to make sure you can get up and get another beer from the refrigerator and go back and watch the NFL football games. So that phenotype of who that person is so critical to the personalization journey. Capturing that upstream helps inform the different outputs that surgeon and care team will deploy. Inside the operating room, those decisions are captured. Then the recovery curve out the other side, we have the only smart knee, the Persona IQ. So we're getting specific data off of that knee change, and that will track with that patient as they start to get their new normal. And so you think about the phenotype beforehand, the decisions that were made intraoperatively, and then tracking the cohort of those recovery curves. It's a closed loop system that will start to add more of that personalization. So it's not a one size fits all because we're not one size fits all.
Mm-hmm. Ricky, we're talking about wearables and continuous data, but how are we making sure that actually is helping people before they become patients, before they're really even maybe in consultation with their medical providers? How do you make sure that data is used and used appropriately? And is it empowering, or with the sheer amount of data your devices can produce, is it just creating noise that's a distraction from genuine healthcare?
Yeah, it certainly could create noise. And so I think it's our job, those that are creating these devices, to make sure that we can identify the signal in that noise. And we're doing a lot of work right now to make sure that if we work with a payer or a provider, that we are providing concise, summarized information. So we're not just giving them another flow sheet to sift through in the 10 minutes that they have with patients, which nobody wants. And as one example, we have a feature called Symptom Radar. And if any of you have an Oura Ring, maybe you've gotten this, like the red clouds of doom in the app there. And this is a feature that was actually developed during COVID. We work with UCSD on a study called TemPredict. And what we found was that Oura Ring wearers could, the device could identify signs of COVID 2.75 days earlier than they would otherwise find out with a COVID test. Because what this was doing was really looking at their baseline set of vital signs and then detecting a deviation from that baseline. And we didn't want to release a specific COVID detection tool, so we decided to release this as a generic way to identify these deviations and then tell people there might be something brewing. And so we released it 1.5 years ago as Symptom Radar. And what we found is that, of course, it is identifying upper respiratory infection and flu. Many people will get this notification, they'll say, well, I feel fine, and then 3 days later, they're surrounded by Kleenex, and they realize, oh wait, this told me something that I didn't know. And that's the power of these devices. It's not tell us something that we already know. It is, can they tell us something we don't know and then help us take action sooner? For example, if you might be coming down with an upper respiratory infection, you can stay home, you can take it easy, maybe you can avoid that exercise or being in that crowd of people. And so this type of action is so important. But what surprised us, because this feature is really detecting deviations from your baseline, there are many things that cause that type of deviation. So we've now seen multiple cases of lymphoma that have been identified, sometimes many months in advance. It told them something was going on, and they went through a diagnostic journey eventually to find out that I was having early symptoms of lymphoma, multiple cases of appendicitis. that were identified where the individuals are just going to kind of brush it off and say, oh, it's probably nothing, it's probably something I ate. And because they got this alert that something was going on, they went to their doctor and avoided that ruptured appendix. And in all of these cases, these individuals probably would have eventually gotten to that diagnosis without the device. But in all these cases, they found out sooner. And time matters. Time matters for all of these things. And so I think this is just the tip of the iceberg for what we're going to be able to see, where we can actually pull that signal from the noise to make sure we're giving consumers, individuals, the right information at the right time to make the right decision, as opposed to a wall of data and making them figure out what matters. And there's still a lot of work that needs to happen in this area, but what we're seeing so far is very promising in ways that will hopefully start to bend that cost curve and help people be healthier, especially those that maybe have lost trust in the health system. You've probably seen this yourself, people that have stopped going to the doctor, and we feel a responsibility, especially in those situations, to help say, no, actually there are cases where you probably do want to go to the doctor, and to try to help be that guide for them. So we can, again, connect them with a doctor who's able to be their coach and quarterback for that specific condition.
Jose, I can't think of somebody better to ask these questions to, and for you to build on what you just heard, given the fact that you're at the very top of government in terms of the infrastructure that's really necessary from a national level to make all of this happen. But what systems need to exist to support this that doesn't exist now in terms of infrastructure and policy, and who owns the systems that would need to make decisions to support all of this, and how do we ensure they're trusted and usable instead of just another added dysfunctionality to an overburdened healthcare system?
And I should have told him before he asked the question, I'm from northeastern Pennsylvania. I'm only going to remember one question at a time. I'm
Fair
joking.
enough.
I'm
Fair
joking.
enough.
I think there's I'll start with a story. So a family member of mine who was significantly older went to the hospital, and the doctor said, hey, I think she has pneumonia. We're going to put her on some drugs, and she'll feel better in the morning. Maybe she's here 3 days, and she'll be able to go home. And one of the paramedics said, actually, I think she's septic, and she's going to die if you don't rush her to like a Trauma 1 center. And he happened to be right. And I think the single most important thing from an infrastructure perspective is how do you empower the system to actually drive a set of values as it relates to the patient based on the information that they have, and a set of controls over the data so that they can actually interact with the patient and treat them. And I think it's a significant shift from a technological perspective. So I think gone are the days of putting all your data into a large system, well, whether it's Oracle or Palantir. I don't work for either of them, so I can say whatever I want. Right? Gone are the days where you put all your data into a system like that, and then you provide all the intellectual understanding of what happens in that marketplace, and they build software that services you, because they are embedding logic in a workflow that's going to be applied to a giant base of consumers or health patients. And we had a dinner last night, and the guy that did prenatal care was talking about like, hey, the difference between treating a child and an adult is significantly different. So gone are those days. And how do we build infrastructure so that the healthcare system itself can define their own logic, can define their sets of values, can overlay controls on the underlying data that they have, and then connect with a Palantir, an Oracle, and AWS, and allow them to use the LLM and processing capability that they have to provide different solutions to solve a problem. And I think that's the fundamental change in the underlying infrastructure that actually has to occur, because at the end of the day, I'm going to be more comfortable speaking to my local doctor than I am to anybody else. From a security perspective, I think we all just need to remember 55% of global health GDP is driven by the United States. Depending on your math, 28 to 34% of US GDP is directly driven by the healthcare sector. We're the most data-rich environment on the planet when it comes to health data. We're a target. I lived through a nation-state levied cyber attack against HHS during the pandemic, 18 billion cyber events a second, from 2 million endpoints across 164 countries just focused on HHS. From an infrastructure perspective, we have to commit to post-quantum security may not be the conversation for this environment, but we have to commit to post-quantum security and post-quantum security standards, whether it's at the device level, the diagnostic that's collecting the data, or in the hospital ecosystem itself. But to me, those are the two single most important pieces of infrastructure. And then you focus on retraining the workforce, then you focus on engaging with the population so that you can drive better health outcomes.
Perfect. We've talked about AI all day. You've heard a lot about AI, but I do think it's so important here, and it's so important to the work each of these gentlemen are doing. We're very bullish. We're very future focused at the ATA, like so many in the room, and I don't want to put words in my mouth, but I think the folks right next to me. But of course, we're very cognizant of these divisive fault lines that are going to make it more difficult to move positive public policy, in my estimate, as compared to telehealth, virtual care, and all the momentum coming out of the pandemic. And those fault lines, like I mentioned before, are around clinical decision-making authority, explainability, liability, and of course the potential for workforce displacement. Ricky, how do we ensure AI augments clinicians rather than replaces or sidelines them? And what does this look like in practice? And how do we keep clinicians on side and not opposed to this emerging technology?
First, I would say AI, and I think I'm probably preaching to the choir here, you all know this, but AI is not one monolithic thing. I think when we talk about AI nowadays, most of the time we're referring to generative AI or foundation models like ChatGPT, Gemini, Claude, things like that. But AI has been around in many other forms. For example, in the Oura Ring, we've been using AI for over a decade when the company was founded, because you need these machine learning models to make sense of the sensor data. And that's key. Like, these things just wouldn't work without that type of AI running on this little device to make sense of your heart rate, your respiratory rate, your temperature, your blood oxygen, all these things to turn that signal into something meaningful. And so I think that form of AI is certainly going to be valuable to help provide the right signal, as we talked about before. Generally, physicians are actually pretty forward-thinking. You can probably debate that depending on who your specific physician is. Certainly, so I have asthma. I went to my pulmonologist in, I think it was like late 2023, early 2024, right after ChatGPT had come out, and I asked her, how many residents are using ChatGPT in the hospital today? And she's like, everyone. Like, every single one is using this. And I said, well, are there issues, safety things? Like, how do you protect? Like, what are the incentives? And it was pretty clear that, well, this helps us do our job better. And we still have attendings that provide oversight, but it helps us get to a differential diagnosis faster, things that we can then look up and verify. And so if there's something out there that's going to make your life easier, it's going to save you time or provide better care, we should be using those things. But we need to do it in a way that we go into it eyes wide open. And so whether it's an LLM-based device or whether it's a wearable device, the best way to understand how to use it, whether to use it, how to implement it, is by doing it. None of this works theoretically. You have to actually implement it. You have to test it. You have to conduct pilots. And we talk about wearables all the time. When I talk to physicians that have worn any sort of wearable ring or a watch for a long time, they understand. Like, they've personally experienced the value that comes from it, and they understand when their patients come and show them their app and say, look at my data, how do I interpret this? And then I talk to clinicians who have never worn a device personally, and they don't know because they haven't experienced it. Another thing that's been eye-opening for me recently, just since December, how many of you in the audience, I'm super curious, have built an app in the last month? Okay, good. Wow. There are some hands up. All of your hands should be up. And the reason I'm saying that is because there are tools available today to build an app in an hour. And I'm not talking about like some sort of crude, facsimile of an app. I'm talking about a full iOS app you can run on your phone that can do all sorts of things. I just built a full-on nutrition tracker last weekend that pulls in my data from HealthKit, that lets me track. I can scan a barcode on any thing that I have at home. It'll pull in all the calories, all of these things. These technologies are available, and if you're not using them, you're going to be blind to the potential in your own companies, your business, your work. And so you need to start using it, start experiencing it firsthand to do that. And I think that's true of any industry, whether it's healthcare, finance, government. We have to be using these tools to stay on the cutting edge. And so that's your challenge for this weekend, is build an app, or at least explore how you might do that. Some of you might not know how to get started. Ask your LLM of choice, how do I get started building an app? It'll tell you, and then you can do it. And so that's your challenge.
It's a good point. I have to say this because he's on the panel with us. So I worked with the Navy specifically on implementing technology for autonomy and targeting, and we flew out on a helicopter to the Abraham Lincoln, which I think is in the Gulf, or the Strait of Hormuz right now. And they were using Oura Ring. And so what's the importance of using modern technology, and why were they using Oura Ring? Well, Navy sailors need more sleep. And there's a whole bunch of downstream issues if they don't get enough sleep, from navigating the ship to dealing with enemy combatants.
There was a collision of 2 Navy vessels in 2017, which is why they did it. Because the sailors,
they weren't sleeping.
They weren't sleeping, and they weren't admitting that they were tired.
Yeah, and I was talking to the commander of the Carrier Strike Group, and I asked him what was the biggest change. He said we had to completely change how we were managing every single sailor on the Navy ship. And we're better off for it. But if we didn't pilot it, we would never know the underlying issues that we actually have. And if you ever been on a Navy ship, it's a city. It is a giant city. So I agree with your point, playing with it and understanding that it's fundamentally going to change the way the workforce operates, whether it's in the neonatal group or whether it's in the emergency response function of the hospital. You never know what it's going to bring.
They did also, there was an individual using Strava on an aircraft carrier running laps, geolocating unknowingly
the physical location
of the aircraft
a target.
Carrier. So, yeah, we got to use all this data in an appropriate way, also. But
no GPS on an Oura Ring.
That's true.
Makes it safer for sure.
Right. But, and for whoever wants to take this, and Sean was going to direct it to you, but please, all fantastic, all exciting, all wonderful. Nobody's Pollyanna here, though, I'm sure. We've got concerns about costs. It's still a huge percentage of our GDP in terms of healthcare. Is AI truly going to, cut the cost curve? Talking to the administration repeatedly in recent weeks, their big term right now is deflationary healthcare spend. They're tired of people like me with a government affairs background, and saying, give us more money, pay us more. Is this going to bend the cost curve? Is it going to allow us to be more efficient with our healthcare spending? Or is it just going to be another added complexity that everybody's going to be at the trough trying to get paid more for this?
Yeah, that's a great question. And we could probably talk about that as we have this entire week.
In 2 minutes, by the way.
2 minutes. Listen, there's an incredible opportunity here. I think everybody can feel it, but there's also an incredible responsibility as well. And so I think that baseline education that everybody needs to shepherd this change appropriately, data rights, data privacy, making sure that it's not just one extra layer of technology cost over the top of an already bloated system. I do believe that there is going to have to finally, I'm going to use the word outcome-based models. The reality is we will be able to start to show outcome-based models finally. And I think the data will set us free in these respects. There, specifically in orthopedics, there's some CJR-X extension really starting to put together, if you are able to do a procedure with better outcomes, that procedure will take a higher degree of supplement payment towards it. That's a first step. There is no panacea here. I think if we try to do some massive consortium panacea type movement, it will fail. We have to start to focus in on the data and highlighting the outcomes that are driven through it. But it's an incredible opportunity right now. We just need to shepherd it in a very methodical way. It will not happen as fast as everybody, I'm sure, is hoping, or we're seeing even outside of healthcare.
We had a fantastic dinner, the speakers on stage last night, and just the energy that was in that room, the passion about transforming healthcare. I think, and I'll dare say, and I'm a much smaller, more medium-sized organization than a great storied organization like the Chamber, but I just don't know of another organization like the Chamber that could have pulled together so many great minds and passionate minds on stage. It was an honor for me to talk to these gentlemen with you just now. We could have really just been scratching the surface. We could have kept talking all afternoon, but we got to get you back on track for some more great sessions. Please give a round of applause to the gentleman to my right.
Thanks.
Good afternoon. All right, very nice. How's today's program been? All right, that's what I like to hear. We started strong. We are closing strong. And this morning we opened with an entrepreneur who has really changed the health options for millions of Americans and people around the world with his healthy food products. Today, we are going to conclude with a real insider's look about how technology and healthcare are evolving even faster than we can sometimes imagine, and understanding how this private sector innovation really interacts with the traditional roles of government in the healthcare space. There could be no one better to help us with that conversation than Seema Varma. You probably know Seema from her time as serving as the administrator of CMS during the first Trump administration. I also learned that you were the longest serving CMS administrator.
Yeah, the biggest fool, right?
Well, you know, when you get a good person in a job, you got to keep them there.
I used to say the survivor, longest surviving administrator.
Longest survivor.
Yeah.
We're going to get into what you went through in a minute then. Today, she's the Executive Vice President and General Manager of Oracle Health and Life Sciences. Maybe let's start there. I think Oracle, a pretty household name for, I'm certain, everyone in this room and people listening in. But Oracle Life Sciences, what do you do?
Well, first of all, I'm going to acknowledge that I'm standing between you and a cocktail, so we'll try to make this entertaining. But so I think most people think of Oracle, big technology company, hyperscaler, cloud company. But one of the things that makes Oracle unique is that we do all of those things, but we also run a lot of software applications. So think about ERP and HR and supply chain. Oracle also has a big footprint in industries. So probably about 75–80% cell phone transactions are all Oracle technology, restaurants, hospitality, utilities, and now our most recent is healthcare. So I think during COVID, our founder, Larry Ellison, was just watching all of the healthcare dysfunction at its best, and just said, you know what, I gotta help here. And the thought was using everything that Oracle's learned about technology over 50 years, over different industries, banking, and bring that know-how and hopefully transform healthcare. So that's the vision and the mission.
So if you are successful, will one day before I die, I can stop filling out the photocopied papers over and over again when I go to the doctor? Is that like in our future, or will I be filling out that form?
Well, you got to
like till the end of time?
You got to thank the healthcare industry. They're keeping the fax industry alive, right?
It's important,
so that's super important. We don't want to throw away those fax machines. But yeah, I mean, that's really the heart of what we're really focused on is data. I mean, Oracle's background's a database company and managing data. And if we think about healthcare and a lot of the dysfunction that we all experience with healthcare, I think you can actually trace it back to a data problem. The data not being in the right place at the right time, you having to fill out the same form over and over, even in the same building sometimes.
But it's not just the data about my current contact information and family history. The data that we now have in real time or virtual real time about people's health performances is at an unprecedented level. Are you all helping physicians and providers manage that data?
Yeah, so if we think about data, you're talking about your health record, right? Being able to have all of your data in one place. And that's really central because especially right now, we're hearing a lot of conversation about AI. And one of the things I like to do is draw the connection between interoperability or having all of your data, your record, and AI. AI is only as good as the data that it has underneath it. So if we continue where we've been in the past, which is that we don't have complete data, and I bet many of you have your data and your health record in several different places, right? You probably have 4 or 5 portals on your phone. And there's different pieces all over. We've got to bring all of that together, and if we want to take advantage of what AI can do, that interoperability is foundational.
And so talk to us about what that will mean from a patient perspective. What can a patient expect to be better from that experience, and from a provider perspective? What gets better because of that?
Sure. Well, let me ask the audience a question so nobody falls asleep. How many of you have used ChatGPT to ask a question about your health? Right. And how many of you have maybe taken a lab result or a test result and put that in ChatGPT? Right. So I think that's where the market is going. Unfortunately, if we think about the conclusions that AI is able to give us, even the AI does not have access to all of our health data. So if we think about what this looks like for patients, it's going to be more of this, where I think patients are more empowered to understand their health better. They're going to be able to ask questions. And I think it's great for the healthcare system as well, because another question for the audience, how many of you have had trouble making a doctor's appointment? It's taken a long time to be able to get in. And what we're seeing is that we've got this aging population. It's a good thing people are living longer, but our health system's not prepared for it. We don't have as many doctors and nurses as we need. And so what I hope some of the things in terms of the benefit for patients is that there's less waiting. You can hopefully do a lot of questions and answers with AI. Maybe AI can help us with what I call low acuity care, answering questions, explaining routine things, and then that actually frees up the healthcare system to focus on the more complex situations. So I hope for patients we're more empowered, we have data. When we're looking for doctors, we're able to compare them on the basis of cost and quality, and that we have more information at our fingertips. I think it's a game changer, though, for the providers. They're going to have to think about, now patients are going to come in, and we already hear doctors talk about pharma and the advertising that goes on, and their patients come in and say, oh, I saw this ad. Well, now their patients are talking to ChatGPT. And so doctors are going to have to figure out, how do I practice alongside ChatGPT? And it's possible that in some places, does AI replace some of that lower acuity care, some of the primary care? But I do think it's going to bring a lot of efficiency. If we think about some of the tools that we're bringing out for providers today, one very common, popular one is ambient listening tools, or it's listening to the doctor-patient interaction, it puts a summary together. And even that has just created a lot of capacity for providers. And for the first time, they're not sitting there staring at their computers and typing, they're actually looking face-to-face with the patient. AI can bring them a summary of their patient's history. So, not only are you filling out forms, but how many times are we saying the same story over and over to our providers? Now the AI can go, comb through thousands of pages of data and actually bring it. A lot of the costs that we have in healthcare, a lot of administrative work, AI can do a lot of that, coding, billing. So to me, when I think about AI, it is an absolute game changer for the entire industry, top to bottom, for patients, doctors, and people working behind the scenes.
Is our current system, including how we pay for care, ready for this type of technological step leap?
ready or not, here it comes. It's here and it's being adopted every day. Look, I think that we've had lots of conversations about payment systems moving to more value-based care and moving away from fee-for-service. I think actually AI can help us get there. If we think about value-based care and the challenges that providers have faced in adopting it, right? A lot of it is because they've got 10 contracts, one patient's in this program, another one's in that one, there's these quality metrics here. Again, AI can make it very simple. It's this patient, here's the preventative services that they've missed. So I think it can actually accelerate some of the long-standing problems that we've had in healthcare. So if we want to move to more value-based care, moving away from fee-for-service, the technology should be able to support those efforts. Whereas I think in the past, we haven't had the right tools to be able to adopt to a different system.
Yeah, so it actually may help with the transition that's frankly been really hard to make, right? It's
super hard. It's super hard. Imagine,
our system was not structured for
no.
these type of payment reforms.
Right, and if you think about it, providers are supposed to be preventing their patient from getting sick. Well, you got to have all the data, you have to have all the information, and when they're trying to see a patient in 15 minutes, it's hard for them to think about, it's more, let me just deal with the problem at hand. So I think AI has a very strong possibility of advancing a lot of the value-based care to make it easy for the provider to understand what they need to do with the patient, what are the services that they're missing. The AI can do a lot of the analytical work to maybe pick out those signals of, hey, this patient is about to have a heart attack. It's taking in a lot of that information. It can start to get people connected to clinical trials, right? So when a patient comes in, we can say, they're eligible for these trials. So I think the AI is also going to have a massive impact on innovation and the speed of bringing out new cures, new discoveries, because we are helping that end of it too. So over the next 5 years, I think we're just going to see a massive difference across the board.
So if this is actually a way to help us reform our payment models, and therefore the payment models isn't necessarily the biggest barrier to fully realizing what technology can do, what would you say is the biggest barrier to kind of fully realizing the efficiency gains, the health improvements from this technology?
One of my concerns about AI, and number one is the interoperability. It won't work well if you don't have the data. So we've got to solve that problem. We've been grappling it for a long time. I think there's also a big risk for healthcare that we could make big investments in AI and that it won't return the types of savings and it won't solve some of the issues. And that's because I think it's complicated when you think about AI. It's not easy to just go out there and buy different types of solutions. And there's no real guide or a map on how to make some of those purchasing decisions. And so there's also the possibility that it could increase cost and not deliver the transformation that we think and we hope that it'll do. If you think about the electronic health records, right? Our country spent $36 billion on that. And has it delivered? Did it deliver? I mean, I would argue in some ways it made us more inefficient.
Yeah.
So there's a danger in that.
I love that point because everyone wants to skip, in technology, you're well familiar with the J curve, right? And so you introduce a new technology and initially it actually makes you a little less efficient because you're figuring out what technology, what platform, how to use it, you're adjusting systems. On the back end, you get the efficiency gains. It feels like we're talking about this technology as if we get to skip that lower part of the J. Are you concerned that as we go down this road, does it begin to look like electronic health records and everyone goes, there was all this great promise, but I guess not. Let's just go on to something else, or let's go back to the way we are doing it. Is that a fear we should have? Is that a fear you have?
I fear about the cost. I think that the type of transformation that it's going to deliver, that it's already delivered. So we think about the ambient listening tools. Doctors have loved it. They've rapidly adopted it. We hear about them using tools like Open Evidence that they can ask questions of the AI. They can search that medical literature. So you're seeing actually high adoption because the good thing with AI is a lot of these tools are very easy to use. I think the question, and I'm sure for a lot of the employers in the room, is what is it going to mean to the bottom line?
Right.
And we have to be careful that we demand that the technology delivers an ROI. So one of the things that I sort of say to whether it's hospital systems or really anybody, even employer groups, is make sure when you're purchasing this that the AI is going to deliver it's going to deliver value, and that should be something we think about at the outset.
What, when you said about, and you're dreaming about what this technology can do, or maybe even not even the technology, just the future structure of healthcare, what is the most amazing thing that will be different 10 years from now, from today, that maybe we haven't thought about?
So I think a few things. I would say number one, the experience that we have, the ability, I mean, I feel like when you go into the doctor's, by the time you go to the doctor's office, you're sick. I think AI will actually give us the ability to think about and to deliver that era of personalized medicine where we can say, this is how to stay healthy instead of worrying about when we get sick. We know that we have uneven quality, right? You can go to a big, large academic center and your care may look very different if you're in a rural area. With AI, I think we even that out. We're able to say to the providers, no matter where they are, it doesn't matter if you're at the Mayo Clinic, you can bring some of the Mayo Clinic thinking to a very, very tiny provider almost all over the world, because the AI is going to give them that. They're going to say, here's the clinical trials. This is how other patients look, and this is how they were treated, and these were the outcomes. So you're able to really bring that to the bedside, and so I feel like quality of care is better. I think we're going to see a big acceleration on cures and treatments. And of course, that will also come with a price tag as well. But it could be that we are now delivering drugs and treatments that are able to prevent disease. We're providing more cures as well.
Into rural communities, maybe even into patients' homes, right? The concept that so many things where you have to get up and trudge to the doctor's office.
Right.
Some combination of telehealth, AI, technology will allow.
Right, and more signal detection, right? Helping people, more preventative care. And I think even when somebody is very sick, you think about somebody with different cancer care, being able to identify which treatments are going to work well for that particular person. So a new era of medicine, and I think really leveling the quality to me is a big one. The other thing I would say is if we think about access, like right now I kind of wonder whether we're actually seeing higher healthcare costs over the last few years. And there's a lot of theories on that. I actually wonder whether one of the problems is we can't get in. And by the time you get in, things have progressed with diseases. And so I wonder whether will bring a lot of efficiency to providers, so therefore they can spend more time with patients, people are able to get in quicker, faster, and we can focus more on prevention and lifestyle and the things that are going to keep us healthy.
And I assume from what you just said that you think that will contribute to dealing with some of the chronic disease elements that have really been a struggle for us as a society.
Right. Well, even, I'm excited about, that there's a cost issue, but if you think about some of the drugs that have come to the market in the last few years, the GLPs, that's kind of a game changer for a lot of chronic disease. We know that it's impacting not just obesity, but heart disease and diabetes, so there's a lot of wins. And it took us how long to develop that drug? We think about the new drugs for Alzheimer's. With AI, the level of discovery is going to go much faster and quicker. We just heard about, yesterday, the FDA announced a way of doing clinical trials quicker and faster, doing that right inside the electronic health record. So you can even see the regulatory shifts as well to kind of speeding things up.
So you touched on this a little bit, but I'm hoping you can go a little deeper. There is, for all these fabulous things that we're talking about, there is concern about cost. Unstable, unsustainable fiscal situation for the federal government, costs for employers continue to grow. That comes at the expense of not just the employer, but wage increases for employees. There is kind of this sense of how much more can we kind of keep investing. What is your best advice for bill payers, whether that be employers or the federal government, about how to think about this era of change and maximize it not just for patient health and sustainability and for our providers, but making sure that we're maximizing the dollars that are being spent?
Right, so look, this has always been the conundrum. It costs more, and that if you think about the last 50 years of healthcare legislation and policy, right? We've passed all these bills, we've expanded programs, we've delivered more and more and more, and yet the price has gone up and up and up. And so we've not really cracked that nut. I thought it was very interesting, just the recent legislation with the BBA, was how this was the first time I felt like there was a bit of a pushback to say, no, we don't want to increase things. In fact, we're going to push on Medicaid a little bit. It was, to me, that's a signal to the healthcare system that, hey, we're at the end here, right? There is no more, we're not going to invest anymore, and the healthcare system has to become more efficient. I think that's going to drive them to technology. There is a big danger if you don't buy the technology, you don't pick the right partner, you could be spending more. I will say this though, as I go around the world in my new job with Oracle, I'm traveling to different places, and before I used to get really paranoid in my first year, and I was like, oh, I'm going to the UK, and I need a primer on this, and I'm going to Germany, and you know what? I've been able to go into every single meeting and be just fine, because guess what? The problems are all the same. They're not different. It doesn't seem to matter whether it's single payer, whether it's semi-private, but it is literally exactly the same. Workforce, cost, access, lack of preventative care. Everybody's saying the same thing. We want to digitize, we want to invest in AI. So I don't think the problem, I guess my takeaway is that the problem isn't whether it's employer-sponsored care, whether the government's paying for it. The system in and of itself is inefficient. It is highly dependent on humans. And if we look at healthcare costs, 50 to 60% of that is humans. AI can do a lot of that work, so maybe humans don't need to do all of it. So there is a possibility as well, but I think alongside that has to have some reforms that come along. Otherwise, you have the potential of just spending a ton of money on technology and you're still paying more and more.
Yeah, I know we're almost out of time, but I can't help but ask, given all the similarities that you just described, is a difference for America, is a competitive advantage difference, the level of innovation that we have, and whether we're talking about pharmaceuticals or technology or just even ways of providing care? Is that what's going to lead us and maybe help the rest of the world?
I do think that we have that advantage. The one thing I think people may not necessarily appreciate is the wide access to drugs and medications. I was just in the UK yesterday. That's why I'm a little sleepy. But they were talking about clinical trials, and they wanted to bring more clinical trials to the UK. But the standard of care is not the same standard of care. So if they think about testing new drugs, they don't actually want to do it in the UK because their population is actually not even exposed to, they don't have access to the type of medication. You're trying to test something out. Well, they haven't even tried the other competitor drug. So I think that that is something that I would say is a big advantage. We complain about timing and access to care. I think it's worse in other countries as well. But the big thing that we have is we do have that breadth of innovation. But at the same time, we have those uneven outcomes. And we are not a healthy population. For the amount of money that we are investing and putting into this, you think we would have a healthier population.
Well, as we've talked about today, all that creates opportunity, right?
Right,
and,
right.
The private sector on its own, the private sector working with government really can take advantage of these innovations to hopefully address some of those.
So my advice to the employers is don't wait for the government. You got to do
lead.
it yourself. It's not going to happen there from my time in government. So
that is well, interestingly, for those of you who were with us the first session, we heard something similar from the Chobani CEO. He didn't start with government. He started with what markets and employers could do, and that's a great way to end it as we close out our program. Please join me in a warm round of applause for Seema Verma for coming here after flying internationally to be with us. You got this one, Seema.
Thank you so much to Seema and Neil. What a great way to close us out. And thank you all for such a great day. Thank you for being with us. And now I have the most exciting news of all, which is that the cocktail reception is open right next door where you guys had your lunch today. Please join us in toasting to a wonderful day and to the start of something great. I will just remind you that the work that we started today is just that. It's just getting started. So we encourage you to work with us on this great initiative. And if you have any questions, feel free to pull any of us aside, but let's toast to the future of American Health Advantage, and cheers.